Now let's start our session. Let's begin with our first system, endocrine physiology. Endocrine physiology. See, what I will be doing in this session, I will be going to the 6 systems. Okay, 6 systems I will be doing. Endocrine, renal, GIT, cardiovascular, respiratory and central nervous system. These are the 6 systems that I will be doing. So in the 6 systems, I will be mainly concentrating on those important high yielding topics, okay, which you need to know for your exam. See, in endocrine physiology, okay, definitely you will be getting somewhere around 3 to 4 marks you will be getting. So let's start with one by one hormone. Okay, one by one hormone. First important hormone that you have to know for your exam is growth hormone. Growth hormone. See, regarding growth hormone, what you need to have in your mind. Okay, important points need to be you need to have in your mind regarding growth hormone. So when the growth hormone levels are elevated, okay, when your growth hormone levels are elevated and when the growth hormone levels are decreased, in which conditions growth hormone level increases and which conditions growth hormone level decreases. Remember, growth hormone levels are elevated during fasting. Okay, so fasting increases the growth hormone. Next, exercise. Exercise, trauma, stress, okay, after eating protein meals, okay, these are the conditions: fasting, exercise, trauma, stress, protein meals and during sleep, sir. Which sleep? NREM sleep, that too stage 3 and 4. Stage 3 and 4 of NREM sleep is called as a deep sleep, okay, deep sleep. So during these stages, the growth hormone levels are elevated. Fasting, exercise, trauma, stress, protein meals, NREM sleep and even hormones like glucagon, okay, hormones like glucagon, okay. So these are the conditions in which the growth hormone levels are elevated. So first of all, tell me, growth hormone, is it a peptide hormone? It's a steroid hormone. It's a peptide hormone and it's an anabolic hormone. It's not a catabolic hormone, it's an anabolic hormone. Okay, so these are the conditions in which growth hormone is elevated. And what are the conditions in which the growth hormone is going to be decreased? Which conditions decreases the growth hormone? The conditions which decreases the growth hormone, let me write here, the conditions which are decreasing the growth hormone are hyperglycemic conditions, okay, conditions wherever there is hyperglycemia. Because see, all these conditions, they are hypoglycemic conditions. Fasting, glucagon, exercise, trauma, stress, all these conditions, they are the ones which are going to cause the hypoglycemic conditions. So the hypoglycemic conditions are going to increase the growth hormone and hyperglycemic conditions are going to decrease the growth hormone. Okay, one, hyperglycemic conditions decreases the growth hormone. Second is somatostatins. Somatostatin, which is called as the growth hormone inhibitory hormone, decreases the growth hormone. Next, and certain drugs like octreotide, which are the somatostatin analogs, they will decrease the growth hormone. And one more thing which is called as the somatomedian C, also called as insulin like growth factor 1. See, this somatomedian C or insulin like growth factor 1, what is the important point? The important point about the somatomedian C or insulin like growth factor 1, it decreases the growth hormone production. What actually it does, it gives the negative feedback. It gives, it's a somatomedian C, important, it's a somatomedian C, it gives negative feedback. It gives the negative feedback for the release of the growth hormone. So who decreases the growth hormone? Insulin like growth factor, it gives the negative feedback, so it decreases the growth hormone levels. And question which was asked is, this somatomedian C, it was a PYQ. This somatomedian C, from where it is getting produced? Somatomedian C, it is produced from liver. Okay, somatomedian C, it produced from the liver. Right? So the conditions in which the growth hormone is elevated and the conditions which are going to decrease the growth hormone. Very, very important. Sleep. NREM sleep. NREM sleep is going to increase the growth hormone, but REM sleep is going to decrease the growth hormone levels. REM decreases the growth hormone levels. Done? Now, after this, what else you should know regarding the growth hormone? What are the functions of the growth hormone, guys? For growth hormone, I have told you it's an anabolic hormone. Anabolic. Okay? So, what are the functions of this growth hormone? As it's an anabolic hormone, see, directly growth hormone, what it is going to cause? It is going to cause protein synthesis. Second function, is lipolysis. Okay, lipolysis. And the third function is it's going to cause the glycogenolysis in the liver, so it will increase the blood glucose levels. So it's going to cause glycogenolysis. It causes glycogenolysis, true. So growth hormone is going to cause the glycogenolysis, so it increases the glucose levels in the blood. It is a hyperglycemic hormone. Growth hormone increases the blood glucose levels, true. It's a hyperglycemic hormone. Okay, done. Growth hormone, if it is elevated abnormally, if it is too much elevated, too much elevation of the growth hormone is going to cause a disease called as, say, too much elevation of the growth hormone in childhood. In childhood, it is going to cause a disease called as gigantism. Okay, it's causing gigantism. And in adults, too much elevation of the growth hormone is going to cause which disease? In adults, it is going A for A. In adults, it's going to cause a disease called as acromegaly. Okay, it's going to cause a disease called as acromegaly. In childhood, it's going to cause a disease called as gigantism. Next, if there is a deficiency of the growth hormone, if the growth hormone is a deficiency, it is going to cause a disease from childhood. If the person is having deficiency of the growth hormone, it is going to cause a disease called as dwarfism. Okay, it's going to cause which disease? Dwarfism. Okay. Now, what else they will ask you is regarding growth hormone. There is a condition. Okay, there is a condition in which the growth hormone levels are elevated. Okay, growth hormone levels are elevated and still the person is a dwarf. What is that dwarfism called as? There is a condition in which the growth hormone levels are elevated. There is more growth hormone, but still the person is a dwarf. What is that condition called as? That is called as Laurent dwarfism. Laurent dwarfism. Okay, so why in this person there is a dwarfism? Why there is dwarfism? Even though growth hormone is there. See, even though growth hormone is there, but why the patient is still dwarf is because the growth hormone receptors are mutated. Because the receptor mutation. Okay, growth hormone receptor mutation. The growth hormone receptor, which receptor? Growth hormone receptor, it is a mutated. So how to identify the Laurent dwarfism? See, in Laurent dwarfism, growth hormone levels are elevated, but somatomedian C levels, the somatomedian C, which gives the negative feedback. Okay, the one which is trying to decrease the growth hormone, the somatomedian C, which is coming from the liver, the somatomedian C levels are decreased. The somatomedian C levels are decreased, but the growth hormone levels are elevated. Such dwarfism is called as the Laurent dwarfism. Done. Now, these are the important points which I want you to know regarding the growth hormone. Growth hormone, anabolic hormone. Growth hormone, peptide hormone. Growth hormone causes protein synthesis, lipolysis and glycogenolysis. Growth hormone, in which conditions it is elevated, in which conditions it is elevated, and in which conditions it is decreased. Okay, and growth hormone abnormalities. Excess of growth hormone is going to cause gigantism, acromegaly. The deficiency of growth hormone is going to cause a disease called as dwarfism. Bas. Now, after growth hormone, now let me discuss about thyroid hormones. Okay, thyroid hormone. Now, what are the important points about the thyroid hormones? You know, T3, T4, these are the two thyroid hormones. Okay, see, thyroid hormone, it's a peptide hormone. Okay, it's a peptide hormone, no doubt. But it behaves like steroid. Okay, it's behaving like what? It behaves like a steroid. Even though it's a peptide hormone, it behaves like steroid. Why I'm saying this? What is that, sir? What is that behavior? Why it is behaving like a steroid? Why I'm saying that word? Is because it crosses the cell membrane. Okay, these thyroid hormones crosses cell membranes. So which means it is lipid soluble. So now they will ask in your exam, thyroid hormones, are they lipid soluble or water soluble? They are crossing the cell membranes. Yes, they cross the cell membranes. Usually, which hormones cross the cell membranes? Is the steroid hormones. It is the steroid hormones like progesterone, testosterone, estrogen, okay, cortisol. It's the steroid hormones which crosses the cell membrane and enter into the cell. So, even though this thyroid hormone, even though it's a peptide hormone, it behaves like steroid. Okay, it crosses the cell membrane. It is lipid soluble. Usually lipid soluble hormones, steroid hormones, they are not stored. Usually lipid soluble hormones are not stored. But the thyroid hormone is the only lipid soluble hormone. It's the only lipid soluble hormone which is stored. Okay, it is stored. Okay, it is stored in colloid. It is stored in colloid for 2 to 3 months. Okay, yes, thyroid hormone, it is stored, it behaves like steroid. Now, what are the important points that you should know in the topic of thyroid hormones? Thyroid hormones is, they are catabolic hormones, predominantly catabolic hormones. Okay, so in the production of the thyroid hormones, there is a very important enzyme required. What is the important enzyme required? Thyroid peroxidase. There is an enzyme called as thyroid peroxidase. In the production of this thyroid hormones, the important enzyme that is required is the thyroid peroxidase. It does 3 reactions, sir. It is involved in 3 reactions. What are they? Oxidation, organification, and coupling reaction. So because of these 3 reactions, once these 3 reactions are completed, like oxidation, organification, coupling reaction, now they are going to help in the production of thyroid hormones. Okay, with the help of this oxidation, organification, and coupling reaction, who is produced? Thyroid hormones are produced. So in the production of thyroid hormones, what is that enzyme that is required? Thyroid peroxidase. So what are the drugs which will inhibit the thyroid peroxidase? So the drugs which are inhibiting the thyroid peroxidase, they are going to decrease the T3 T4 production. So they can be used as anti-thyroid drugs. So what are the drugs inhibiting the thyroid peroxidase? The drugs which are inhibiting the thyroid peroxidase are propyl thiouracil, carbimazole, and methimazole. Okay, carbimazole, methimazole. Propyl thiouracil, carbimazole, methimazole, all are TPO inhibitors, thyroid peroxidase inhibitors. They will all decreases the production of T3 T4. In that, one important MCQ for your exam is propyl thiouracil. It is the drug of choice for hyperthyroidism. Okay, when in the first trimester. Okay, it's a drug of choice for the hyperthyroidism in the first trimester of the pregnancy. For second and third trimester, it's the carbimazole and methimazole, they are the drug of choice. Okay, the drug of choice for second and third trimester can be carbimazole or methimazole, but for the first trimester, the drug of choice for the hyperthyroidism is a propyl thiouracil. Okay, next, what else you should know regarding the thyroid hormones is, see, thyroid hormones need to be converted. The main important thyroid hormone, the one who is in the most quantity, the one who is in the in the big amount quantity wise, it's a T4. The T4 need to be converted into T3. So T3 is the most potent. T3 is the most potent. T4 is less potent. T3 is most potent. So who will convert? Who will help in the conversion of T4 into T3? See, that is with the help of deiodinases. Okay, there are hormones called as deiodinases. These deiodinases, they will help in the conversion of T4 into T3. What are the examples of the deiodinases, sir? There are 3 types of deiodinases: D1, D2, D3. Out of all these 3, it's a D1 which is the major deiodinase. The D1 deiodinase, it's a D1 deiodinase which helps in the conversion of T4 into T3. Okay, this T3 deiodinase is there. No, this is a D3. Do you know what this deiodinase will do? D3, mainly D3. It converts T4 into RT3. Okay, RT3, reverse T3. So which deiodinase? It's a D3 deiodinase. Which converts T4 not into T3 but into a RT3 molecule. Okay, that's one important point which I want you to know. Out of all these 3 deiodinases, D1, D2, D3 deiodinase, who is the most important? D1 is the most important, and the major deiodinase is a D1. Okay, mainly remember D1 for your exams. Now, in your blood, let's say, or in your plasma, both T4 is present as well as T3 is present. T4 and T3, they are not simply floating in the plasma. They are bound with the plasma proteins. Okay, they are bound with the plasma proteins. So T4 mainly bonds with, okay, mainly it binds with, T4 mainly binds with which plasma protein? Thyroid binding globulins, MCQ. So T4 mainly binds with which plasma protein? Thyroid binding globulins. And T3 mainly binds with which plasma protein? Albumins. Okay, T3 mainly binds with albumin, T4 mainly binds with T3 mainly binds with albumin and T4 mainly binds with thyroid binding globulins. This is one more difference. Okay. Next, what else you should know regarding thyroid hormone is, sir, the functions of the thyroid hormones. Okay, functions. Thyroid hormones, they help in the development of central nervous system development as well as the skeletal development. Skeletal development. So, CNS as well as the bone development. Okay, thyroid hormone helps in the development of central nervous system, that's the brain, and the skeletal development. Brain development ke liye, for brain development as well as the skeletal development, what do you require? Thyroid hormones are very, very important. Thyroid hormones and proteins. See, I have told you thyroid hormones are the catabolic hormones. Catabolic hormones. As they are catabolic hormones, they are going to cause proteolysis. Next, lipolysis. Okay, and glycogenolysis. All lysis. Okay, catabolic hormone, predominantly catabolic hormone, so lysis, proteolysis. So because of the proteolysis, lipolysis and glycogenolysis, it's called as a catabolic hormone. So glycogenolysis, what it's going to do, it's going to increase the blood glucose levels. Even growth hormone increases the blood glucose levels, and even the thyroid hormones also increases the blood glucose levels. So thyroid hormone is also a hyperglycemic hormone. Okay, done. Next, what else the thyroid hormones are going to do? See, the thyroid hormones are going to increase your basal metabolic rate. They will ask you, thyroid hormones are going to increase your basal metabolic rate. How they are going to increase the basal metabolic rate? How, sir? Thyroid hormones, they are increasing our energy expenditure. They are increasing our metabolism. More and more calories are getting used by the body. They are increasing our metabolism, more basal metabolic rate. Okay, how? By increasing the number of sodium, potassium pumps. Okay, so how thyroid hormones increases the basal metabolic rate? By increasing the number of sodium potassium pumps. So thyroid hormones increases the number of sodium potassium pumps on our cells. So more the number of sodium potassium pumps, more ATP breakdown. More ATP breakdown means more calories are being utilized by the body. So more basal metabolic rate. So thyroid hormones increase our metabolism by increasing the number of sodium potassium pumps. Okay. Next point is thyroid hormones increases our body temperature. Okay, so that's why thyroid hormones are also called as thermogenic hormones. Thyroid hormones are called as what? Thermogenic hormones. Next, what else you have to know? See, I have told you thyroid hormones, they are having, they are what? They are lipid soluble hormones. Thyroid hormones are the lipid soluble hormones, which means they will enter into the cell. Look at here, guys, let's say this is our T4. T4 will be converted into T3. After conversion into T3, what this T3 will do? See, T3, it is going to enter into the cell. Okay, see T3, what it will do? T3 is going to enter into our cell. Okay, let me show you here. See, this T3 is going to cross the cell membrane, it enters into the cell. Now, do you know what this T3 will do? This T3 is going to enter into the nucleus. See, let's say this is the nucleus of the cell. So, T3, first, it will enter into the nucleus. After entering into the nucleus, T3 binds with its receptor. So, where is the receptor of thyroid hormone? The thyroid hormones, they have intranuclear receptors, not the intracytoplasmic receptor, it's having the intranuclear receptors. So, here, I want you to highlight this very, very important MCQ. Okay, so first, let me write here. All steroids, steroid hormones, they are the lipid, they are the cholesterol derived hormones. Steroid hormones means a cholesterol derived hormone. If a hormone is derived out of cholesterol, then it is called as a steroid. All steroids have intracytoplasmic. All steroids have intracytoplasmic receptors. All steroids have intracytoplasmic receptors except estrogen. Except this hormone estrogen. Estrogen is also steroid. Except estrogen, all other hormones have intracytoplasmic receptor. Except estrogen. Then, which hormones have intranuclear receptors? See, now I am giving the heading intranuclear receptors. Which hormones has the intranuclear receptors? The mnemonic which I formed for myself is sex with T3, T4, thyroid hormones. Sex with T3T4. Sex hormones like estrogen. See, sex may, which letter is there? Sex may, E is there. E for estrogens. Estrogens. Okay. Estrogens, vitamin A and vitamin D. Vitamin A and vitamin D. There is a controversy over this, but anyway, vitamin A, vitamin D, both vitamin A, vitamin D, as well as thyroid hormones T3T4. So sex hormones including estrogen. Sex hormones, estrogen, not including, I should say only sex hormone. It's a estrogen because other androgens, dihydroepiandrosterone, others, progesterone, they have the intracytoplasmic receptor. Which sex hormone? It's the estrogens, vitamin A, vitamin D, and thyroid hormones. They all have the nucleus within the nucleus, so they are all having intranuclear receptors. Done. Now, apart from this, what else you should know regarding the thyroid hormone? Let me tell you. See, regarding thyroid hormone, the histology is important. Okay, histology is important. They will give you the histology of the thyroid gland. They will give you the histology of thyroid gland. In the thyroid gland, what you can appreciate here is the colloid. Colloid. There is a space. There is a pinkish colored space will be there. Okay, let me show you in the pink color itself. So there will be a space. These are called as the colloids. See, within the colloid, okay, what will be there? T3T4 hormone is stored. Within the colloid, T3T4 hormone is stored. See, these colloids, they are surrounded by cells. The colloid is surrounded by the cells. So these cells which I am showing here, these are called as the follicular cells. Okay, these cells which I am showing here, what are these cells called as? These are called as the follicular cells. Follicular cells. So how to identify a follicular cell? They will just give this arrow. They will just show an arrow. They will keep an arrow and they will ask, what are these cells? If a cell is having colloid, if the cells are surrounded, okay, if the cells are surrounding the colloid, then those cells are follicular cells. Follicular cells. These follicular cells are the ones who produces the T3T4. And not only that, there are also parafollicular cells present. Okay, there are also some parafollicular cells present. These parafollicular cells, they do not have any colloid. The parafollicular cells do not have any colloid. So these parafollicular cells. Parafollicular cells, they do not have any colloid. What is the function of the parafollicular cells then? The parafollicular cells are the ones which are going to produce a hormone called as calcitonin. Okay, they are going to produce a hormone called as calcitonin. Now this calcitonin, इसका function क्या है sir? What is the function of the calcitonin? Calcitonin decreases your calcium levels. So here itself I want you to know, sir, if calcitonin, if it is decreasing your calcium levels, then who increases your calcium levels in your blood? Who increases the calcium levels? It's a parathyroid hormone. So these two hormones are antagonistic hormones. So calcitonin decreases the blood calcium levels. Your parathyroid hormone increases the blood calcium levels. Very, very important. So these are the antagonistic hormones. Okay. Now apart from this, what else that you should know? Now I am taking one follicular cell. Okay, I am taking one follicular cell. Okay. Let's say here is your blood. Here is your blood vessel, and here is a follicular cell. Okay, on the other side I am showing a colloid. Let's say here is the side of the colloid. This is the side of colloid. Okay. Now here you are having iodides. So for the production of T3T4, here in the colloid, you need to get the iodides, right? Iodides are very important components. They are the raw materials in the production of thyroid hormones. So how you can get this iodide? So with the help of a transporter, sir. There is a transporter. Okay. So there is a transporter through which these iodides are taken into the cell first. Okay, you need to first get the iodides. Later, by using that iodide, you can manufacture the T3T4. You can form the T3T4. So, what is the name of this transporter which is present on the follicular cells? The name of this transporter is called as sodium iodide symporter. Okay, this is the question which was asked in the exam already. It was already asked. So, sodium iodide symporters are present on which cells? They are present on follicular cells. But the question is, they are not only present on the follicular cells. But they are also present in other areas like salivary glands. Okay, placenta. Okay, they are present in salivary glands, placenta. They are present in ciliary body of eye. Okay, they are present in lacrimal glands. Okay, So all these areas, so the sodium iodide importer is not only present in the follicular cells, it is also present in other areas which I want you to know, that's the salivary glands as well as the salivary glands, placenta, ciliary body, lacrimal glands, even in other areas these sodium iodide importers are present. Okay, iodine came into the cell. Now this iodine for the production of T34, where it should go? The iodine have to go into the colloid. Okay, you need to send the iodine into the colloid for the production of T34 in the manufacturing of T34. So what is this transporter which is helping in the movement of iodide into the colloid? This transporter is called as a pendrin transporter. If this transporter if it is mutated, that's the question. If that pendrin transporter is mutated, it is going to cause a syndrome called as a pendred syndrome. Okay, so pendrin mutation, if the transporter is mutated, it is going to cause a disease called as a pendred syndrome. In this pendred syndrome, the person cannot make T34. So there will be congenital hypothyroidism with sensory neural hearing loss. So these are some important points about the thyroid hormones. Okay, at least these are the important points which I want you to know regarding the thyroid hormones. With this, the thyroid topic will be completed. See, what I am telling you is, see, there will be definitely, without any doubt, one question will be coming on the thyroid hormones. Without a doubt, a question will be coming on the thyroid hormones. So what else you should know? From your pathology? Okay, what else you should know from your pathology is know what is the difference between from patho. You have to concentrate on this. Concentrate from patho. Okay, so difference between primary hyper versus secondary. So primary hyperthyroidism versus secondary hyperthyroidism. Okay, this is what you need to concentrate. So differentiate, what are the differences between the primary, how to differentiate a primary hyperthyroidism or secondary hyperthyroidism. In the same way, differentiate between primary hypothyroidism versus secondary hypothyroidism. Okay, so how they are differentiated, what are the causes of primary hyperthyroidism? For example, like Graves is an example of primary hyperthyroidism. Okay, what is an example of a secondary hyperthyroidism? What is an example of a primary hypothyroidism? What is an example of secondary hypothyroidism? How the laboratory values are going to be changed? So concentrate this area from your patho. Apart from this, what else you have to concentrate? One thing I forgot, actually let me tell you now. See, iodides are required. See, iodides are required for the production of T34. This is what I have told you. Iodides are required for the production of T34. But when you increase, when you give lots and lots of iodine, okay, that is excessive iodine intake. Let me write here, note. Excessive iodine intake. So do you think more T34 will be produced? Whenever you take more amount of iodine, suddenly you are taking accidentally because of some reason, you are taking high amounts of iodine. Do you think the person is going to produce more T34? There will be hyperthyroidism? No. So remember, whenever you take high amounts of iodine, that inhibits which step? Organification step will be inhibited. So intake of high amounts of iodides is going to inhibit which process? Organification process. I have told you, in the production of T34, how many steps are required? In the production of T34, oxidation, organification, coupling reaction. Whenever you take high amounts of iodide, the organification process will be inhibited and the thyroid hormone production will be decreased. So yes, this step is called as excessive iodine intake inhibits the organification. So what happened to T34 production? The T34 production is going to decrease. This effect is called as, okay, Wolff-Chaikoff effect. Okay, Wolff-Chaikoff effect. So from your pathology, I highly recommend you to know what is the George-Besidov effect, thyrotoxicosis factitia, what is the thyroid storm. So these are the important topics that you have to concentrate from your patho. What is George-Besidov effect? What is the thyrotoxicosis factitia? What is the thyroid storm? What is the drug of choice for thyroid storm? So that you concentrate from your patho. This will be enough for your physio. This will be enough for your physiology, sir. Now, after thyroid hormones, now let me discuss about insulin. Okay, insulin. Sir, I can't take up all your questions. I know you're commenting. I can't take up all the questions because taking up all these questions, interacting with you. Yes, interacting with you will be good. It will be good. But I can't take up all the questions because if I am interacting with you, we can't have I can't complete the whole thing in a little time. See, right now time is money, time is God, time is everything right now. Okay, this 50 days is very, very important for you. So whatever I have to complete in time. So in a short time, so that this video is going to be very super high yielding. In short time, maximum will be covered. Okay, so insulin. Let's take insulin. Let's talk about insulin. Insulin is a peptide hormone. Okay, it's an anabolic hormone. It's an anabolic hormone. Insulin is a peptide hormone. Insulin is an anabolic hormone. Okay, done. See, insulin, where it is produced from? Insulin is produced from beta cells. Okay, insulin is produced from which cells? Beta cells of pancreas. Insulin is produced from the beta cells of the pancreas. Okay. See, along with insulin, these beta cells also produce two more substances. The beta cells of the pancreas, they produce insulin without any doubt. Along with insulin, it produces two more substances called as amylin as well as C-peptide. The important point about the C-peptide is, say if one molecule of insulin is produced, one molecule of along with one molecule of insulin, one molecule of C-peptide will be produced. So can I say something like this? C-peptide is produced in equal concentration. C-peptide is released in equimolar concentration along with insulin. So the amount of insulin levels and the amount of C-peptide levels will be always equal. They are produced in equimolar concentration. Okay, that's the one point which I want you to know. Next, sir, this insulin, it is stored in the vesicle. Let's say this is a beta cell. Here is a beta cell. Now within the beta cell, here is insulin. Now insulin molecules, they are stored with which ions? Zinc ions. Insulin, it is stored with which ions? Zinc ions. Insulin is stored with zinc. Okay, that's okay. Now these beta cells, they are going to release the beta cells will release insulin. Okay. Now what is the function of this insulin now? Now insulin is going to act on your tissues. Which tissues is important? Insulin is acting on which tissues? Insulin is acting on tissues like adipocytes, and skeletal muscles. Okay, insulin is acting on the which cells? Only two types of tissues. Insulin is acting on the two types of tissues. For your exam, adipocytes and skeletal muscles. But insulin acts on adipocytes, skeletal muscles. Now, here is the insulin receptor. Let's say here is the insulin receptor. So, insulin is coming and acting. Now, they will ask you for your exam, what is this receptor? Which type of receptor? Insulin acts on which type of receptor? Insulin receptor is a tyrosine kinase receptor. Insulin receptor is a tyrosine kinase receptor. Okay, once this insulin receptor is activated, now this adipocytes and skeletal muscles, now they will produce a special type of transporters. Now they are going to produce a special type of transporters on the cell membrane. Previously they are not there. Now they are going to make this special type of transporters which I am showing here in the pink color. These transporters are helping in the transport of glucose. They are helping in the transport of glucose from the blood into the cell. So this is how glucose enters into your cells. So only in the presence of insulin, so these pink color transporters which I am showing here are produced. So with the help of this transporter, glucose is coming into the cell. So what is the name of this transporter? This transporter is called as a glucose transporter type 4. So glucose transporter type 4, they are insulin dependent. Glucose transporter type 4, they are insulin dependent. And where the glucose transporters are present? The GLUT4 glucose transporters, they are present on adipocytes and skeletal muscles. So lifelong remember this one point as a doctor. At least till the time of your exams, FMGE and NEETPG exams. The point is, wherever you see GLUTs, okay, GLUTs. So all glucose transporters, how I used to remember, GLUTs like GF, sir. GF, like girlfriend, GF, girlfriend. All the GLUTs are examples of facilitated diffusion. See here the glucose is getting transported. The glucose is getting transported to the cell. What kind of transport? Is it primary active transport? Is it secondary active transport? Is it facilitated diffusion? Is it simple diffusion? Is it osmosis? They will ask you. All the gluts are examples of facilitated diffusion. Wherever you see the word glut, gluts are examples of facilitated diffusion. Okay. Now, here itself, let me discuss with you where glut 1 is present. Glucose transporter type 1, important for your exam. Glucose transporter type 1, they are present in your brain, they are present in your RBC, and they are present in your placenta or in placenta. Okay, they are present in placenta, RBC and brain. Glucose transporter type 2. Glucose transporter type 2, glut 2, they are present in. Their present main answer is always liver, sir. Okay, the best answer is always liver. Apart from liver, they are also present in small intestine. They are present in intestine. They are present in kidneys. Okay, they are present in intestine. They are present in kidneys and in other areas also. But mainly, main answer is always liver. Glut 2. It is present in kidneys. In the kidneys, where mainly PCT. In the PCT of the kidneys, glut 2 is present. Okay, glut 2 is present. It is present in the small intestines and it is also present in liver. Also, it is present in pancreas. Okay, glut 2 is also present in glut 2. Glucose transporter type 2 also present in pancreas. Okay, done. Forget about the glut 3. Glut 4. Now I have told you glut 4. Glut 4. Where exactly the glut 4 transporters are present? Glut 4 transporters are present in skeletal muscle. Okay, present in skeletal muscle plus adipocytes. Okay, but important point about the glut 4 is insulin dependent. They are insulin dependent. Glut 4 transporters are insulin dependent. But what are the glut 2 and glut 1? They are insulin independent. These are insulin independent. And glut 5. Glut 5, it is a fructose transporter. Fructose transporter. It transports fructose. Okay. It's a fructose transporter. So where exactly this glut 5 is present? Glut 5, it's a fructose transporter. It is present in intestines. It is present in intestines as well as it's present in the sperms. Okay, it's present in intestines as well as sperms. Okay. So these are the important points which I want you to know regarding the glucose transporters and how the insulin is going to act. See, insulin is going to release. Insulin is going to be released from the beta cells. Insulin acts on tyrosine kinase receptor. When the tyrosine kinase receptors are activated, glucose transporter type 4 is produced. With the help of glucose transporter type 4, glucose is undergoing facilitated diffusion into the cells. Okay, glucose is undergoing facilitated diffusion into your cells. Okay, done. Next, after this, what else you have to know regarding insulin? Insulin relationship with the potassium. Always insulin. See, insulin is going to decreases your potassium levels. Insulin, why? How means insulin moves potassium. Insulin moves potassium into cells, especially adipocytes. Okay, insulin, what it is doing? So whenever you are going to take the insulin, whenever you take the insulin, the potassium from your blood, the potassium from your plasma will be going into the cells. So what happened to the blood levels of potassium? The blood levels of potassium is going to decrease. So that's why whenever you are giving insulin in some emergencies like diabetic ketoacidosis, whenever you are giving IV insulin, so you should be mainly worried about this complication. The insulin may lead to hypokalemia. Insulin may decreases the potassium levels. Okay, it's because insulin decreases the potassium. Insulin moves the potassium into the cells. Okay, remember this point. Next, let me tell you some important biochemistry points about the insulin. See, insulin, it activates certain reactions. Okay, insulin, it activates certain biochemical reactions and it inhibits some biochemical reactions. What are they? Insulin is going to activate, okay, lipogenesis. Okay, lipogenesis. Insulin activates lipogenesis. Next, insulin activates glycolysis. Okay, insulin is activating what? Glycolysis. It's activating glycolysis. It's activating lipogenesis and it's also stimulating glycogen synthesis. Okay, glycogen synthesis. Because insulin is very, very important for your exam. Without a question on insulin, there is no FMGE paper. See, you have to know important points about the insulin. So, insulin, what it is doing? insulin, it's going to, they will give a question something like this. All of the following reactions are activated by insulin. All of the following reactions are activated by insulin except. So you should know insulin activates lipogenesis, glycolysis, and it activates glycogen synthesis. Okay, and insulin, I have told you, it's an anabolic hormone. It's a major anabolic hormone in the body. So it's also going to cause the protein synthesis. That's okay. Okay. In the same way, insulin inhibits what? Insulin inhibits lipolysis. Okay, lipolysis. Insulin inhibits glycogenolysis. Insulin inhibits, okay, gluconeogenesis. Insulin inhibits ketogenesis. So this is the most important point which I want you to know. Till the time insulin is there in the body, ketone bodies are not produced. Till the time insulin is there in the body, till the time insulin is there in the body, till the time you have insulin in your body, ketone bodies are not produced. So tell me, what happens if you are not having insulin? Insulinopenia, which is seen in diabetes mellitus type 1. Insulinopenia, sir, in diabetes mellitus type 1, there is no insulin in the body. Now insulin is not there. What happens? The person is going to have ketone body production. Ketone body are produced. Ketone bodies. Okay. Ketone bodies are produced. Now, these ketone bodies are going to be responsible for diabetic ketoacidosis. So simple, no? The patient is a diabetic, type 1 diabetic, and here the person is not having insulin. Without insulin, who is produced? Ketone bodies are produced. Ketone bodies are acidic in nature. They are acids. Ketone bodies are acids. So, as the ketone bodies are getting produced in the body, that is going to lead to metabolic acidosis. So, diabetic ketoacidosis is mainly seen in type 1 diabetes mellitus. So, you tell me, what is the drug of choice? What is the drug of choice for the treatment of this diabetic ketoacidosis? Are simple. Insulin is not there. So, just give the insulin. So, IV insulin. Okay, insulin. So, that's the drug of choice for diabetic ketoacidosis. See, what is the most common cause of death? If a child, usually the child will have the diabetic ketoacidosis because type 1 diabetes mellitus is mainly seen in childhood. So, what is the most common cause of death in a diabetic ketoacidosis? The most common cause of death is a cerebral edema. So, cerebral edema is the most common cause of death in a child with diabetic ketoacidosis, the most common cause of death. Next one is a child who is suffering with a diabetic ketoacidosis. If you ever see a child who is suffering with a diabetic ketoacidosis, he is going to breathe so heavily, sir, like this. He is going to have the hyperventilations. Okay. So such hyperventilation is called as, which is seen in a patient who is suffering with a diabetic ketoacidosis, that is called as Kusumal breathing. Okay. Kusumal breathing. So Kusumal breathing is seen in diabetic ketoacidosis. Done. So what is the main problem? The main problem with the diabetic ketoacidosis, the main problem with the diabetic ketoacidosis is a metabolic acidosis. The insulin is not there, so there is metabolic acidosis. Done. Next, after this, let's discuss about some steroids. From which part of your body the steroid hormones are getting produced? Okay, the major source of steroid hormones in your body is adrenal cortex. You know adrenal gland. So here is adrenal cortex. Adrenal cortex is divided into 3 regions. That is GFR. Zona glomerulosa, zona fasciculata, zona reticular. Zona glomerulosa, zona Z. Okay, let me write full form. Glomerulosa, zona fasciculata, and zona reticularis. Okay, the adrenal cortex, not medulla. Adrenal cortex is divided into zona glomerulosa, zona fasciculata, zona reticularis. And adrenal medulla, you see here, what is the important point that you should know regarding adrenal medulla? Adrenal medulla, it is derived from neural crest cells. Okay, neural crest cells. Adrenal medulla, it contains cells called as chromaffin cells. Okay, chromaffin cells. These adrenal medulla, these chromaffin cells are going to produce, adrenaline, noradrenaline. Okay, adrenaline, noradrenaline. Okay, adrenaline, noradrenaline, they are coming from the adrenal medulla. Now, what about the zona glomerulosa fasciculata and reticularis? Sir, this zona glomerulosa fasciculata and reticularis, adrenal cortex is going to produce steroids. Okay, they are going to produce what? Steroids. What are steroid hormones? Steroid hormones means they are derivatives of what? Cholesterol. Okay, they are derivatives of cholesterol. Now, zona glomerulosa is going to produce a steroid called as aldosterone. So, what is the function of aldosterone in your body? The function of aldosterone in your body, here itself I am telling you, aldosterone is called as a MC, sir, mineralocorticoid. What it will do? It is going to increase your, okay, let me write here, aldosterone is going to act on collecting ducts of your nephrons. They are going to act on collecting duct. It increases your sodium levels in the body, and it decreases potassium levels, and it decreases the proton levels in the body. So what this aldosterone is going to do? Aldosterone, which is a mineralocorticoid, acts on the collecting ducts of the nephrons. Okay, CD means you will confuse, collecting ducts of nephrons. So what it will do? So by acting on the collecting ducts of the nephrons, it increases the sodium reabsorption back into the body, and it causes the potassium and proton excretion. Potassium and proton will be excreted out of the body. As the potassium and proton are excreted out of the body, what happened to their levels in the body? Decreases. The potassium levels and the proton levels are going to decrease. Okay, decrease. Next, zona fasciculata. Zona fasciculata is going to produce cortisol. So cortisol, it's called as a glucocorticoid. Why? Because it is going to increase your blood glucose levels. Cortisol increases your blood glucose levels. And one more important function of a cortisol in our body is to increase the BP. Okay, cortisol maintains our BP, cortisol maintains our vascular tone, and cortisol is going to increase your blood glucose levels. Okay, and zona reticularis. The zona reticularis is going to produce what? The zona reticularis is going to produce weak androgens. Okay, weak androgens. What are the examples of the weak androgens? The weak androgens here, they are androstenedione, or dihydroepiandrosterone sulfate. Okay, dihydroepiandrosterone sulfate. This is the MCQ which was already asked in the exam. This question was asked. Dihydroepiandrosterone sulfate, DHEAS, not DHEA, DHEAS is produced from zona reticularis of adrenal cortex. So whatever I am showing here, all of these are steroids. All these are steroids. Aldosterone, cortisol, and androgens, all are steroids. Okay. Now in one of the exams, this question was asked. Steroids are produced by which organelle? So write, steroids are synthesized from smooth endoplasmic. See, you might feel like, it's a simple or funny question, but such questions are already asked in the exam. Okay, so smooth, that too, this question was asked in the NICT exam. Okay, the steroidogenesis will happen in which organelle? So smooth endoplasmic reticulum. Okay, smooth endoplasmic reticulum. Okay, now after this, what else I want you to teach is, sir, what is the condition in which there is excessive aldosterone levels? Aldosterone levels. What is the condition in which the aldosterone levels are elevated, and what is the condition in which the cortisol levels are elevated? See, this is a main topic from your patho. You have to actually study it from your patho, but only I will tell you the names. So the condition in which the aldosterone levels are elevated is called as a Conn syndrome. Okay, Conn syndrome. In Conn syndrome, the aldosterone levels are elevated. Okay, what happens in Conn syndrome? What is the problem with the Conn syndrome? The problem with the Conn syndrome is there is a tumor. There is a tumor in the adrenal cortex. This tumor is continuously 24/7. It is secreting aldosterone. Okay, it is secreting what? Aldosterone. 24/7 it is releasing aldosterone. So primary hyperaldosteronism. So Conn syndrome, aldosterone levels are elevated. And what is the condition in which the cortisol levels will be elevated? The cortisol levels will be elevated in Cushing syndrome, sir. Cushing syndrome. Okay, Cushing syndrome. You will be having high cortisol levels in Cushing syndrome. What is the most common cause of Cushing syndrome? Many times tested. What is the most common cause of Cushing syndrome? Iatrogenic. That is a doctor giving excessive steroids. A doctor prescribing or doctor giving more steroids to the patient. So that is causing the Cushing syndrome. So iatrogenic. See, let me tell you one more important point here. See, let's say this is the pituitary gland. Here is the pituitary gland. In the pituitary gland, there is a tumor. Okay, there is a tumor. This tumor, what it is doing? It is producing excessive amount of ACTH. ACTH producing tumor. This ACTH, where it is coming? ACTH is coming and acting on adrenal gland. When there is excessive amount of ACTH coming and stimulating the adrenal gland is making more cortisol. This excessive amount of cortisol now is going to cause which syndrome? Cushing syndrome. So now what is the name of this condition called as? See, this is a pituitary tumor. This is a pituitary tumor leading to Cushing syndrome. Now this pituitary tumor, this is called as Cushing disease. Okay, Cushing disease. So in Cushing disease, where is the problem located? In Cushing disease, the problem is in the pituitary gland. The pituitary gland tumor. So tumor in pituitary. Okay, the tumor where? In the pituitary gland. So the tumor in the pituitary gland is the one responsible, is the one causing high levels of ACTH. The high levels of ACTH is increasing the cortisol levels. That is going to cause the Cushing syndrome. The point which I want you to know for your exam is, see, whenever you are having high ACTH levels, do you know what this ACTH will do? The high ACTH levels are the ones responsible to stimulate the melanocytes, you can say. So the high ACTH levels are going to stimulate the melanocytes and they are going to produce more melanin, so there will be hyperpigmentation. Okay, hyperpigmentation. So now tell me, the hyperpigmentation in a patient who is having Cushing syndrome, if you do the physical examination of palms and soles, and the oral mucosa, it will be hyperpigmented. That hyperpigmentation is not because of cortisol. The hyperpigmentation is not because of cortisol. The hyperpigmentation is because of ACTH. So it's the ACTH, right? It's the ACTH MCQ. ACTH is responsible for the hyperpigmentation, not the cortisol. Okay. Now let me tell you some more important points about this cortisol. Okay, so I have already told you cortisol is going to increase your blood glucose levels, increases your BP. Apart from that, let me tell you some more important points about the cortisol. Cortisol, which is a steroid hormone, glucocorticoid, it decreases all the WBCs. Cortisol decreases all the WBCs. It decreases every WBC, T lymphocytes, B lymphocytes, eosinophils, it decreases everything. But it increases neutrophils. Okay, it increases neutrophils. It increases monocytes. It increases your RBC. It increases your WBC. So the normal functions. This is the normal function of cortisol. Cortisol is going to decrease your WBCs, but cortisol increases your neutrophil levels. It increases your monocytes, increases RBC and WBC. This is the MCQ which I want you to know for your exam. Cortisol increases neutrophils. Okay. Next, apart from this, what else I have to teach you regarding cortisol? See, cortisol levels, sometimes in a day, cortisol levels are very, very less. And sometimes the cortisol levels will increase. And again the cortisol levels will decrease. Again the cortisol levels will increase. So in a day, okay, if you take 24 hours, sometimes the cortisol levels are high and sometimes the cortisol levels are low. And again next day, sometimes the cortisol levels are less and sometimes the cortisol levels are more. So in a 24 hours, sometimes the cortisol levels are less and sometimes the cortisol levels are more. This is called as diurnal variation. So which hormone shows diurnal variation? Diurnal variation is seen with cortisol. Okay, so these are some important points which I want you to know regarding this glucocorticoid called as a cortisol. Okay, now after this, let's discuss about the calcium homeostasis. In the topic of the same endocrine, let me discuss about the calcium homeostasis. Calcium homeostasis. Okay, so which hormones increases? Now I am still talking about the hormones. Which hormones increase the calcium levels and which hormones decrease the calcium levels? See, calcium homeostasis are the calcium levels in your body are regulated by three things. Two hormones and one vitamin. Parathyroid hormone, calcitonin and vitamin D. So the parathyroid hormone increases calcium, but it decreases phosphate. So this is the function of parathyroid hormone, sir. I used to remember like parathyroid hormone as phosphate trashing hormone. Phosphate trashing hormone. It causes the excretion of phosphates out of the body. So parathyroid hormone increases the calcium but decreases the phosphates. What about the calcitonin? Calcitonin decreases the calcium levels in the body. Okay. But what about the vitamin D? Vitamin D increases the calcium levels as well as increases the phosphate levels in our body. Okay, this is the function of vitamin D. Vitamin D is also called as calcitriol. Calcitriol. So vitamin D, also called as a calcitriol, what it is doing? It is increasing calcium as well as phosphate. But what about the parathyroid hormone? It is increasing calcium but decreasing phosphate. Okay, calcitonin doesn't have any effect on phosphate, sir. Now, can I say something like this? There is a vitamin which acts like a hormone. Okay, which vitamin acts like parathyroid hormone? Which vitamin acts like a parathyroid hormone? Vitamin D, because both are increasing the calcium levels. So in one of the exams, this question has been asked: vitamin D acts like hormone. Acts like hormone. Even though it's a vitamin, it acts like a hormone. It's increasing the calcium levels. So these are the important points which I want you to know regarding calcium homeostasis. Apart from this, what else you should know in the topic of this endocrine physiology is the topic of secondary messengers. Okay, secondary messengers. The topic of secondary messengers. See, what is the function of the secondary messengers? In each and every cell, some secondary messengers are produced. Whenever a hormone is coming and acting on the receptor. Okay, whenever a hormone comes and acts on the receptor. Okay, a hormone is coming. Okay, let me just erase this. It will confuse you. Okay, whenever a hormone it's coming and acting on the receptor, who is produced inside the cell? Some secondary messengers are produced. So these secondary messengers, what is the function? Recent question. What is the function of the secondary messengers? They control intracellular reactions. Okay, they are going to control some intracellular reactions. They will facilitate the intracellular reactions. So what are the different types of secondary messengers? The different types of secondary messengers include CAMP, CGMP and inositol triphosphate, IP3. Okay, CAMP, CGMP and inositol triphosphate. So which hormones produces cyclic AMP? Which hormones produces the cyclic AMP inside the cell? The hormones like TSH, FSH, LH, ACTH. Okay, hormones like TSH, FSH, LH, ACTH, these are all coming from the pituitary gland. All these hormones are going to use cyclic AMP as a secondary messenger. Next, apart from them, antidiuretic hormone when it acts on V2 receptors and histamine when it acts on H2 receptor. Antidiuretic hormone acting on V2, histamine acting on H2 and epinephrine acting on the beta 1, beta 2 receptors. They are all producing cyclic AMP. They all uses cyclic AMP. Okay. Apart from that, beta HCG also uses cyclic AMP. Then who uses cyclic GMP? Which hormones produces cyclic GMP? The cyclic GMP, it is produced by nitric oxide and atrial natriuretic peptide and brain natriuretic peptide. So nitric oxide, atrial natriuretic peptide and brain natriuretic peptide, these hormones which I am showing here, these hormones, they are uses which type of secondary messenger? Cyclic GMP. And IP3, inositol triphosphate, is a secondary messenger. It is utilized by which hormones? It is utilized by oxytocin, hormones like oxytocin, histamine, antidiuretic hormone. The point is here, see, histamine acting on H1 receptor, antidiuretic hormone acting on V1 receptor. Because see, histamine acting on H2 receptor and antidiuretic hormone acting on V2 receptor, they produce a cyclic AMP. But the histamine acting on H1 receptor, antidiuretic hormone acting on a V1 receptor, they all uses which type of secondary messenger? IP3. Okay, and angiotensin 2. So what is one thing in common? See, can you guys tell me what is one thing in common here? Oxytocin causes uterine contraction, histamine causes bronchoconstriction, antidiuretic hormone causes vasoconstriction, because you know antidiuretic hormone also called as vasopressin, it causes vasoconstriction, and angiotensin 2 causes vasoconstriction. The one thing which is common here is IP3 is the secondary messenger involved in smooth muscle contractions. Okay, smooth muscle contractions. So which secondary messenger is involved in smooth muscle contractions? IP3. Do you know what IP3 will do? For smooth muscle contraction, what do you require? Calcium is required. So IP3 increases the calcium levels inside the cell. IP3 increases the calcium levels inside the cell. IP3 is responsible for muscle contraction, smooth muscle contraction. So those hormones which are involved in contractions of the muscle, they use which secondary messenger? IP3. Oxytocin, uterine contraction. Histamine, bronchoconstriction. Antidiuretic hormone, vasoconstriction. Angiotensin 2, vasoconstriction. Okay, done. Now, apart from this, see, I want to discuss some important points about oxytocin as well as antidiuretic hormone. These are also still hormones, no? Now, who produces this oxytocin and antidiuretic hormone? See, here is the hypothalamus. Here is the pituitary gland. Okay, hypothalamus as well as the pituitary gland. Hypothalamus include two nucleus. Hypothalamus, it has two nucleus. Okay, hypothalamus has two nucleus. What are the names of these two nucleus? The name of these two nucleus is, one is a supraoptic nucleus and other is a paraventricular nucleus. Supraoptic nucleus as well as paraventricular nucleus. The supraoptic nucleus produces what? Antidiuretic hormone. And paraventricular nucleus, what it will produce? Oxytocin. So tell me, where the production of antidiuretic hormone occurred and where the production of oxytocin occurred. So the production of antidiuretic hormone and oxytocin, they occurs in hypothalamus. Production occurs in hypothalamus. But where are they stored? See, the antidiuretic hormone and oxytocin, they are stored in posterior. They are stored in which pituitary? Posterior pituitary. Okay, so the mnemonic which I make is SOAP. So what is the SOAP? Supraoptic nucleus produces antidiuretic hormone, paraventricular nucleus produces oxytocin. Okay, that's how you have to know it. So production occurs in hypothalamus. Okay, now what is the function of this oxytocin? Let me tell you, function of oxytocin. Let me write oxytocin here. Oxytocin. What is the function of oxytocin? Oxytocin, it helps in milk ejection. Okay, milk ejection. Oxytocin helps in milk let out, milk ejection. Okay, next oxytocin helps in uterine contractions. Okay, uterine contractions. In the place of milk ejection, sometimes just to confuse you, they will use the word galactokinesis. Galactokinesis is nothing but the milk ejection, and that's under the control of oxytocin. Then who helps in milk production? Milk production. So milk production, it is under the control of prolactin. Okay, so prolactin helps in milk production. Oxytocin helps in milk ejection. Instead of using the word milk production, they will use the word lactogenesis or lactopoiesis. Okay, lactogenesis is the better word. Okay, so lactogenesis is under the control of prolactin. Galactokinesis is under the control of oxytocin. So first of all, to produce the milk, what is required? Breast is required. That is breast development. That is mammogenesis. Mammogenesis, the breast development, it is under the control of estrogens. So estrogens are the first hormones. Estrogen helps in mammogenesis. Later prolactin helps in milk production and oxytocin helps in milk ejection. So what is the order of events? Order of events is first start with mammogenesis, next lactogenesis, next galactokinesis. Okay, till here every student can answer. 1, 2, 3. What is the last step, sir? The last step is galactopoiesis. The fourth step is galactopoiesis. Galactopoiesis means maintenance of milk production and ejection. Maintenance. Okay, maintenance. The milk is again and again, the new milk should be produced. No, that is maintenance. That's mainly under the control of prolactin again. Okay, galactopoiesis, it's mainly under the control of prolactin. Okay, so they will ask you in the exam, already this was asked. So what are the steps? In the milk production? First, mammogenesis, lactogenesis, galactokinesis. Last one is galactopoiesis. Okay, so done. So with this, the important points about the prolactin is also completed. One more point is, see, regarding prolactin. Okay, even though it's taking time, yeah, I am trying to complete as much as possible. See, to complete the entire physiology, if you have to attend the entire physiology classes, it will take like 5 days, 4-5 days of physiology. But here I am trying to complete everything, the rapid revision of physiology in somewhere around 4 to 4.5 hours. Okay. See, who increases the prolactin? Who increases the prolactin levels? Who increases the prolactin levels? The prolactin levels are increased during sleep. Estrogens. Okay, so during REM sleep, rapid eye movement sleep, and estrogens, pregnancy, as well as TRH, thyrotropin releasing hormone. This is MCQ. So thyrotropin releasing hormone, TRH, can increases your prolactin levels. Then who decreases the prolactin? The prolactin, it is decreased by dopamine. Okay, very important. So dopamine is called as a prolactin inhibitory hormone. Dopamine is also called as what? Prolactin inhibitory hormone. Prolactin decreases, okay, by dopamine. Whenever dopamine level increases, prolactin levels decreases. Okay, just remember that one point. Next, apart from this, what else you should know? See, 2 clinical cases, let me explain you. The 2 clinical cases here is the hypothalamus, here is the pituitary gland. Okay, let me talk about the anterior pituitary. Now I am talking about the anterior pituitary. Now what happens is, see, because of some trauma, okay, because of some road traffic accident or because of some reason, see, the pituitary stalk, it is damaged here. Okay, pituitary stalk is damaged. Here there is a cut. Whenever there is it is severed. Whenever the pituitary gland, it is separated from the hypothalamus, do you know what happens? Sir, what happens is all pituitary hormones like growth hormone, thyroid stimulating hormone, next corticotropin releasing hormone, ACTH. Okay, ACTH, FSH, LH, all hormones decreases. All hormones, they are decreasing. See, all hormones decreases except prolactin. Okay, so whenever there is a pituitary stalk damage, just remember this one point. Whenever there is a pituitary stalk damage, sir, all hormones decreases except prolactin. Next, one more condition I am showing you. See, this is again hypothalamus. Here is the pituitary gland. There is a complication, sir. The complication is postpartum hemorrhage. In a female who delivered the baby, and now she is having a complication called as a postpartum hemorrhage. Whenever there is postpartum hemorrhage, severe blood loss, do you know what happens in this female? Now, in this female, the blood supply to the pituitary gland decreased. So pituitary gland has undergone necrosis. The pituitary gland has dead, sir. Now it is dead. Here it is still living. But here in this condition, it is dead because postpartum hemorrhage, severe blood loss is going to decrease the BP, causes severe vasoconstriction. So that is going to cause first ischemia, hypoxia, necrosis. So this entire pituitary gland is dead. Okay, so dead. Now what happened to all the hormones? All hormones decreases. All pituitary gland hormones like growth hormone, TSH, FSH, LH, ACTH, all decreases, even prolactin. Even in this mother, prolactin levels goes down. Okay, postpartum hemorrhage means mother only, no. She is pregnant, she delivered the baby. Now in this mother, all the pituitary hormones decreases, even prolactin. So this condition is called as Sheehan syndrome. Okay, Sheehan's syndrome. So what is Sheehan syndrome? Sheehan syndrome is a postpartum necrosis. It's called as, let me write it here, full form, postpartum necrosis of, postpartum means after delivery, postpartum necrosis of pituitary gland. Okay, Postpartum necrosis of the pituitary gland is called as a Sheehan syndrome. So in Sheehan syndrome, all hormones decreases, even prolactin decreases. So in this mother, prolactin is not there. When the prolactin is not there, so what happens? She can't give milk to the baby. So failure to breastfeed. Failure to breastfeed. So breastfeeding is not going to occur. Okay, no possibility of breastfeeding, sir. So that is what happens in Sheehan's syndrome. That's what happens in Sheehan syndrome. Next, apart from this, the last thing that I am teaching here in endocrine physiology, the last thing that I want you to know in the endocrine physiology, here is the hypothalamus and here is the pituitary gland. See, in the pituitary gland, there are different types of cells present. Okay, there are different types of cells present. Out of which 2 cells are going to stain in pink color. 2 cells are going to stain in H and E stain. Whenever you do hematoxylin and eosin stain, H and E stain, 2 cells are going to come in pink color, sir. Okay, so pink color means what? Acidophilic. So what are the 2 acidophilic cells? What are the 2 acidophilic cells? One is a somatotrope, which is producing the growth hormone, and other is the lactotrope, which is producing the prolactin. Okay, which is producing what? Prolactin. So these 2 cells, the somatotropes and lactotropes, they are acidophilic cells, and others are basophilic cells. Okay, others are basophilic cells, which are staining in blue color. The basophilic cells, no one will ask you. What they will ask you is acidophilic cells. The somatotropes and lactotropes are the acidophilic cells. So with this, what we have completed the endocrine physiology, sir. All the important endocrine points, whatever is needed, all important endocrine points completed. Okay, completed. Next, let's hope the questions will come from this only. Okay, this is the last start of resort. I make sure that most of the questions I have covered. Okay, chalo. Next, after this, let's start GAT. See, GAT is very simple. GAT is only 2 marks. Okay, GAT, gastrointestinal physiology. See, in gastrointestinal physiology, 2 marks will be coming, and what are the important things that you should know in GAT physiology is cells which are present in gastric gland, cells in stomach or gastric glands. Cells in the stomach or gastric glands. What are the different types of cells? What are the different types of cells present in the gastric gland or stomach? See, stomach contains parietal cells. What is the function of the parietal cells? The parietal cells, okay, parietal cells are going to produce acid. Parietal cells are the acid producing cells. As well as these parietal cells also produces something called as intrinsic factor. Parietal cells also produce intrinsic factor. Intrinsic factor helps in absorption of which vitamin? Vitamin B12 absorption. Intrinsic factor helps in vitamin B12 absorption. What is the important point about the vitamin B12? This vitamin B12, you can get it. You will only get it from animal sources. Only animal source. So what is the important point of the vitamin B12? Vitamin B12, you can only get it from your animal sources. Okay, like milk, curd, ghee, or like the meat of the animals. Okay, vitamin B12 only from the animal sources. From where this vitamin B12 is absorbed? Okay, in which part where this vitamin B12 is absorbed? Vitamin B12 is absorbed from terminal ileum. Okay, along with intrinsic factor. Only in the presence of intrinsic factor, vitamin B12 will be absorbed in terminal ileum. Okay, next point is parietal cells completed. Okay, they produce the acid. Next, enterochromaffin cells. Enterochromaffin like cells. See, these enterochromaffin like cells, we call it as ECL, enterochromaffin like cell. Enterochromaffin like cells, the enterochromaffin like cells, they are going to produce histamine. Okay, histamine. Next, third cell, G cell. G cells are going to produce gastrin. Now you can ask me, sir, what is the function of histamine in the stomach and gastrin in the stomach? The function of histamine and gastrin in the stomach, these two, histamine and gastrin, they will stimulate the parietal cells. They will stimulate the parietal cells to release more acid. So histamine and gastrin, they will increase acid. They will release acid, more and more acid from the parietal cells. Okay. Next, chief cells. Chief cells. So what is the function of chief cells in the stomach at the gastric gland? Chief cells, they are going to produce the hormones called as pepsinogen. pepsinogen, okay, and gastric lipase, pepsinogen and gastric lipase. Pepsinogen helps in the digestion of proteins. Gastric lipase helps in the digestion of lipids. But wherever you see the word ogen means inactive, ogen means inactive. So the pepsinogen need to be converted into pepsin. You have to convert the pepsinogen into pepsin. So who will convert that? So let me write here, take a note. A pepsinogen will be converted into pepsin with the help of acid in the stomach. It's the acid which is converting. Pepsinogen into pepsin. Understand? So now tell me, sir, in your stomach, which digestion is happening? Proteins are getting digested, lipids are getting digested, but is there any enzyme for carbohydrate digestion? No amylases are present in the stomach. No amylases are produced in the stomach. So write that point, no carbohydrate digestion, or you can say no amylases. No amylases in the stomach. Okay? But I want you to know one important amylase in your mouth, sir. In your mouth, there is very important amylase produced from the salivary glands. That is, just I am going back. From the stomach, I am going back. There is an enzyme called as salivary amylase, also called as thiolene. Okay? So, thiolene, what it helps in digestion of? This thiolene, which is called as a salivary amylase, produced from the salivary gland, it helps in the digestion of carbohydrates. I don't know why the examiner is very fond of this. Very, very important. Thiolene is a salivary amylase produced from the salivary glands, helps in the digestion of carbohydrates. So carbohydrate digestion occurs in mouth itself. Okay? Done? Next. So how many cells we have completed? Parietal cells, enterochromaffin cells, G cells, chief cells, and D cells. D cells of the stomach. D cells of the stomach produces somatostatin. Somatostatins. What is the function of somatostatin? It decreases the acid production in the stomach. And last cell is in your stomach. You know who produces the mucus? Mucus. The mucus is produced by cells called as foveolar cells. So foveolar cells are the ones which produces the mucus in the stomach. It's not the goblet cells. Goblet cells are not present in the stomach. It's the foveolar cells of the stomach produces the mucus. Okay, understand? Now, look at this. Guys, here is a parietal cell, let's say. Okay, this is parietal cell. Parietal cell, what it produces? It produces acid. Okay, it produces acid. Now, what are the stimulus for the production of acid, sir? I have already told you two stimulus. One is gastrin. Other is histamine. Okay, gastrin stimulates the parietal cells, histamine stimulates the parietal cells, and there is one more stimulus for the release of acid, sir. One more stimulus is there, that is acetylcholine. So, acetylcholine coming from the parasympathetic nervous system, vagus. So, these are the three stimulus: gastrin, acetylcholine, histamine. They are all the stimulus for the release of acid. Now, the acid is coming from a pump, sir. Okay, acid is released with the help of a pump called as a proton pump. Okay, pump. Now here I am telling you, wherever you see the word from today, wherever you see the word pump or the word ATPase. Okay, proton pump or proton ATPase. Blindly answer, I have told you, wherever you see the word GF, glucose transporters, facilitated diffusion. Now from today, sir, here the acid is getting transported, no? Acid is getting transported out of the cell into the stomach cavity. Now wherever you see the word pump or ATPase, they are all examples of primary active transport. Blindly answer it. Proton pump, calcium ATPase, sodium potassium ATPase. Wherever you see the word pumps, they are all examples of primary active transport. Okay, they are examples of primary active transport. Done. Now tell me, these proton pumps, they are inhibited by drugs called as omeprazole, like pantoprazole and esomeprazole. Okay, so drugs like pantoprazole, omeprazole and esomeprazole, they are all proton pump inhibitors. They inhibit primary active transport. Okay. Okay, so these drugs, this is the question which was already asked in the exam. Omeprazole, pantoprazole, esomeprazole, yes, they are all proton pump inhibitors. So they are inhibiting which kind of transport? See, these drugs, they will give you inhibits which type of transport? They are inhibiting primary active transport. Primary active transport. Simple, no? So done. Next, after this, what does I have to teach you in the GIT? So in the GIT, the next most important topic is the absorption, sir, iron absorption. Okay. Before going to the iron absorption, let me tell you one more thing here. Sir, acid secretion, acid is going to be secreted in 3 phases. 3 phases. First one is called as a cephalic phase. Cephalic phase. Next one is gastric phase. Gastric phase. And third phase is called as intestinal phase. Intestinal phase. Acid is secreted in 3 phases. Cephalic phase means when you think about the food, acid production has started. How much percent acid production has started, sir? Almost 30% acid production has started. Okay. Gastric phase means when you actually eat the food. When you actually eat the food, 60% of the acid will be produced. 60% acid will be produced. That is gastric phase. And when the food is going into the intestines, when the food is leaving the stomach, when it is going into the intestines, only 10% of the acid will be produced. So the acid production happens in 3 phases. That is the cephalic, means when you are thinking about the food, when you actually eat the food, and food going into the intestines. So 3 phases are there. The question which was asked is maximum acid production seen in gastric phase. Maximum acid production always seen in gastric phase. Done. Now after this, let's see important points about the iron absorption. Okay, iron absorption. So here is your duodenum. Let's say here is your duodenum. Here is your blood vessel. Okay, let me show you in a duodenum in a different color. Let's say here is your duodenum. Here is enterocyte, epithelial cell, and here is a blood vessel. Okay, and here is the liver. Here is the liver. Understand? Now tell me, in which area the iron will be absorbed? Iron is absorbed in duodenum. Okay, so iron is of how many forms, sir? Iron is in 3 forms, sir. Fe3 and Fe2 plus. Only you can absorb Fe2 plus form of iron. Only you can absorb which form of iron? Fe2 plus form of iron you can absorb. That is called as a ferrous. Only you can absorb ferrous form of iron, not the ferric form of iron. Ferrous form of iron will be absorbed. So who will convert this Fe3 plus? Fe3 plus you are getting it from plant sources, sir, actually. Okay, Fe3 plus. You need to convert the Fe3 plus form of iron into the Fe2 plus form of iron. That conversion occurs with the help of acid in the stomach and vitamin C. So acid and vitamin C. Acid and vitamin C in the stomach itself, they will convert Fe3 plus into Fe2 plus. Okay, Fe2 plus. Now this Fe2 plus, you can absorb it into the cell with the help of a transporter called as a DMT1. Okay, DMT1, divalent metal transporter 1. With the help of a divalent metal transporter 1, you can absorb Fe2 plus. Okay, now this Fe2 plus, now it need to go into the blood, sir. It need to go into the blood. Okay, with the help of a different transporter. So what is the name of this different transporter? This is called as a ferroportin. Okay, what is it called as? Ferroportin 1. Okay, ferroportin 1. So it's a ferroportin 1 which helps in iron absorption. Into the blood. So now you got your iron here, sir. Okay, we got the iron here. But in the blood, say this Fe2 plus form of iron is good to absorb. Okay, to absorption for absorption you require Fe2 plus form. But once you absorb into the blood, it will be again converted back into Fe3 plus form. Okay, it will be again converted back into Fe3 plus form with the help of a molecule called as hephaestin. There is a molecule called as hephaestin here. It converts the Fe2 plus back to Fe3 plus. So tell me now which form of iron is there here? Fe3 plus. Now this Fe3 plus form of iron, it's bound with a plasma protein, sir. It is carried by a plasma protein. The plasma protein is called as transferrin. Okay, transferrin. Now what is transferrin will do? Transferrin is a plasma protein binding with the iron. This transferrin, it transport the iron through the blood, it transport the iron to the storage site. So liver is the storage site. Okay, liver is the storage site. So here this is the place where iron is stored. Now this stored iron is called as ferritin. This stored iron is called as what? Ferritin. Okay. So The storage form of iron is called as a ferritin, sir. Actually, ferritin is a protein which is binding with iron. But anyway, the stored iron is called as a ferritin, Fe3+. Iron is stored in which form? Fe3+. Iron is absorbed in which form? Fe2+. Okay. Now, see, the point which I want you to know is, this transferrin, it's not only transporting the iron to the liver, it's not only transporting there, it is also transferring the iron to bone marrow. Why it is transporting the iron to the bone marrow? For hemoglobin synthesis. Okay, but in hemoglobin, which form of iron will be there? Sir, in your RBCs, in your hemoglobin, there will be Fe2+ form of iron. Fe2+ form of iron, not the Fe3+ form of iron. So in the hemoglobin, there will be Fe2+ form of iron. But once if it is converted into, because of some free radical injury, if Fe2+ form of iron in the hemoglobin, if the Fe2+ form of iron, if it is converted into Fe3+ form of iron, okay, then it is, tell me, good hemoglobin or bad hemoglobin? Then it is called as a bad hemoglobin, sir. Then such hemoglobin is called as methemoglobin. Then it is called as which hemoglobin? Methemoglobin, bad hemoglobin, it is going to cause anemic hypoxia. It is going to cause anemic type of hypoxia, sir, because it cannot carry oxygen, it causes hypoxia. So the iron which was supposed to be in Fe2+ form, if it is converted to Fe3+ form, it is called as a methemoglobin. Done. Now, what else you should know? Once you have sufficient amount of iron here, do you need any further iron absorption to the body? No. So the liver is going to produce a molecule called as hepcidin. Okay, liver produces what? Hepcidin. Hepcidin, what it will do? Hepcidin, it inhibits ferroportin. Okay, hepcidin inhibits ferroportin. So once the ferroportin is inhibited, now iron absorption to the blood decreases. Iron absorption to the systemic circulation, iron absorption to the body decreases. Okay, so what is hepcidin doing? Hepcidin is trying to decrease the iron. Always remember, hepcidin decreases iron absorption. True, hepcidin decreases iron absorption. From where hepcidin is produced? Hepcidin is produced from liver. Okay, sir, everything is good. Now, what they will ask you? One microbiology integration they will ask. That is, there is a parasite that is living here. Parasite. Okay, parasite, sir. See, what is this parasite doing? Sir, this parasite, the parasite, where is it living? First of all, this parasite, it is living in the duodenum. Now, as it is living in the duodenum, it interferes with which absorption? Iron absorption. So, what is the name of the parasite? The parasite which is living in the duodenum, it interferes with the iron absorption. That parasite is called as ankylostoma duodenale. Okay, that parasite is called as ankylostoma duodenale. So tell me, can I say something like this? Ankylostoma duodenale is going to decrease which absorption? Iron absorption. It's going to decrease the iron absorption. As it is living in the duodenum, it interferes with the iron absorption. Okay. What else you should know regarding the iron absorption is which substances, right? Substances decreasing iron absorption. Substances are decreasing the iron absorption. One is alkaline substances, like milk, tea, okay, phytates, tannates, okay, phytates, tannates, milk, tea, antacids, okay, hepcidin. All these fellows, whatever I have shown here, milk, tea, phytates, tannates, antacids, hepcidin, they all decreases the iron absorption to the body. Okay, then who increases the iron absorption? I have told you who increases the iron absorption. The iron absorption is increased by acid and vitamin C. The HCl, the acids, the HCl and vitamin C, it converts Fe3+ form of iron into Fe2+ form of iron. So Fe2+ form of iron will be readily absorbed. Okay, done. Now, after this, what else you should know? Regarding some GAT hormones. So some GAT hormones. What are they? See, in your duodenum, there are some cells called as, in your duodenum, there are some cells called as S cell and I cell. Okay, these are called as enteroendocrine cells. They are endocrine cells because they produce some hormones. Okay, enteroendocrine cells. S cells produce a hormone called as secretin. I cells produces a hormone called as cholecystokinin. Pancreas, sir. Simply remember it like cholecystokinin, cholecystokinin. What is the function of this secretin? Secretin function is to always decrease acid production. Secretin decreases the acid production. What about the cholecystokinin? cholecystokinin is going to cause a contraction of gallbladder. Contraction of gallbladder. So when the gallbladder is contracted, who will be released? Bile will be released. Bile release. Bile release. Okay, bile release. See, the one who causes the release of the bile, is called as cholecog. See, who is helping in the release of the bile? Cholecystokinin. So this cholecystokinin, it is called as cholecog. Why it is called as a cholecog? Because it causes the contraction of gallbladder and helps in bile release. The one who releases the bile is called as cholecog, and that is cholecystokinin. But tell me, what is the stimulus when S cells are going to produce secretin and when I cells are going to produce cholecystokinin? When? See, it's the acid from the stomach. Okay, acidic chyme. Okay, it's the acidic chyme. The acidic chyme entering into the duodenum is the acid which is going to stimulate the S cells to release secretin. And what is the stimulus for the I cell? The stimulus for the I cell is fat-rich food, mainly fat food. Okay, fat-rich food. It is the fats which are the stimulus for the I cells. So fat-rich food stimulates I cells, acid stimulates S cells. Acid stimulates S cells. So these are some important points which I want you to know. Now apart from this, next, the topic which I want you to know is gastric. The topic name is called as gastric emptying. So what is this gastric emptying? The concept of gastric emptying. See, the food from the stomach has to enter where? The food from the stomach has to enter into your duodenum. The food from your stomach has to enter into your duodenum. Okay, that process is called, the process of movement of food from the stomach into duodenum is called as gastric emptying. Now, which foods will move quickly? Which foods will move slowly? See, carbohydrates, carbs, have fast gastric emptying, sir. Very quickly. When you eat carbohydrate food, the carbohydrate food from your stomach will enter into your duodenum very, very quickly. Carbs, followed by proteins, followed by lipids or fats. Okay, so tell me, who is having fast gastric emptying? Which foods? Carbohydrates will have fast gastric emptying, followed by proteins, followed by fats. Okay, so this is one question. Next question is, sir, this gastric emptying, it is promoted by, who promotes it? Who makes this gastric emptying quicker? So gastric emptying, it's promoted by, hormone called as gastrin. Gastrin promotes the gastric emptying. But who inhibits it? Gastric emptying inhibited by. Okay, gastric emptying inhibited by secretin and cholecystokinin. So these two hormones, like secretin and cholecystokinin, other hormones are also there like amylin. But anyway, secretin, cholecystokinin, they inhibits the process of gastric emptying. They delays the gastric emptying. But who quickens this gastric emptying? Promoted by gastrin. I have told you from where gastrin is coming. Gastrin coming from G cells, secretin coming from S cells, cholecystokinin coming from I cells. Okay. Now in the duodenum, as I am discussing about duodenum, see, in the duodenum there are some cells called as there are some glands. Actually, there are some glands called as Brunner glands. In the duodenum, which glands are there? Brunner glands. What is the function of these Brunner glands? Brunner glands produce highly alkaline mucus. So what are Brunner glands now? Tell me. Brunner glands are nothing but the mucus producing cells. Where? In the duodenum. So these Brunner gland secretions, this mucus, whatever is producing, it is the most alkaline secretion. The highly alkaline secretion in the JT is the Brunner gland secretion. Okay. So this is having the highest pH. Okay. It's having the very high pH. So tell me, which secretion has the maximum pH? I should write the word, not just the high, the maximum, sir. Maximum pH means highly alkaline. Okay, maximum pH, highly alkaline substance. Which substance? The Brunner gland secretion. From where they are coming? Brunner glands in the duodenum. Okay. So highly alkaline secretions. Okay. If you don't find Brunner glands in the answer, if you don't find highly alkaline secretion, Brunner glands option is not there. If it is not there, then you can answer. Then the second best answer is pancreatic secretions. So pancreatic secretions are also highly alkaline. First highly alkaline secretion is bladder gland secretion. If you don't find it, answer pancreatic secretions. Okay, done. Now, after this, let's see the other important points which you should know for your exam from the JAT sir. Other important points is the topic of pancreas. Okay, the topic of pancreas. See, pancreas is going to produce some enzymes. Which enzymes? Pancreas is producing all enzymes sir, for carbohydrates, proteins as well as fats. Pancreas produces pancreatic, amylase for the digestion of carbohydrates. Pancreas produces trypsinogen, chemotrypsinogen. Okay, this is trypsinogen, chemotrypsinogen, and there are other enzymes like procarboxypeptidase. Okay, let me write here procarboxypeptidase. See, these are the enzymes. These are the enzymes for the digestion of proteins. And fats को digest करने के लिए, what are the lipases? One important lipase that I am telling you, colipase. Okay, colipase. This is the MCQ. So, colipase is produced from, colipase is present in pancreatic juices. Pancreatic juices. That's the MCQ. That's only for that MCQ I am telling you this topic. Pancreas, colipase is produced from pancreas. It's a lipase. It's a lipase. Apart from that, sir, here you can see trypsinogen, chemotrypsinogen. These are inactive in nature. They are inactive. You need to make it active. You need to make it active. Okay. So, who will convert trypsinogen into trypsin? So, right, the trypsinogen need to be converted into trypsin. Okay, it need to be converted to trypsin. And chemotrypsinogen need to be converted into chemotrypsin. Who will convert that? So, trypsinogen is converted into trypsin with the help of an enzyme called as enterokinase. Okay, let me write the full form. Enterokinase. Or sometimes they will use the word enteropeptidase. Enterokinase or enteropeptidase. Okay, so from where this enterokinase or enteropeptidase is produced? That's the question, sir. Duodenum. It's a duodenum. So the enterokinase is produced from. This is a question which was asked in the FMGE exam. Enterokinase or enteropeptidase, it is produced from duodenum. This enterokinase is converting trypsinogen into trypsin. Okay, then what about the chemotrypsinogen to chemotrypsin? That will be done with the help of trypsin. So it's the trypsin. It is this trypsin, sir. It is this trypsin converts the chemotrypsinogen into chemotrypsin. Done. Pepsinogen to pepsin. Pepsinogen to pepsin with the help of HCl. Don't forget. Done. Now after this, let's discuss about the JAT contractions. Contractions in the JAT. Okay. The contractions in the JAT. This topic is a 5-star topic. Super high yielding topic. Before going to the exam, if you have to go through one topic, there's a JAT contractions. So the JAT contractions, see, whenever a person is taking the food, fed state, during fed state means the person have taken the food. See, two types of contractions can occur. During fed state, two types of contractions can occur. One is called as peristalsis. One is called as what? Peristalsis. And other is segmentation. So what exactly is peristalsis? What exactly do I mean by peristalsis? Peristalsis means, see, here is your intestine, here is the food bolus present, here is the food bolus present. So the proximal segment is going to contract like this. To prevent the regurgitation, the proximal segment is going to contract. And what happened to the distal segment? The distal segment will undergo relaxation. It will undergo relaxation to welcome the food. So this is a type of JAT contraction where a proximal segment is contract and distal segment is relaxed, pushing the food forward. Such type of contraction is called as peristalsis. Okay. Now question is, who is causing this contraction of the proximal segment? Which neurotransmitters are responsible for the contraction of proximal segment? That is acetylcholine as well as substance P. So acetylcholine and substance P, they are causing the contraction of the proximal segment. And who is responsible for the relaxation here? Relaxation of this part of the intestine is done with the help of vasoactive intestinal peptide, nitric oxide and vasoactive intestinal peptide. So tell me, what is the final role of peristalsis? The main function of the peristalsis is for the movement Okay, it's for the movement of the food. It's for the movement of the food, forward movement. Okay, forward movement. So arrow is important. So the arrow should be moving forward. The foot should be moving forward. Then what is segmentation? See, in segmentation, both the proximal segment is contracted and distal segment is contracted. Both the proximal as well as the distal segments are contracted like this. Okay. So here the food is present. Here there is food. Okay. Now what happens? So gradually the food will be mixed with the enzymes. Here the food will be mixed with the enzymes. Okay, food is getting mixed with the enzymes. So both the proximal segment, distal segment are contracting and the food is getting mixed with the enzymes. So the word that I will use here is segmentation is a mixing movement. Mixing movements. So what happens at the end of the day? So this food, whatever is present over here, finally at the end of the day, look what is happening. The food is getting, what is happening in the food? The food is getting digested. Okay, the food is getting digested and the undigested food will undergo peristalsis. It will go forward. Okay, so the food is getting digested. So segmentation is for digestion. Okay, segmentation is actually the major movement. Segmentations are the major movements. So segmentation is for the digestion. It's a mixing kind of movement, and peristalsis is the propulsion movement. It's for the movement of the food. It's for the movement of the food. Okay, so these are the two types of GAT contraction that happens during fed state. Means when you are actually eating. But during fasting state, will your GAT contract? I am asking you, during fasting state, will your GAT contract? Yes, even during fasting state, your GAT is still contracting. So those contractions are called as migratory motor complexes, MMCs. Okay, so why sir? Why during fasting state your GAT is contracting? Because these migratory motor complexes, they will clean the GAT. Okay, GAT. So that's why these migratory motor complexes are called as broomstick of GAT. Broomstick. Okay, broomstick of GAT. They are called as a broomstick of GAT or housekeeper of the GAT. Sir, what is the frequency of this migratory motor complex? How much frequently this migratory motor complex will come? So one migratory motor complex will come in every 90 minutes. This is the frequency. And with how much speed these contractions will occur, sir? With how much speed this migratory motor complexes will come to clean the GAT? If there is any leftover food, it have to be removed, no? So the migratory motor complexes, what is the velocity, the frequency I have told you? 1 in every 1.5 hour. 90 minutes means 1.5 hour. That is 5 centimeters. It will move, this migratory motor complexes, it will move with the speed of 5 centimeters per 1 minute. And migratory motor complexes, it is starting with which letter? M. So it is motilin mediated. It's mediated by a hormone called as motilin. Okay, it is mediated by a hormone called as motilin. Migratory motor complex, motilin mediated. Done. Now let me tell you some important points about the motilin. Motilin is produced by which cells of your GAT? Mo cells, not M cells, Mo cells. Okay. Now where motilin is going to act? See, this is your GAT cell. Okay, let's say this is your intestine. Here are the smooth muscle cells. Let's say here are the smooth muscle cells. These are the smooth muscle cells surrounding your GAT. Now here are the receptors. Which receptor? This is a motilin receptor. Okay, this is a motilin receptor. So when motilin comes and binds here, what happens? The muscle will undergo contraction. Okay, so what happens when the muscle is contracted? There will be migratory motor complexes. There will be contractions in the GAT. That will cause GAT contractions. Okay, GAT contractions. So what I am trying to say this motilin binds with its receptor, so causes the GAT contractions. But the point which I want you to know for your exam, sir, these motilin receptors, they are also stimulated by a drug, sir. There is a drug, okay, which will stimulate the motilin receptors. What is this antibiotic drug? That is called as erythromycin. So this erythromycin is a drug which will stimulate the motilin receptors. So can I say something like this? What is the side effect of erythromycin? Sir, erythromycin is an antibiotic. It kills the bacteria, okay. But unnecessarily it is stimulating the motilin receptors. So the side effect of erythromycin is diarrhea. Okay, the side effect is diarrhea, sir. Done. So motilin receptors are stimulated by erythromycin. So erythromycin causes contractions, GAT contractions, heavy GAT contractions that can lead to diarrhea. So that's why erythromycin can be used. Erythromycin, let me write here. erythromycin can be used in treatment of, okay, it's used in the treatment of diabetic gastric paralysis. Diabetic gastric paralysis. Okay, it's used in the treatment of diabetic gastric paralysis. Means gastric paralysis, wherever you see the word gastric paralysis means what? No GAT contraction, GAT is not contracting. So how can you make the GAT to contract? How can you make the GAT to contract? By giving erythromycin. The moment you give the erythromycin, yes, the motility receptors are stimulated and GAT contractions will occur. So for the treatment of gastric paralysis or paralytic ileus, paralytic ileus. So we can use erythromycin. Erythromycin can be used in the treatment of gastric paralysis and paralytic ileus. So with this, what we have completed is the GAT contractions topic completed. Now the last thing that I want you to teach in the GAT is some reflexes. Okay, reflexes in GAT. What are the two reflexes that I want you to know for your FMG exam? First reflex is called as enterocolic reflex. See, sir, not enterocolic reflex, sorry sir, it's a gastrocolic reflex. Gastrocolic reflex. Gastrocolic reflex. See here, what does it mean by the word gastro, stomach? Here, colic means colon, sir. Okay, gastrocolic reflex. What does it mean by the word gastrocolic reflex? Any activity in the stomach. Okay, the activity in the stomach is going to cause the colon contractions leading to defecation. Seen in infants. It is seen in infants, sir. Whenever an infant is going to take the breastfeeding, okay, whenever the infant is going to take the meal or breastfeeding, so the baby is going to pass the feces out. Okay, the baby is going to pass the feces after taking a meal. So what I am saying is gastric activity leading to contractions. Where? Contractions in colon. Contractions in colon leading to what? Defecation. Leading to defecation. So this reflex is called as the gastrocolic reflex, especially seen in children or infants. Okay. The next reflex is enterogastric reflex. Enterogastric reflex. See, enterogastric reflex, what I want you to know is, sir, here the name entero means what? Your intestines. Your intestines are talking with stomach. Gastric means stomach. So what is enterogastric reflex? Whenever acid enters into your duodenum, acid into intestines or duodenum, what your intestines will produce? Secretin. What the secretin will tell to the stomach? Secretin will tell to the stomach, don't send acidic food into the duodenum quickly. Or the secretin, what it will do? It will decrease the acid production in the stomach. It will first decrease acid production in the stomach. Okay, in the stomach it is happening. And the secretin is going to delays or decreases gastric emptying. So this is called as enterogastric reflex. Means once the acidic food or acidic chyme, once it enters into the intestines, now intestines, by producing hormones like secretin, they are causing the reflux, a decrease in the acid in the stomach, and they decreases the process of gastric emptying. This is called as enterogastric reflex. Okay, so these are the two important the reflexes which I want you to know in your the GAT physiology. And last but not least, actually I have to teach you in the beginning of the GAT physiology, but let me tell you here itself, no issue. See, there are 4 layers in the GAT, no? Okay, GAT contains how many layers? In GAT, it has 4 layers. Okay, what are the 4 layers of the GAT? You know, the innermost layer is called as mucosa. Okay, mucosa. Second layer is called as the submucosa. Third layer, muscularis. And fourth layer, serosa. So these are the 4 layers, no? Now, what are the important MCQs that you should know for your exam is, sir, submucosa, in the submucosa of the GAT, in the submucosa of your GAT, there is a plexus called as a Meissner's plexus. Meissner's plexus. Okay, a network of neurons, sir. Plexus means a network of neurons called as the mesenteric plexus. And in the muscularis, which plexus will be present? Sir, in the muscularis, there will be myenteric plexus present. Myenteric plexus. Myenteric, also called as Auerbach. Auerbach's plexus present. Okay, myenteric as well as Auerbach's plexus present. What is the function of this mesenteric plexus? Sir, mesenteric plexus helps in secretions. Okay, the mucus secretion in the GIT. The secretions are with the help of the mesenteric plexus. Then what is the function of the Auerbach plexus? The function of the Auerbach plexus is the contractions. Okay, the contractions in the GIT. Done. So if they ask you what is the submucosal plexus, the submucosal plexus is the mesenteric plexus. And what is the muscularis plexus? The muscularis plexus is the myenteric plexus. Okay. And one more important point is the submucosa is considered as the strongest layer of the GIT. It's considered as the strongest layer of the GIT. And serosa, the important point about the serosa is absent. Absent in esophagus. Okay, serosa is what? Serosa is absent in the esophagus. Done. So these are some important points which I want you to know regarding GIT, sir. With this, the topic of GIT is completed. The topic of GIT is completed. Everything I have explained you. Okay, done. Now after this, let's start with the different system. Okay, let's start with the different system. Let's start with the renal physiology, sir. Okay, renal physiology. Because you know, in the last FMGE exam, renal physiology, 6 questions came from the renal physiology, sir. Okay, 5 direct questions, 1 indirect question came. So 6 questions have already asked from the renal physiology in the last session. I'm not saying in every session 6 questions will come. No, I'm not saying that. In the recent session, 6 questions came from the renal physiology. That's a very important chapter, renal physiology. See, in renal physiology, that's all about the kidneys. No, what are the important topics that you should know? Let me tell you. First, functions of the kidneys. Kidneys produces, okay, the kidneys produces, first function number 1, erythropoietin. Erythropoietin. Every student knows erythropoietin is going to increase your RBC count. But that's not the question. See, apart from kidneys produce erythropoietin. First of all, tell me, erythropoietin is produced from which cells? Which cells? Which cells produce erythropoietin? First, tell me this. Erythropoietin is produced from cells called as interstitial. Interstitial cells. Interstitial cells of peritubular capillaries. Interstitial cells of peritubular capillaries produces erythropoietin. Interstitial cells of peritubular capillaries produces the erythropoietin. Okay, done. Next, second question is, in the recent INSET exam, the question which was asked is, sir, erythropoietin is not only produced from the kidneys. Erythropoietin is also produced from liver, produced from uterus. It is also produced from brain. Okay, it is also produced from the oviducts or fallopian tubes, you can say. But mainly, this is the question which was asked. Erythropoietin is not only produced from the interstitial cells of the peritubular capillaries of the nephrons, not only produced from the kidneys, but erythropoietin is also produced from liver. Okay, sir. Next step, in your kidneys, there are nephrons present. Okay. Nephrons, they contain proximal convoluted tubule, the first part. Okay, proximal convoluted tubule. Proximal convoluted tubule, one important event will happen, sir. One important event happens in the proximal convoluted tubule of the nephrons. Do you know what is that important event? That is activation of what? Activation of vitamin D. So activation of vitamin D occurs in which part of the nephron? Proximal convoluted tubule, with the help of an enzyme called as alpha-1 hydroxylase. Okay, so what is the enzyme required for the activation of vitamin D? For the activation of vitamin D, you require alpha-1 hydroxylase. But this alpha-1 hydroxylase activity, it is under the control of which hormone? Which hormone is responsible for the activation of this alpha-1 hydroxylase so that the vitamin D will be activated? So, right, alpha-1 hydroxylase, it is under the control of the parathyroid hormone. So, it's the parathyroid hormone which is activating the alpha-1 hydroxylase. So, it's the alpha-1 hydroxylase activates the vitamin D. So, vitamin D will increase your calcium levels in the body. Okay, so this is also very, very important. Alpha-1 hydroxylase or the vitamin D activation is controlled by which hormone? Parathyroid hormone. Parathyroid hormone. Very, very important. Okay, done. where this activation is occurring in the PCT. Next, your kidneys, they contains nephrons. Nephrons contains a cells called as the JG cells. JG cells of the nephrons. See, these JG cells of the nephrons, they produces an enzyme called as renin. See, this renin is going to activate a pathway called as RAS pathway. Okay, renin angiotensin aldosterone system, RAS pathway, sir. Now, what is the one function of the RAS pathway? The one function of the RAS pathway is to increase your BP. RAS pathway is to increase your BP, is to increase your blood pressure. Next, function number 4 of the kidneys. The function number 4 of the kidneys is to maintain the acid-base balance. Acid-base balance. Acid-base balance. So, acid-base balance, or I can say pH. What is the normal pH? The normal pH is 7.35 to 7.45. Let's say round figure, 7.35 to 7.45. Always your pH should be in the range of 7.35 to 7.45. Always it should be in the range of 7.35 to 7.45. Less than 7.35 causes acidosis. Less than 7.35, what happens? That will cause acidosis in the body. Or more than 7.45 will cause alkalosis. Okay, both are bad. Both can kill the patient. Acidosis, alkalosis, both can kill the patient. So always you need to take care about your pH. So who is taking care about your pH? 3 systems, sir. The acid-base balance is happening with the help of 3 systems in your body. One is kidneys. Okay. Apart from kidneys, lungs, as well as the buffer system. There is something called as buffer system. Okay. So buffers, lungs, and kidneys. Buffers are considered as the first line of regulation, lungs considered as the second line of regulation, kidneys considered as the third line of regulation in the maintenance of acid-base balance. So who are the 3 systems? What are the 3 systems maintaining our pH? Buffers, lungs, kidneys. Buffer, lungs, and kidneys. Okay, so these are the 4 important functions of the kidneys. Okay, 4 important functions of the kidneys. Okay, now here itself I want you to know, sir, in which conditions erythropoietin is produced? What is the stimulus for the release of erythropoietin? It is hypoxia. Okay, so hypoxia is going to stimulate the release of erythropoietin, so RBC production increases. But in which condition you will have hypoxia, sir? Where you will get the hypoxia? High altitudes. Okay, whenever the person is going to the high altitudes, there will be hypoxia seen. Hypoxia is going to stimulate the erythropoietin release, so that the person is going to have more RBC. Now he will produce more RBC to get the oxygen, to capture the oxygen. Okay, next. Now, let me discuss the different parts of the nephron. Okay, one part of the nephron and see what are the important points. Okay, let's draw the first part of the nephron. That is the Bowman's capsule. Let's say here is the glomerular capillary. Okay, here is one glomerular capillary. Now down to the glomerular capillary, what do we have? We are having the Bowman's capsule. So let's only concentrate on this part of the nephron first. Okay, on this part of the nephron, which is the Bowman's capsule, or you can call it as a glomerulus. This area is called as what? Glomerulus. Now the fluid should have to filter like this. Okay, the plasma have to filter like this, right? Now how many structures are there in between? See, here are the endothelial cells. These are the endothelial cells. Now the endothelial cells, in between them, they are having gaps, no? These gaps are called as what? These gaps are called as fenestrations. So first gap, okay, through which the plasma can be filtered. These gaps are called as what? Fenestrations. Fenestrated capillaries. These are the fenestrated capillaries. Okay. Now these endothelial cells, they are lying on. Okay, they are lying on a membrane, sir, here. This membrane which I am showing here in the pink color, this is called as the glomerular basement membrane. Okay, here in the pink color, this membrane which I am showing here, this is called as the glomerular basement membrane. The glomerular basement membrane is made up of type 4 collagen. Collagen type 4, sir. Collagen type 4. Okay. And one more thing, the glomerular basement membrane, it is having which charge? It is having negative charge. The glomerular basement membrane will be having negative charge. Okay, so that negative charge is because of the glomerular basement membrane is having very, very important point, negative charge. Okay, that negative charge of the glomerular basement membrane is because of presence of some important proteins over there. Because of presence of some important negative charge proteins, it is getting the negative charge, sir, like sialoproteins and heparan sulfate. Okay, heparan, sulfate and cyanoproteins. Next point is, sir, are you able to appreciate these cells which I am showing here in the green color? See, these cells which I am showing here, okay, they are having a foot-like processes. They are having what? A foot-like processes. So these cells which I am showing here, these are called as podocytes. Podocytes. In between the podocytes, there are gaps present. These gaps are called as slit pores. Sir, within the slit pore, there are some structures present. There is a structure present. This structure which I am showing here in the orange color, that is called as a slit diaphragm. Slit diaphragm. Okay, slit diaphragm. Now, slit diaphragm is very, very important because slit diaphragm is made up of some proteins, sir. What are the proteins which are forming the slit diaphragm? Nephrin, podocin. Okay, nephrin and podocin are the proteins present in the slit diaphragm. See, nephrin is a protein. Podocin is a protein. So, what are the genes? Nephrin, it is coded by a gene called as NPHS1. Podocin is coded by a gene called as NPHS2. Okay, NPHS1 and NPHS2. Okay, these are the genes. Let me come back to the genes topic in a minute. But tell me, sir, here is a substance X. Let's say here is a substance X, sir. X substance. Now this substance have to filter into the Bowman's capsule. It have to filter into the Bowman's capsule. So now tell me, it have to cross how many layers? It have to cross first endothelial layer, glomerular basement membrane. Later it have to cross the podocytic layer. Okay. So now tell me, how many barriers are there? Okay, how many barriers are there? There are 3 barriers. This is called as glomerular filtration barrier. Okay, glomerular filtration barrier. Okay, glomerular filtration barrier. Okay, glomerular filtration barrier. Sir, now tell me, glomerular filtration barrier is made up of how many structures? Sir, it is made up of 3 structures. Okay, it is made up of how many structures? 3 structures. What are the 3 structures? Can you tell me? The 3 structures include endothelial layer. Second structure is glomerular basement membrane, and third layer is podocytic layer. Now my question to you, sir, out of these 3 layers, there are 3 gates, sir. These are the 3 gates: endothelial, glomerular basement membrane and podocytes. So who is the real gate? So who decides whether the substance is going to be filtered or not? So minimum gap, the one who is having the minimum gap, is the one who determines the filtration of substance. Do you know where the minimum gaps are there? It's a slit diaphragm. So slit diaphragm is having a minimum gap, sir. So let me write here slit diaphragm. Okay, let me write here itself. Slit diaphragm has minimum gap. So it's a real barrier. Do you know what is the gap of slit diaphragm? It's going to be somewhere around 4 to 14 nanometers. Okay, very small gaps. The size is not important, but the point which I want you to know is the slit diaphragm, which contains the minimum gaps. Okay, minimum gaps. Next, tell me, if this slit diaphragm, if the slit diaphragm is damaged, okay, large substances will start to filter now. See, it's a slit diaphragm which is the major gate. It's the main gate for the filtration of substances. It's a main barrier. Now you tell me, if this slit diaphragm, if it is affected, now proteins will start to come out. Big substances will start to filter. So now what I am saying is concentrate here on this NPHS1 and NPHS2. See, if NPHS1 is mutated, which structure will be affected? Slit diaphragm will be affected. Slit diaphragm affected. So that is going to cause a protein loss, proteinuria, called as congenital nephrotic syndrome. Also called as Finnish type of nephrotic syndrome. What is nephrotic syndrome? Nephrotic syndrome means more than 3.5 grams of protein lost in a day. If in a day, if you lose more than 3.5 grams of protein in the urine, if you lose this much amount of protein in a day, that is called as a nephrotic syndrome. Okay. So now tell me, congenital nephrotic syndrome. Congenital nephrotic syndrome is due to mutation in NPHS1 gene mutation. Now NP NEETPG gene mutation is also going to affect the slit diaphragm. That will cause a nephrotic syndrome, sir. Again, that is going to cause a nephrotic syndrome. That is called as steroid resistant nephrotic syndrome. Steroid resistant nephrotic syndrome. So now tell me, steroid resistant nephrotic syndrome is due to mutation of NPHS2 and steroid sensitive. The first one is a steroid sensitive cell. Okay, this congenital nephrotic syndrome, it is easily treated with steroids. So that is steroid sensitive, but the NPHS2 gene mutation is going to cause a steroid resistant. First one is a steroid sensitive, second one is a steroid resistant. Okay, so done with this. The important points regarding the glomerular filtration barrier completed. One more point is there. That is, sir, glomerular filtration barrier is having which charge? Negative charge. So now tell me, which charged substances are easily filtered? See, if a substance is a positively charged substance, that will be attracted by the negativity and it is easily filtered. But if a substance is a negatively charged substance, if a substance is a negatively charged substance, that will be repelled away. So, order of filtration. Order of filtration is, sir, positive charged substances are better filtered when compared to neutral, when compared to negative charge. Okay, so which substances are easily filtered? Positive charged substances are better filtered when compared to neutral, when compared to negative charged substances. This is the order of filtration. Okay, next up. What else you have to know? Some basic points, let me teach you. Some basic points in the beginning itself. See, how much is your renal blood flow? How much blood will go to your kidneys? Renal blood flow, sir. Renal blood flow. How much blood do you think will go to the kidneys? Every minute, per minute. Almost 1.2 liters. Okay, 1.2 liters of blood will go to both the kidneys together. Okay, so 1.2 liters. MCQ. Out of this blood, how much is the renal plasma flow? Total blood is okay, 1.2 liters. How much is the renal plasma flow, sir? Renal plasma flow. Renal plasma flow is 625 ml per minute. And in that renal plasma flow, out of that 625, how much is actually filtered into the Bowman's capsule? How much is actually filtered, sir? That is the glomerular filtration rate. Glomerular filtration rate is 125 ml will be filtered every minute out of 625. So can I say something like this? Out of 625, okay, out of 625, how much is filtered? 125 is filtered. So this is called as filtration fraction. Out of 625, 125 is filtered. So how much is filtration fraction? 20%. That is GFR divided by renal plasma flow. GFR divided by renal plasma flow is called as a filtration fraction 20%. Done. Okay, done. Now this was the question which was asked in the recent FMGE exam. GFR, how much is the GFR? 120 ml per minute. 125 ml per minute. 125 ml per minute is the GFR. Okay. Next. What I should teach you is, guys, first let's go to let me draw here a nephron. Let's write all the important points here itself. Here is the Bowman's capsule. Here is the proximal convoluted tubule. Let me draw the proximal convoluted tubule like this. Okay. Now the proximal convoluted tubule, it continues as what? The proximal convoluted tubule, it continues as the descending limb of loop of Henle. Okay, here it is the descending limb of loop of Henle, sir. Okay. Now this descending limb of loop of Henle, it continues as ascending limb of loop of Henle. So here is the ascending limb of loop of Henle. Now this ascending limb of loop of Henle, it further continues as distal convoluted tubule. Okay, here is the distal convoluted tubule. Now this distal convoluted tubule, it continues as collecting duct. Okay, here is the collecting duct. So this is our nephron. Let's say here is our nephron. Now, let's see important points about all the regions one by one. What are the important points which you need to know for your exam? The minimum base points first I will tell you. Later I will go into the concepts also. First, PCT, proximal convoluted tubule. See, in the proximal convoluted tubule, first there is brush border. Okay, there is a brush border. In the proximal convoluted tubule, what kind of epithelium will be there? Brush border epithelium will be there. Brush border epithelium will be there. Okay. Point number 1. Second point. Sir, in the PCT, maximum reabsorption I should say. Maximum reabsorption occurs. Maximum reabsorption occurs in PCT. Maximum reabsorption of substances. Okay, maximum reabsorption of substances occur. Except one substance. Most of the substances are maximally reabsorbed in PCT except one. Who is that except? Except magnesium. Except magnesium, all other substances are maximally reabsorbed in PCT. So, how much substances are reabsorbed, sir? In the PCT, let me tell you how much 70% water will be reabsorbed, 70% sodium chloride will be reabsorbed, sodium as well as chloride, 70%, sorry not 70%, 80% bicarbonates will be reabsorbed, and 100% glucose, 100% amino acids will be reabsorbed. Okay. So these are the substances which are reabsorbed in the PCT. 100% glucose, these are the MCQs. 100% glucose, 100% amino acids. Okay. Now, let me tell you what else you should know regarding the PCT, sir. See, regarding the PCT, see, what happens to the urine? Say here there will be urine, no? Will the urine will be concentrated or diluted? Urine osmolarity, will it increase or decreases? What is the what is the normal plasma osmolarity? The normal plasma osmolarity is 300 milliosmoles. Okay, 300 milliosmoles. Now, I am asking, sir, the same plasma is filtered here. Here it is 300. Here it is 300. In Bowman's capsule it is 300. So, how much will be the osmolarity of the fluid in the PCT? The urine osmolarity, will it increase or will it decrease? Will the urine be concentrated or diluted? Answer is right. First MCQ number 1. Urine osmolarity in PCT is same, not changed, unchanged. It is still 300 or isotonic to plasma. Isotonic to plasma. Okay, isotonic to plasma. Understand? It's not changing. It's still 300. It's still 300 because say same amount of water, same amount of solute. Sodium is a major solute. So water is reabsorbed and sodium is reabsorbed in same proportion. Both the solute as well as the solvents are reabsorbed in the same proportion. So the urine osmolarity will not change. It will be again 300 here. 300. It's not changing. Next, what else you should know? Sir, water reabsorption PCT. Water reabsorption PCT, does it require any hormones? No hormones required. So, second MCQ is, it is obligatory. Obligatory water reabsorption. Okay, so what kind of water reabsorption occurs in PCT? It's called as the obligatory water reabsorption, sir. Obligation means must ensured, must ensured. Wherever sodium goes, see, 70% sodium reabsorbed, so 70% water should reabsorb. So it's not a facultative water reabsorption. It is the obligatory water reabsorption. No hormones are required. 70% maximum water reabsorption occurs in PCT. Okay, so this is the first question which I want you to know. Urine osmolarity, isotonic to plasma. Second one, obligatory water reabsorption. So what else you should know? Sir, the 100% glucose reabsorb, no? 100% glucose reabsorb. So glucose reabsorption occurs in PCT with the help of, okay? So let me tell you, the glucose reabsorption, okay, glucose reabsorption in PCT occurs with the help of a transporter. What is the name of the transporter, sir? The name of the transporter is called as SGLT2. SGLT2. So SGLT2 means SGLT2. So what is the transporter with which the glucose will be reabsorbed in the PCT? The name of the transporter is called as SGLT2. So from now onwards, you should always say, so the glucose is reabsorbed, yes, along with the sodium. See, the glucose G for glucose, sir. The glucose reabsorption is linked with, L for linked. Glucose reabsorption is linked with the sodium. So glucose is reabsorbed in the PCT, yes, along with what? Sodium. So right, so SGLT2 means the glucose is reabsorbed along with sodium, So two substances will be reabsorbed together. Sodium will be reabsorbed along with the glucose. So that's why it is called as SGLT2, sodium glucose linked transporter, or sodium glucose co-transporter. Co-transport. Okay, it is sodium glucose co-transport. Sodium glucose co-transport. Now the question which I want you to know is, see, wherever you see the word, lifelong I have told you to remember, wherever you see the word gluts, facilitated diffusion, pumps are ATPases, primary active transport. From now, whenever you see two substances going together, that is called as a symport or co-transport. So all of them are examples of symports or co-transporters are example of what? They are all examples of a secondary active transport. They are example of what? Secondary active transport. So sodium is reabsorbed along with the glucose. So it's an example of what kind of transport? Secondary active transport. So glucose reabsorption in PCT is an example of secondary active transport. Okay, done. So this is the third question which I want you to know. Maximum glucose, how much you can reabsorb? Sir, every minute, how much maximum glucose that you can reabsorb in the PCT? Everything has a limit, no? Everything has a limit. How much maximum glucose that you can reabsorb in a PCT in a minute? That is transport maximum value. The transport maximum value for glucose is 375 milligrams per minute. This is the maximum that you can reabsorb. This is the fourth MCQ that I want you to know. Okay, this is the fourth MCQ. Now, so these are the important points which I want you to know regarding the PCT. In PCT, maximum reabsorption, maximum water reabsorption, obligatory water reabsorption, glucose 100% reabsorbed with the help of SGLT2. That is an example of secondary active transport. Maximum glucose that can be reabsorbed is 375 milligrams per minute. Done. Now, let's talk about the descending limb of loop of Henle. See, this is a descending limb of loop of Henle. No? In descending limb of loop of Henle, I am telling you, see, only who will be reabsorbed? Only water will be reabsorbed, not solutes. Only water will be reabsorbed. Okay, not the solutes. So only pure water is getting reabsorbed. As the water is getting reabsorbed, what will happen to the urine? The urine is getting concentrated. Okay, so that's why the descending limb of loop of Henle, the point which I want you to know, right, it is only permeable to, only absorbs water, or you can say only permeable to water, impermeable to solutes. Impermeable to solutes. What is it doing to the urine? Sir, it is concentrating the urine. So it's called as a concentrating segment. It is called as what? Concentrating segment. You understand? So descending limb of loop of Henle is going to help in the reabsorption of water. It's concentrating the urine gradually. So it is called as a concentrating segment of the nephron, sir. Concentrating the segment. It's concentrating the urine. Okay, done. That will be enough regarding the descending limb of loop of Henle. Now, where is the urine going? The urine is going up. Okay. Now, we are going into this ascending limb of loop of Henle, sir. This area which I am pointing right now. This is the ascending limb of loop of Henle. In the ascending limb of loop of Henle, there is a thin ascending part as well as a thick ascending part. So this is called as a thick ascending limb, and down one is called as a thin ascending limb. First point number 1. See, here, let's say I am showing you one cell, sir. One cell. Okay, there is a transporter. Okay, there is a transporter. This transporter is helping in the reabsorption of sodium, potassium, as well as 2 chloride ions. So what is the name of this transporter? The name of this transporter is called as sodium potassium 2 chloride, NKCC, sir. Sodium potassium 2 chloride, NKCC. Sodium potassium 2 chloride importer. So now tell me, what is the location of NKCC? Sodium potassium 2 chloride importer is located in TAL, thick ascending limb. Now, NKCC, what is it doing? Sir, it is removing the ions, sodium, potassium, chloride from the urine. It is removing the ions. So tell me, the ascending limb of loop of Henle, this ascending limb of loop of Henle, is it permeable to solutes or solvent? Is it reabsorbing solutes or is it reabsorbing water? Solutes, no? So yes, the TAL only permeable to, right? Okay, thick ascending limb, only permeable to water. Sorry, only permeable to solutes. Okay, impermeable to water. Impermeable to water. Okay, so now tell me, sir, from the urine, what you are removing? You are removing sodium. You are removing the sodium, sir. As you are removing the sodium out of the urine, diluted from 1200 milliosmoles. Now the urine, it is getting diluted, sir. Now it becomes 1000. It becomes 800 here. As it going further up, it becomes 600. It becomes 500. Later 200. Later 100. So as the urine is moving up in the ascending limb of loop of Henle, the urine is gradually getting diluted. The urine is getting gradually diluted because you are removing more and more sodium out of it. You are removing sodium, potassium, chloride out of it. So that's why the ascending limb of loop of Henle, this ascending limb of loop of Henle is considered as a diluting segment of the urine. Diluting segment. It's called as what? Diluting segment. Done. Now, 3 important points I have told you regarding TAL. TAL, first important point, number 1, it is permeable to solutes, not to solvents. Second one, it's a diluting segment. It's a diluting segment. Third point, it contains a transporter called as NKCC, sodium potassium 2 chloride importer. Okay. Now tell me, say this sodium potassium 2 chloride importer, NKCC, let me write here. NKCC. It is inhibited by drugs. It is inhibited by drugs. Which drugs, sir? Which drugs? Loop diuretics. Loop diuretics. Have you ever heard about furosemide, torsemide? Okay, drugs. Loop diuretics, what they will inhibit? They will inhibit rich transporter, sodium chloride, sodium potassium 2 chloride importer. Okay. Now time bad, if this NKCC transporter, if it is mutated by birth, that will cause a disease. If this NKCC transporter, if it is mutated by birth, then that is going to cause a disease called as a Bartter syndrome. Bartter syndrome. Okay, autosomal recessive disorder, Bartter syndrome, sir. Okay, Bartter syndrome. So now tell me, in Bartter syndrome, which transporter is affected? NKCC. Loop diuretics, which transporter will be inhibited? NKCC. So always remember, see, Bartter syndrome may and loop diuretics usage may, in both the conditions, is the same transporter is affected. So these two, can I say something like this? Bartter syndrome resembles. Clinical features. The clinical features resembles loop diuretic usage. Okay, so Bartter syndrome, how it resembles? It resembles loop diuretic overusage, sir. It resembles loop diuretic overusage. Done. Now, any other important point which I want you to know is, sir, that ascending limb of loop of Henle. This ascending limb is there, no? The thick ascending limb. The thick ascending limb of loop of Henle, sir, it is having which charge, sir? They will ask you. It is having positive charge. Which charge will be present? Positive charge. Why positive charge will be present? Sir, because here potassium will be secreted. So write in TAL, thick ascending limb, which charge? There will be positive charge, positive luminal charge. Due to, why? That is due to potassium secretion. So what is the importance of that positive charge, sir? Okay, positive charge is there. That is due to potassium getting secreted. Potassium will be secreted into, see, again I am telling you, potassium is excreted or secreted into TAL. So potassium is a positive charge. So a TAL will be having a positivity. So what is the importance of that positivity? See, this positivity, okay, what do you know it will do? So do you think now calcium is coming here? Magnesium is coming here. Do you think this Ca2 plus and Mg2 plus, they are positive charges? What will happen? The positive charges will repel the positive charges. So do you think this calcium and magnesium, they can go further up into the ascending limb of loop of Henle? No. So they will be reabsorbed. So that positivity will help in the reabsorption of calcium and magnesium reabsorption. Okay, understand? So now tell me, what is the importance of this luminal positivity? That luminal positivity helps in absorption of calcium and magnesium. Okay, done. So with this, what we have completed, ascending limb of loop of Henle, important points completed. Now let's discuss about the distal convoluted tubule. Now let me discuss about the distal convoluted tubule. Okay, see, this is cell where it is present in the distal convoluted tubule. Okay, Now here there is a transporter, sir. Here there is a transporter which is helping in the reabsorption of sodium as well as chloride. Sodium as well as chloride. Okay. So what is the name of this transporter called as? That is called as a sodium chloride symporter. That is called as what? Sodium chloride symporter. Now this sodium chloride symporter, is there no? The sodium chloride symporter. See, where is it located? First question number 1, it is located in DCT. The sodium chloride symporter, it can be inhibited by drugs. It can be inhibited by some drugs called as, right, sodium chloride symporter, it is inhibited by drugs called as thiazides. Thiazides inhibit sodium chloride symporter. Done. What if time bad? If this transporter is mutated, okay, naturally if the transporter is mutated by birth, that is going to cause a disease called as mutation. Okay. Mutation is going to cause a disease called as Gitelman syndrome. Gitelman's syndrome. Okay. So now tell me, Gitelman syndrome is a defect in, Gitelman syndrome is a defect in DCT, Bartter is a defect in PCT. So can I say something like this? Sir, in Gitelman syndrome and in thiazide diuretic usage, it's the same transporter that is affected. So yes, Gitelman syndrome, it resembles what? Thiazide diuretic usage. Thiazide usage, because the same clinical features will be there, because it's the same transporter that is affected, so similar clinical features will be there. Okay, similar clinical features will be there. Okay, so these are some important points which are important about the distal convoluted tubule. See, can you tell me, sir, thiazides, what is the one difference between loop diuretics and thiazide diuretics? Loop diuretics, one difference I am telling you from your pharmacology, the difference is loop diuretics, fluctuations are coming, so just wait. See, now loop diuretics. Versus thiazides. Loop diuretics, they act on thick ascending limb. Thiazides act on DCT. Loop diuretics, they will inhibit NKCC. Thiazides will inhibit sodium chloride symporter. Loop diuretics increases the calcium loss excretion. Thiazide diuretics decreases the calcium excretion. Okay, these are some important differences which I want you to know for your exam. Okay, done. After this, the last part of the nephron. I want to discuss about the last part of the nephron, that is your collecting ducts. So in the collecting ducts, what are the important MCQs that you should know? Is, listen carefully. Let's say here is your collecting duct. Okay, here is your collecting duct, sir. 2 collecting ducts I am showing you. Okay, why? You will understand. 2 collecting ducts I am showing you. See, here these are principal cells present. Which cells? Principal cells. Okay, principal cell. Now, here on this collecting ducts, 2 hormones will act. First hormone I am talking about aldosterone. Other cell here I am showing you, let's say this is your intercalated cell. IC for intercalated cell. Now, aldosterone, look, aldosterone, when it is acting on the principal cell and when it is acting on the intercalated cell, do you know what is happening in the collecting duct? In the collecting duct, what is happening? Sir, aldosterone, it is acting on collecting duct. Okay, when it is acting on collecting duct, aldosterone helps in reabsorption of sodium. And it helps in the excretion of potassium, sir. Potassium will be excreted. When the same aldosterone, when it is acting on the intercalated cell, it helps in the secretion of protons or excretion of protons. So now tell me, what are the 3 functions of aldosterone? Aldosterone helps in sodium reabsorption, potassium and proton excretion. So what is the name of this channel, sir? The name of this channel is called as, this sodium reabsorbing channel is called as epithelial sodium channel, sir. ENaC. What does ENaC stands for? ENaC stands for epithelial sodium channel. Okay, so this epithelial sodium channels, now tell me, they are under the control of aldosterone. So aldosterone with the help of epithelial sodium channels helps in reabsorption of sodium. Okay, now in your exam they will ask you, what if this epithelial sodium channels, they are mutated, they are having gain of function mutation, they are doing overaction, sir, overactivity. So overactivity of this epithelial sodium channels is going to cause a disease called as Liddle syndrome. Overactivity is going to cause a syndrome called as Liddle syndrome. So now you tell me, in Liddle syndrome, which channels are overfunctioning? Epithelial sodium channels. So what is the treatment? Block the epithelial sodium channels. So in Liddle syndrome, you have to block this epithelial sodium channels. So right, Liddle syndrome, we will use ENaC blockers, epithelial sodium channel blockers, called as amiloride. Okay, so amiloride is the drug which is used in the treatment of Liddle syndrome. Liddle syndrome is an autosomal dominant disorder. Liddle syndrome occurs in the collecting ducts. Okay, epithelial sodium channel overactivity. So done. Now this is the function of aldosterone. So this, what are the three functions of aldosterone? I have told you: sodium reabsorption, potassium and proton excretion. Now let's discuss about a different hormone called as antidiuretic hormone. Okay, look here, antidiuretic hormone. Now antidiuretic hormone, first tell me what is the stimulus for the release of antidiuretic hormone. When antidiuretic hormone will be released, the major stimulus, let me write major stimulus. The major stimulus for the release of antidiuretic hormone is hypertonic, not hypotonic. Some Q banks were given hypotonic plasma. No sir, it's a hypertonic plasma. When your plasma is getting concentrated, when your blood volume is decreasing, when you are having hypertonic plasma. Okay, hypertonic plasma stimulates the release of antidiuretic hormone. Antidiuretic hormone acts on principal cells, which receptors? V2 receptor. When the V2 receptor is activated, the intracellular cyclic AMP is going to be produced. The intracellular cyclic AMP is going to produce a channel called as aquaporin 2. It is going to produce what? Channels, water channels called as aquaporin 2 channels. So with the help of aquaporin 2 channels, now water is getting reabsorbed into the cells. Water reabsorption is occurring. So now tell me, the water reabsorption in the collecting ducts. It is under the control of a hormone. So it's a hormone which is controlling the water reabsorption. Understand? So such a type of water reabsorption is called as facultative water reabsorption. Okay, facultative water reabsorption. So what does it mean by the word facultative? See, I have told you obligatory water reabsorption occurs in PCT. Facultative water reabsorption is occurring in collecting ducts. So what is facultative water reabsorption? Let me write. See, facultative water reabsorption means usually collecting ducts are impermeable to water. They are impermeable to water, but in the presence of antidiuretic hormone. So whenever there is antidiuretic hormone, becomes water permeable. Collecting duct becomes water permeable. Means if there is antidiuretic hormone, they will reabsorb the water. If there is no antidiuretic hormone, there is no water reabsorption. Okay, they becomes water permeable. Okay, they becomes water permeable. So now you understand. So the collecting ducts are usually not absorbing water, but in the presence of antidiuretic hormone, they becomes water permeable. Such a type of water reabsorption, the water reabsorption is dependent on a hormone. Such a type of water reabsorption is called as a facultative reabsorption. Okay, occurring in collecting duct in the presence of antidiuretic hormone. Okay, in the presence of antidiuretic hormone. So in the presence of antidiuretic hormone, not only water will be reabsorbed, but also urea will be reabsorbed. So antidiuretic hormone also helps in the reabsorption of urea. Yes, true. Okay, urea, it helps in the reabsorption of urea. True. Next, what else I have to teach you regarding this collecting ducts? See, in collecting ducts, I have told you two hormones acting. One is aldosterone, antidiuretic hormone. Aldosterone helps in the reabsorption of sodium. Antidiuretic hormone helps in the reabsorption of water with the help of aquaporin 2 channels. Now here, the MCQ which I want you to know is, look at this. In the presence of antidiuretic hormone, first question, acts on. Simple answer is collecting duct. Antidiuretic hormone helps in water reabsorption. Antidiuretic hormone helps in water reabsorption. Where? In the collecting ducts. Antidiuretic hormone, where it is causing the water reabsorption? Collecting ducts. But if the question is like this, in the presence of antidiuretic hormone, maximum, if they use the word maximum water reabsorption, don't answer collecting ducts. Because always maximum water reabsorption occurs in PCT. Because you know 70% of the water reabsorption occurs in PCT. So antidiuretic hormone present or not present doesn't matter. Doesn't matter. Always maximum water reabsorption occurs in PCT. Okay? Yes. Antidiuretic hormone helps in water reabsorption. Where? Collecting duct. How much, sir? Only 5 to 10% maximum. But 70% maximum water reabsorption, 70% water reabsorption occurs in PCT. So in the presence of antidiuretic hormone, if they ask maximum water reabsorption occurs in not collecting duct, the answer is PCT. Again, I have seen some Q banks, very famous Q banks. They says that in the presence of antidiuretic hormone, the highest water reabsorption occurs in collecting ducts was given. No, it's not the collecting ducts. It's the antidiuretic. It's a proximal convoluted tubule. It's a PCT. It's a PCT. Okay. Now tell me here, any sodium is getting reabsorbed, only pure water is getting reabsorbed. No, so it is called as solute free or sodium independent water reabsorption. So they will ask you, so in collecting that, what kind of water reabsorption? That is sodium or solute free or solute independent solute free water reabsorption occurs. Water reabsorption. But in PCT, what kind of water reabsorption? 70% of sodium reabsorbed, so 70% of water reabsorbed. Okay, so solute free water reabsorption occurs. Solute free water reabsorption occurs. Okay, next, see here one point is missing. What is that one point is? See, I have told you what is the major stimulus for the release of antidiuretic hormone? Hypertonic plasma. Then what is the major stimulus for the release of aldosterone? The major stimulus for the release of aldosterone, don't think it's the RAS pathway. No, it's not the RAS pathway, sir. It is hyperkalemia. Hyperkalemia. So hyperkalemia is the major stimulus for the release of antidiuretic hormone, aldosterone, and hypertonic plasma is the major stimulus for the release of antidiuretic hormone. Done? Now after this, what else I should teach you? These are the main important points. See, collecting duct also completed. So these are the main important points which I want you to teach in renal physiology. Apart from this, the one important graph is there, sir. One important graph I want you to know for your exam. What is that graph? That graph is cystometrogram. Cystometrogram. What is the cystometrogram? I will explain you. Before going to the cystometrogram, okay, let me tell you a few more clinical integrations. See, what if you are having a more amount of antidiuretic hormone? What happens if there is more amount of antidiuretic hormone? So that condition is called as, if you have more amount of antidiuretic hormone, that condition is called as SIADH. Okay, SIADH, syndrome of increased antidiuretic hormone, syndrome of increased antidiuretic hormone, or syndrome of inappropriate antidiuretic hormone synthesis, SIADH. From where this extra antidiuretic hormone is coming? From where this antidiuretic hormone is coming into the body, sir? The extra antidiuretic hormone is coming into the body from some cancers. Some cancers are producing this antidiuretic hormone, like oat cell cancer. Okay, oat cell cancer, also called as small cell cancer of lung. Small cell cancer of lung or oat cell cancer of lung is going to produce excessive amount of antidiuretic hormone. Understand? Now question is, what if there is more amount of antidiuretic hormone? If there is more antidiuretic hormone, more water reabsorption. So what happened to the urine, sir? Urine will be very less. So there will be very less urine produced. So the person is going to produce very less amount of urine. And how that urine is going to be? Diluted? No, it is concentrated urine, sir, or you can say hypertonic urine. Now the urine osmolarity is increased. Because more and more water is reabsorbed back into the body. More and more water is going back into the body. As more and more water is going back into the body, what will happen to the plasma? Plasma will become diluted. So what happened to the plasma, sir? Plasma, there is hypotonic plasma. Okay? Hypotonic plasma. Our plasma osmolarity decreased. And urine osmolarity increased. So these are the laboratory changes that you will see. So what you will see in the labs, there will be hypertonic urine and hypotonic plasma. The plasma is getting diluted away. More and more water is getting reabsorbed in the body. So what happened to the sodium levels in the body? Sir, you are adding more and more water. The sodium levels will be diluted. So there will be dilutional hyponatremia, sir. This is the keyword. There will be dilutional hyponatremia. Okay, so there will be this person with SIADH is going to have dilutional hyponatremia. So tell me how to treat this condition. So how to treat this condition, sir? See, you can block simply, so there is more antidiuretic hormone. Okay, There is more antidiuretic hormone, sir. Okay. So what you can do? You can simply block the V2 receptors. Simply block the receptor. So V2 receptor blockers like Vaptans. So the drug of choice in this condition is V2 receptor blockers. Okay, V2 blocker called as Vaptans. So V2 receptor blockers like Vaptans, like Tolvaptan or Conivaptan. So they are the drugs which are used in the treatment of SIADH. SIADH, very important condition which you need to know for your exam. Okay. Anyway, this SIADH, diabetes insipidus, they will also come in your internal medicine. They will also come in your pathology. You know. So here mainly I am concentrating on the physiology points. Anyway, the clinical integrations you can anyway do it in your medicine. Okay. Chalo. Next step. After this, let's discuss about the cystomatogram. So very important diagram, 5-star question, sir. Cystomatogram, what exactly is this cystomatogram talking about? See here we are talking about volume changes in the bladder, on the x-axis, and pressure changes in the bladder. Okay, pressures are not pleasure. Okay, pressure changes in the bladder. Okay, in the urinary bladder. So volume means let's start from 0, 100 ml, 200 ml, 300 ml, 400 ml, something like this. Okay, see when you are increasing the urine volume into the bladder, when the bladder is getting more and more urine, see what you are doing, the urine is getting filled, sir. Urine volume what happens? Increases, yes or no? So automatically what happened to the pressure in the bladder? Increases. So when the urine, see here are the two kidneys, kidneys are producing the urine. Now urine will come into the bladder. So as the urine is filling in the bladder, what will happen to the bladder pressure? Bladder pressure also increases, slightly bladder pressure also increases, sir. Okay, slightly bladder pressure increases. But see, for most of the time, bladder pressure is remained constant like this. For most of the time, the bladder pressure is not rising sharply. It is not rising sharply like this. It is almost constant. Till how much? Till 400 ml. Once you have 400 ml, the bladder pressure rises. Now, from now, the bladder pressure is going to rise. Okay. So, what are these phases? Let's say this is 1, this is 2, and let's say this is 3, sir. They can change they can change also A, B, C, 1A, 1B, 2. They can change, like any numbers can be given. Now they will ask you, see in this phase 2, or phase B, the bladder pressure is constant. It is not rising sharply. Why? Because bladder is not a rigid organ. Bladder will distend. It will accommodate the urine. Okay, so the pressure is not rising sharply, the pressure is almost maintained constantly because the bladder is also stretching, distending in order to accommodate the enough amount of urine. So this phase 1B, it is due to, that's the question, sir. The phase 1B, it is due to bladder, okay, it is due to bladder plasticity. It is due to bladder plasticity. Not elasticity, sir, that's due to bladder plasticity. And there is a law. Which law explains the phase 2? That is law of Laplace. Law of Laplace. Law of Laplace explains why the pressure in your bladder is not increasing sharply. And the phase 1B is due to the plasticity of the bladder. It's not due to the elasticity, it's due to the plasticity of the bladder. And at 400 ml, see, now once you have 400 ml of urine into the bladder, now there is no more further distension, so the bladder pressure is rising sharply. So at this ml, 400 ml, what you will have? You will have strong urge for urination. Okay, but the bladder pressure is increasing very sharply, so you can't hold it, you will rush for the urination. But when you will have the first urge for urination, sir, at 150 ml, you will have first urge for urination. Not strong urge, you will have a feeling, okay, let me go for the, the toilet, let me go for the urination, so that you can empty the bladder. So first urge for urination comes at 150 ml, but the strong urge for urination comes at 400 ml. So this is the image based questions that they will give you. So whenever they are talking about volume changes on the x-axis and pressure changes in the y-axis, they are talking about which graph? Cystomatogram. Phase 1B, phase 2. Phase 2 is due to plasticity, or it is explained by Laplace law. So okay, these are the important questions which I want you to know in the cystomatogram topic. And I have explained you most of the important topics. I have explained you in the renal physiology how the questions will come. Okay. So if you know this much, that will be enough. But let me add a few more important points. Okay, few more important points. What are they? The topic of auto regulation of GFR. Auto regulation of auto-regulation of GFR. So, what you have to know in this topic of auto-regulation of GFR, always your GFR is regulated always, means always your GFR is maintained at 125 ml per minute, always it's maintaining in a normal value. How? This auto-regulation of GFR occurs with the help of two mechanisms. It occurs with the help of two mechanisms. What is that? One is called as a tubulo-glomerular feedback. Tubulo-glomerular feedback. The second mechanism is called as myogenic hypothesis or myogenic mechanism, you can say myogenic mechanism. Okay, myogenic mechanism or tubulo-glomerular feedback. So, what are these two mechanisms? Who is regulating these two mechanisms, sir? This tubulo-glomerular feedback is very, very important. So, this tubulo-glomerular feedback is given with the help of a cell called as a macula densa. Macula densa. So, this macula densa, where is it located? The macula densa, it is located on the thick ascending limb. Okay, if not that, DCT. So, thick ascending limb is always the best answer, sir. This is macula densa cells. The macula densa cells, where are they located? They are located on the thick ascending limb. The macula densa cells, what they are checking? They are checking the sodium chloride levels in the urine. Okay, sensitive to. They are sensitive to sodium chloride levels in the urine. So, by looking at the sodium chloride levels, it will estimate the GFR. So, the macula densa cells which are located on the thick ascending limb, they are checking the sodium chloride levels in the urine. By checking the sodium chloride levels in the urine, they will estimate the GFR, whether the GFR is more or whether the GFR is less. So, by looking at the sodium chloride levels, they will control the GFR. They can actually control the GFR, sir. So, that is called as a tubulo-glomerular feedback given by macula densa. And what is this myogenic mechanism, sir? Myogenic mechanism, it's with the help of calcium ions. It's with the help of calcium ions. And one more thing, and this macula densa, it produces which chemical? Macula densa produces adenosine. That's also MCQ. Very, very important. Macula densa produces adenosine. Adenosine, important MCQ. Okay. Sir, what is this myogenic mechanism? Myogenic mechanism, simple. It is also regulating GFR. Okay. How is muscles will contract? Which muscles, sir? Muscles present on myogenic, the muscles. See, some muscles are also controlling the GFR, sir. Which muscles control the GFR? Muscles present are the smooth muscles present on the afferent arteriole. So, some smooth muscles which are present on the afferent arteriole, they will cause the afferent arteriolar constriction, afferent arteriolar dilation. By causing afferent arteriolar constriction and dilations, they can actually control the GFR. Okay. So, with the help of calcium ions, for the contraction of the smooth muscles, what is required? Calcium is required. So, the tubulo-glomerular feedback and the myogenic mechanisms are the two important ways to regulate your GFR, to maintain your GFR always in a normal state, normal value. Okay. And after this, see, after the renal physiology, I will give you the break. After renal physiology, I will give you 5-10 minutes break I will give you. After that, we will continue with the remaining systems, the cardiovascular system, respiratory system and central nervous system. That we will discuss after the break. So, now look carefully here. See, here is afferent arteriole. Okay. Here is afferent arteriole, let's say. Here is the glomerular capillary. Here is efferent arteriole, sir. Efferent arteriole. Okay, like this. Now, I am telling you, afferent arterioles, when they are dilated, what happens? Afferent arterioles, when they are constricted, what happens? Next step, efferent arteriole, when they are dilated, what happens? Efferent arterioles, when they are constricted, what happens? Let me tell you. Okay, let me tell you. Afferent arteriolar dilation is going to increases your GFR. Always remember, whenever they give the question, afferent arteriolar dilation, when the afferent arteriole, when it is dilated, more blood will come, more will filter, so it increases the GFR. Afferent arteriolar constriction decreases GFR. Okay. Next, efferent arteriole, if it is constricted, efferent arteriole, if it is constricted, initially GFR increases. See, initially GFR increases, but later GFR decreases. Initially increases, later decreases. But what about the efferent arteriolar dilation? When the efferent arteriole, if it is dilated, simple, GFR decreases. GFR decreases. Okay. So, efferent, this is important, sir. Efferent arteriole, when it is constricted, that's the recent FMGE question. Efferent arteriole, when it is constricted, initially GFR increases, Initially GFR increases, later decreases. This response is called as biphasic response. This is called as biphasic response. Okay, this is called as a biphasic response. Who will cause the efferent arterial constriction? It's the angiotensin 2. Angiotensin 2 causes efferent arterial constriction. So initially GFR increases, later decreases. Okay, and later what else you should know in the renal physiology is regarding the formula to calculate the GFR. The formula to calculate the GFR or the formula to calculate clearance. The formula to calculate the GFR and clearance is, the formula used is UV by P, urinary concentration of a substance into volume of urine produced by the plasma concentration of a substance, UV by P. The formula UV by P is used, okay, urinary concentration of a substance and the same plasma concentration of a same substance into how much urine is getting produced in a minute. Okay, so the formula UV by P is used to calculate the GFR as well as the clearance of any particular substance. For both it's the same formula. For both it is the same formula. Okay, so GFR, it is calculated by using which substance, sir? What is the substance? So GFR, it is calculated by using which substance? So for GFR estimation, which substances are best? That is inulin. Inulin is gold standard. Inulin is a gold standard for the estimation of GFR. Apart from inulin, what else you can use? Creatinine. Creatinine. Okay, inulin, creatinine. Inulin is a gold standard for always estimation of GFR. But if they ask you for the estimation of renal plasma flow, sir, I have told you renal plasma flow is how much? 625 ml per minute. For the estimation of renal plasma flow, which substances are used? The substance that is used is para-aminohippuric acid. Para-aminohippuric acid is used in the estimation of the renal plasma flow. For the estimation of the GFR, the substance that is used is the creatinine or inulin. Creatinine or inulin. Okay, so okay guys, let's continue with the cardiovascular physiology. Okay, so everything about the heart. So in this cardiovascular physiology, what are the important things that I want you to know? See, actually cardiovascular system is a very big system, right? It's a very vast system, lots and lots of things are there. So here I will be mainly concentrating. What are the important areas that you should know for your exam? See, first one is your cardiac cycle. Cardiac cycle. See, in cardiac cycle, what are the important things that you should know? First, what is the time duration for the cardiac cycle? The time duration for the cardiac cycle is 0.8 seconds. Okay, 0.8 seconds. In cardiac cycle, how many phases are there? There are two phases in the cardiac cycle. What are they? Systole as well as diastole. Okay, there will be systole and diastole. Systole and diastole. Sir, in systole, how many phases are there? There are three phases in the systole. That is isovolumetric contraction, rapid ejection phase, slow ejection phase. Okay, isovolumetric contraction, rapid ejection, slow ejection phases. Diastole, there are 5 subphases present. Okay, there are 5 subphases present. What are the 5 subphases? That is the protodiastole, protodiastole, isovolumetric relaxation, IVR, isovolumetric relaxation. Next, rapid ventricular filling, RVF, rapid ventricular filling. Next, slow filling, slow ventricular filling, also called as a diastasis. And atrial contraction. Atrial contraction. So these are the 5 phases of the diastole. Now here in the cardiac cycle, the one thing I will tell you, see wherever you see the word, isovolumetric contraction or isovolumetric relaxation, during these phases, blindly mark, during isovolumetric contraction, during isovolumetric relaxation, your response should be all valves, sir, all the valves in the heart, all valves are closed. All valves are closed. All the valves in the heart are closed. That is, the tricuspid valve, mitral valve, aortic valve, pulmonic valve, all the 4 valves in the heart are in closed state. So nothing is coming into the ventricles, nothing is going out of the ventricles. Nothing is coming into the ventricles, nothing is going out of the ventricles. So that's why the word isovolumetric, same volume. The volume of blood within the ventricular cavity is not changing because all valves are in closed state. Nothing is coming in, nothing is going out. Okay. Apart from this, what else they will ask you? They will mainly ask you, sir, atrial contraction. Okay, atrial contraction. See, now you tell me when the atria is contracting. Okay, when the atria is contracting, where the blood will go? The blood will go into the ventricles, yes or no? Atria contracting, how much the blood will go? Ventricles, okay, let's say atrial contraction is going to cause 30% filling of ventricles. 30% filling of ventricles. Okay, 30% filling of ventricles, sir. The question which was asked. So, 30% filling of the ventricles is occurring during atrial contraction. Okay. So, if ventricles are filled 30% here, the remaining 70% where it will fill? During rapid ventricular filling. See, during rapid ventricular filling, 70% of the ventricles will be filled. Okay. 70% of ventricular filling. Okay. But what is the difference between these two? Atrial contraction is an active processor. This is active filling. Okay, this is active filling. But 70% filling of the ventricles, this is passive filling. Okay, guys, percent active filling of the ventricles. Active filling of the ventricles will occur in atrial contraction. How much percentage filling? How much percentage filling? 30%. See, when 30% of the bleeding, okay, when 30% of the blood, when it goes into the ventricles, when it falls into the ventricles, will it cause sound or not? When 30% of the blood, when it's coming and hitting the ventricular walls, will it cause sound or not? Yes. So, which heart sound? Atrial contraction ke time mein, you can hear S4 heart sound. Atrial contraction, let me write with the big letters. Atrial contraction is going to cause which heart sound? S4 heart sound. Okay, it's going to cause S4 heart sound. Next, sir, when 70% of the blood, when it is hitting the ventricular walls, will it cause sound or not? Yes, it will also cause sound, sir. That heart sound is called as S3 heart sound. So, during rapid ventricular filling, which heart sound is heard? S3 heart sound is heard. S3 heart sound is heard. Okay, S4, S3. Now, sir, S3, S4 completed. What about the S1, S2? S1, S2, sir, always in the beginnings. Look, sir, during isovolumetric contraction, you will hear S1 heart sound. S1 heart sound is due to isovolumetric contraction, and S2 heart sound is seen during protodiastole. S2 heart sound seen in protodiastole. Beginnings. Okay. So, beginning of the systole. Systole begins with S1. Systole begins with S1 and diastole begins with S2. Okay. Diastole begins with S2. You understand? Sometimes this protodiastole, it is not given in some books, sir. It's very small phase. It's not given in the books. So, you can say S2 is heard in isovolumetric relaxation also. Okay, you can say always best answer is S2 is heard in protodiastole. Best answer, sir. But if you don't see that protodiastole, then you can mark isovolumetric relaxation also. Okay, so isovolumetric relaxation begins with which heart sound? S2 heart sound. Okay, done. So now quickly answer. Sir, S4 heart sound is seen during atrial contraction. S1 is due to isovolumetric contraction. S2 is due to protodiastole. S3 is due to rapid ventricular filling. Okay, rapid ventricular filling. These are the heart sounds and in which phases they are going to produce. Heart sounds and which phases they are coming, sir. Okay. Now, let me tell you something. Sir, here is your heart. Okay, here is your heart. 4-chambered heart, sir. Okay. So, here is the pulmonic valve and on this side, okay, let me show you in a different color. Guys, here is the pulmonic valve, the pulmonary artery, and on this side I am showing the aorta, sir. Here is the aorta. Here I am talking about the aortic valve. Okay, here is the aortic valve. Now, the closure of these above valves, what are these valves? That is a tricuspid valve and mitral valve. The closure, always remember, the closure of these above valves is going to cause S1 heart sound during isovolumetric contraction. Okay, and the closure of these below valves, what are these below valves? Aortic valve and pulmonic valve. The closure of these bottom valves, they are going to cause which heart sound? S2 heart sound.
S2 heart sound. That is seen during protodiastole. If you don't see that, answer isovolumetric relaxation. In the beginning of isovolumetric relaxation, S2 heart sound. Okay, above wall closure S1, below wall closure S2. So now tell me, S1 heart sound is due to closure of mitral valve and tricuspid valve. S2 heart sound is due to closure of, sir, S2 heart sound is due to closure of aortic valve and pulmonic valve. Aortic and pulmonic valves. Bas? Done? Now, what else I should teach you? See here. Systole is very, very important, sir. Look. S1, S2, again who will come? S1 will come. Heart sounds are coming like this. See, the phase between S1 and S2 is called as, the phase between S1 and S2 is called as systole. Okay, the phase between S1 and S2 is called as a systole, and the phase between S2 and again one more S1 is called as diastole. Okay, diastole. See, in diastole, how many phases are there? First one, protodiastole, isovolumetric relaxation, rapid ventricular filling, next slow filling, last phase is atrial contraction. So during atrial contraction, which heart sound is heard? S4. And during rapid ventricular filling, which heart sound is heard? S3 heart sound is heard. S3 heart sound is heard. So now tell me, what is a pre-systolic heart sound before S1? Okay, before S1, S1 with S1 again one more systole starts. What is a pre-systolic heart sound? So S4. So always remember, S4 is a pre-systolic heart sound. Okay, S4 is a pre-systolic heart sound. Chalo, next. So what is the phase between S1 and S2 called as? S1 and S2 ke phase, the S1 S2 heart sounds ke beech mein, in between S1 and S2, the phase is called as a systole. Now systole, how many phases are there? Isovolumetric contraction, rapid ejection phase and a slow ejection phase. 3 phases are there in the systole. Okay. Now, after teaching you the heart sounds, let me add a few more points to it. See, there are some low pitch heart sounds. Low pitch heart sounds. See, what are these low pitch heart sounds? Okay, what are the low pitch heart sounds? Low pitch heart sounds means you can only hear them with the bell side of the stethoscope. Okay, you can hear them with the bell side of the stethoscope, not the diaphragm size, not the big side, small size will be there, not to the stethoscope. So low pitch heart sounds will be heard with the bell side of the stethoscope. So what are the low pitch heart sounds in the entire medicine? In the entire medicine, S3, S4 and one more sound called as a tumor plop sound. So S3 heart sound, S4 heart sound and the tumor plop sound, these are the low pitch heart sounds. So tell me, S3 is heard during rapid ventricular filling, okay. S4 is heard during atrial contraction, okay. But the question is, sir, S3 and S4, are they physiological? Can you hear them normally? No, you can't hear them normally. Okay. When you can hear them, sir? In pathological conditions. S3 and S4 are heard in pathological conditions. See, S4 is seen in which cases? In cases wherever there is ventricular hypertrophy. When a ventricle is undergoing hypertrophy, in such cases, you will hear S4 heart sound. So now tell me, ventricular hypertrophy is seen in which conditions? Like long-standing hypertension, aortic stenosis or hypertrophic obstructive cardiomyopathy. In these conditions, you will hear S4 heart sound. Okay, and where you will hear S3 heart sound, sir? S3 heart sound is associated with ventricular dilation. When a ventricle is undergoing dilation, when a ventricle has undergone dilation, in those dilated ventricles, if the blood is filling, that will cause S4 heart sound. Okay, so now tell me, in which conditions there will be ventricular dilation? That is congestive heart failure. You know, when a heart is failing, it will be becoming big and big dilated. Next, myocarditis. Or dilated cardiomyopathy. Okay, dilated cardiomyopathy. So in these conditions, okay, dilated cardiomyopathies. So in these conditions, you can hear S4 heart sound. S4 heart sound. Okay, sir, S4, S3, okay. But where you will hear this a tumor plop sound. See, this tumor plop sound, it is seen in a condition where there is a tumor in the left atria, sir. See, there is a condition where a tumor is arising in the left atria. Okay, tumor is arising in the left atria, sir. See, this tumor is called as atrial myxoma. Okay, so this atrial myxoma is going to cause which heart sound? Tumor plop sound. Because that tumor, it's moving, it is hanging over there, it is moving, and that's what is going to cause the tumor plop sound. So these are the three low pitch heart sounds: S3, S4, tumor plop sound. That's it. In the entire medicine, these are the three low pitch heart sounds. So normal heart sounds I have explained you. After normal heart sounds, for your exam, you need to know your murmurs, sir. Murmurs are very, very important for your exam. So what are those murmurs? Look here. Okay, murmurs. Which murmurs? First murmur that I am talking here, see, there is a type of murmur called as pansystolic murmur. Pansystolic murmur. So where you will hear such pansystolic murmur? Pansystolic means throughout the systole there is a murmur. Throughout the systole there is a murmur. Pansystolic murmurs are heard in MR, TR, VSD, MR, TR, VSD, mitral regurgitation, tricuspid regurgitation, ventricular septal defects. Only these three conditions are in the entire medicine. The three conditions like mitral regurgitation, tricuspid regurgitation and ventricular septal defects, they are going to cause which type of murmurs? Murmurs in systole. That's the pansystolic murmurs. The second type of murmur is called as, look, crescendo decrescendo murmur. Also called as, let me write, crescendo decrescendo murmur, also called as ejection systolic murmur. So crescendo decrescendo murmur or ejection systolic murmur, where you are going to hear them? They can be heard, crescendo decrescendo murmur or ejection systolic murmur, they can be heard in aortic stenosis, pulmonic stenosis, pulmonic stenosis and HOCM, hypertrophic obstructive cardiomyopathy. Very, very important. Either aortic stenosis or pulmonic stenosis or hypertrophic obstructive cardiomyopathy. Even in hypertrophic obstructive cardiomyopathy, if you have properly studied in your medicine, there is aortic stenosis, there is subaortic stenosis. Because of the thickening of the interventricular septum, there is a subaortic stenosis. So this is stenosis. This is stenosis conditions are like aortic stenosis, pulmonic stenosis and HOCM. These conditions are associated with which kind of murmur? It is associated with a crescendo decrescendo murmur. The third murmur, sir, the third murmur which is very important for your exam, that is early diastolic murmur. Early diastolic murmur. Such early diastolic murmurs, they are associated with what? Which condition? Aortic regurgitation. Okay, so aortic regurgitation is going to cause early diastolic murmur. Next, the fourth type of murmur is called as a continuous murmur, sir, both during systole as well as diastole. So that is continuous or machinery like murmur. Okay, machine like. Okay, continuous machine like murmur, that is seen with patent ductus arteriosus. Patent ductus arteriosus, the baby who is suffering with the patent ductus arteriosus, you can hear a continuous machine like murmurs can be heard. Okay, so which babies will get a patent ductus arteriosus? Congenital rubella syndrome. If a baby has a congenital rubella syndrome, okay, congenital rubella syndrome, the baby who is suffering with the congenital rubella syndrome, they will develop patent ductus arteriosus, and whenever you do the auscultation, you can hear which kind of murmur? Continuous machinery like murmur. This continuous machinery like murmur is also called as a Gibson's murmur. Gibson's murmur. Okay. Next, after this, let me teach you some named murmurs. Okay. See, I am not explaining why these murmurs are happening, why in MR, TR, VSD there will be pansystolic murmur. See, that much time is not there for us. See, the moment you see the word mitral regurgitation, which kind of murmur? Pansystolic murmur. Or if you see the patient is having crescendo decrescendo murmur, your immediate diagnosis should be the patient is either having aortic stenosis or pulmonic stenosis or HOCM. something like that. If you see the word continuous machinery like murmur is heard, the patient is suffering with the patent ductus arteriosus. Okay. Next step, and if you see the word early diastolic murmur in the question, immediately your diagnosis should be aortic regurgitation. Okay. In the same way, if you ever hear, these are some important named murmurs. Okay. If you ever hear a murmur called as Carey-Coombs murmur, Carey-Coombs murmur. Such Carey-Coombs murmur, it is seen in acute rheumatic fever. Okay, acute rheumatic fever, Carey-Coombs murmur is going to be seen. Okay, so this is important. Carey-Coombs murmur. Next, Austin-Flint murmur. Austin-Flint murmur. Austin-Flint murmur is seen with aortic regurgitation. Okay, aortic regurgitation, AR. Okay, so it's a little different. Aortic regurgitation have early diastolic murmur. Okay, this Austin-Flint murmur is a late diastolic murmur, sir. It's a late diastolic murmur. Okay, so aortic regurgitation, yes, aortic regurgitation, there will be early diastolic murmur and there is a late diastolic murmur. This Austin-Flint murmur, this is a late diastolic murmur, not early diastolic. That's called as a Austin-Flint murmur. Austin-Flint murmur. Okay, anyway, Gibson's murmur I have explained you. Gibson's murmur is a continuous machinery like murmur. Okay, done. Next, one more murmur, that is called as a Graham-Steele's murmur. Graham-Steele's murmur. That is seen with Graham-Steele's murmur. It is seen with what? Pulmonary regurgitation. Okay, Graham-Steele's murmur. Bus. So with this, these are the important murmurs which I want you to know. At least for your exam, remember that early diastolic murmur is a seen in aortic regurgitation. Pansystolic murmurs are seen with MRTR VSD, and acute rheumatic fever is going to cause Carey-Coombs murmur. Austin-Flint murmurs are seen in aortic regurgitation. They are the late diastolic murmurs. Okay, so these are the important murmurs which I want you to know for your exam. Okay, now after this, if they use the words, for example, see S1, S2, S1 again, S1, S2, S1 again. See, the person is having a mid-systolic clicks. You know, this is systole. The phase between S1 and S2 is called as a systole. See, here I am talking about what? A mid-systolic clicks. Mid-systolic clicks. And there is a late systolic murmur. Late, not diastolic, late systolic murmur. So, right here, mid-systolic click with late diastolic murmur. Late diastolic murmur. So, what is that condition? This condition is mitral valve prolapse. Okay, mitral valve prolapse. In a patient who is having MVP, mitral valve prolapse, there are mid-systolic clicks with a late diastolic murmur. So, tell me what is the importance of this late diastolic murmur, sir? Let me tell you, all murmurs decreases. Okay, the murmur sound decreases upon standing. See, upon standing, all murmurs decreases except mitral valve prolapse murmur. Except if the patient is having mitral valve prolapse or if the patient is having HOCM. You know, mitral valve prolapse, there will be late systolic murmur. This murmur will not decrease in intensity, and HOCM patient will have crescendo decrescendo murmur. So the crescendo decrescendo murmur which is seen in the HOCM patients, okay, and the late systolic murmur which is seen the late systolic, sorry, sir, why I have written here late, why LDM I have written here? No, this is systole, no, this is late systolic murmur. Okay, so mid systolic click with the late systolic murmur. Okay, late systolic murmur. So the patient is going to have a late systolic murmur in mitral valve prolapse, and a crescendo decrescendo murmur which is seen in the HOCM. They will not decrease. All other murmurs in the entire medicine, all other murmurs decrease upon standing and Valsalva except two murmurs, that is mitral valve prolapse murmur and HOCM murmur. Bus. Okay, bus. Now after this, what I should teach you is, in cardiovascular physiology, the next most important topic is the JVPs, jugular venous pulses or JVPs, jugular venous pressures. See how the pressure is going to fluctuate in your central veins or in your jugular veins. In your jugular veins, how the pressure is going to fluctuate? See, pressure is going to fluctuate something like this. See, initially pressure increases, later decreases. Again the pressure increases and decreases with one cardiac cycle. With one cardiac cycle, that is systole and diastole, the pressure in your jugular veins is increasing, decreasing, like this. So what are these waves called as? These waves are called as A wave, C wave, X wave, V wave, Y wave. These are the waves. See, when a wave is going up, we call it as a positive wave, means pressure increasing. When a wave is coming down, we call it pressure is decreasing. Okay. So what are the positive waves? Positive waves are A, C, V. A, C, V are A, C and V because they are increasing. Okay. So A, C, V are positive waves. X and Y are negative waves. Okay. Negative waves are X and Y. X and Y are negative waves. Now they will ask you, see, why the pressure in your internal jugular vein is increasing? The pressure, see here in the internal jugular vein is increasing, or the central venous pressure, the venous pressure is increasing. So now they will ask you, A wave is due to, right? A wave, it is due to atrial contraction. Atrial contraction. A wave is because of atrial contraction. Next, C wave. C wave, this is due to, that is due to isovolumetric contraction of ventricles. Okay, it is seen due to ventricular contraction. Which phase of ventricular contraction? That too specifically isovolumetric contraction of the ventricles, leading to the bulging of, bulging of which valves? Tricuspid valves. So, sir, the isovolumetric contraction of the ventricles leading to the bulging of tricuspid valve is the one responsible for this little C wave. C wave is due to C for contraction of ventricles. Ventricular contraction is going to cause the C wave. C wave in the jugular veins. Okay. Next, X wave. Sir, this X wave is due to what? X wave, sir, wherever you see X wave is due to relaxation, atrial relaxation. Okay. See, here itself atria is relaxing. See, atria is relaxing. Here also see atria is relaxing. When the atria is relaxing, in between, see who is coming. While the atria is relaxing, suddenly ventricular contraction occur. But still atria is relaxing. So during the phase of, see, this whole area is the atrial relaxation. But during atrial relaxation, who is happening? Ventricular contraction is happening. Ventricular systole started. Okay, done. So A wave is due to atrial contraction, X wave is due to atrial relaxation, C wave is due to isovolumetric contraction of ventricles. Okay. Next, V wave. V wave, when you will see the V wave, sir. Okay, let me tell you. So this V wave, pressure is increasing, that V wave is due to venous filling of atria. Okay, V wave is due to, let me write, venous filling atria, sir. So when the atria is filling with the blood, the pressure in the atria increases, automatically the pressure in your jugular veins also increases. Okay. Next, and Y wave is due to atrial emptying. Okay, into where? Atrial emptying into ventricles with opening of what? With opening of tricuspid valve. So tricuspid valve opened, right atria is emptying into right ventricle. So the pressure in the right atria decreases and the pressure in the internal jugular vein also decreases. So this is the most important area. They will ask you, A wave is due to, C wave is due to, X wave is due to, V wave is due to, Y wave is due to. The pressure in your internal jugular vein sometimes increases, sometimes decreases. According to the pressure in your right atrial cavity, the pressure in your internal jugular veins or the central venous pressures will fluctuate. So these are the pressure fluctuations. Okay. So how the questions will come in your exam? Let me tell you, sir, A wave absent in. Okay. Absent A wave. Sir, A wave, it is absent in condition called as atrial fibrillation. In a condition called as atrial fibrillation, see, A waves in the JVPs are absent, sir. The central pulses may A wave is absent. A wave is absent in which condition? Atrial fibrillation, because in atrial fibrillation atria is not contracting. Without atrial contraction A wave is not going to be seen. Okay, absent A wave. Next, large A waves. Large A wave. So the large A waves in the venous pulses, the large A waves in the venous pulses are going to be seen with three conditions. Okay, large A waves are seen with which conditions? Tricuspid stenosis, okay, pulmonic stenosis, pulmonary artery hypertension. So these conditions, tricuspid stenosis, pulmonic stenosis and pulmonary artery hypertension, in तीनों conditions में, in these are pathologies, these are abnormalities. Medicine, okay, so tricuspid stenosis, pulmonic stenosis and pulmonary artery hypertension, in these conditions, in the monitor, what kind of waves will be seen? Large A waves will be seen. Okay, next, third type of A wave is called as giant A wave. Giant, also called as canon. Canon A waves. So these canon A waves or giant A waves are associated with third degree heart block, also called as complete heart block, and ventricular tachycardia, sir. Ventricular tachycardia. So if a patient is having a third degree heart block or complete heart block or ventricular tachycardia, in these patients you will have giant or canon A waves. Or you can say in another word, sir, whenever a patient is having a third degree heart block or ventricular tachycardia, we say the patient is having atrioventricular dissociation. What does it mean by AV dissociation? Atrioventricular dissociation means atria and ventricles, they are contracting at the same time. Both atria and ventricles, they are contracting at the same time. If both atria and ventricles contract, normally how it should be? First atria should contract, later ventricle should contract. First atria should contract, later ventricle should contract. If the whole heart, if the both atria and ventricles, if they contract at the same time, that is called as atrioventricular dissociations. Such atrioventricular dissociation results in giant or canon A waves. Okay, giant or canon A waves. Now, after this, let's say if a person is having, okay, let's say tricuspid regurgitation. What kind of changes will be seen in the central pulses? What kind of JVP changes will be seen? Say tri is starting with which letter? 3, no? Tri means 3. So in a patient who is having tricuspid regurgitation, they are going to have, absent X. Okay, absent X should be coming down, no? So absent X descent. There will be prominent Y descent. The Y wave will be prominent. Y wave will come very sharply. Y wave will be coming very sharply. And tall V waves. So these are the changes which will be seen. The tall V waves are also called as the CV waves. Okay, so in a patient who is suffering with a tricuspid regurgitation, three changes will be seen. What are they? Absent X, prominent Y, and tall V waves. Okay, in the same way, if a patient is suffering with constrictive pericarditis, this is my favorite. If a patient is suffering with constrictive pericarditis, the patient is going to have both the prominent X descent and prominent Y descent. Okay. So both prominent X as well as a prominent Y. Both the X will be prominent and Y will be prominent, sir, in constrictive pericarditis. Who will get constrictive pericarditis? The patient who is having extrapulmonary TB. Okay, the patient who is having extrapulmonary TB, the TB is spreading from the lungs into the heart. Okay, it will cause constrictive pericarditis. Okay. In the same way, if a person is having cardiac tamponade, what changes will be seen? There will be prominent X will be seen, but absent Y. So Y will be blunted away. So Y wave is absent in which condition? The Y waves are absent in a condition called as cardiac tamponade. See, from your patho, always remember, if a person is having cardiac tamponade, which triad will be seen? Beck's triad. Okay, Beck's triad. So what included in the Beck's triad? If a patient is having cardiac tamponade, he will have three symptoms. What are they? decreased JVP, jugular venous pressure is decreased. There will be muffled heart sounds. There will be muffled heart sounds, and the patient is also going to have hypotension. So in a patient who is having cardiac tamponade, there will be Beck's triad present. Beck's triad, JVP decreases, hypotension, and there will be muffled heart sounds. Okay. So with this, what we have completed is the topic of JVPs, jugular venous pressures topic completed. First I have explained you normal waves. What are the normal waves? ACX, VY, and how these waves are going to change in different conditions, in different medical conditions, how these waves are going to be, the wave pattern is going to be changed. So that I have explained you. Now after this, let me tell you what is Kusumal sign. What is Kusumal sign? Kusumal sign, sir. So what exactly is this Kusumal sign? I am not talking about Kusumal breathing, Kusumal sign. Okay, Kusumal sign. Let me tell you, whenever a person is doing inspiration, what happens? Sir, your jugular venous pressure should decrease without any doubt. That's normal, sir. That's normal. Whenever a person is doing inspiration, the pressure in your veins decreases because the venous blood will be going towards the heart. So the blood pressure in your veins will be decreased because the blood will be dragged towards the heart. So the blood is not accumulating here. So blood pressure will decrease. So whenever a person is doing inspiration, the jugular venous pressures must decreases. What if it increases? With inspiration, if your JVP increases, then it is abnormal, sir. Then it is abnormal. Okay? Then it is abnormal. That is called as Kusumal sign. Kusumal sign. Okay? Where you will see such Kusumal sign? So the mnemonic is KCR, sir. KCR. The mnemonic is KCR. KCR stands for Kusumal sign seen in constrictive pericarditis. It is seen in Kusumal sign. It is seen in, see K, it is seen in constrictive pericarditis, okay, and restrictive cardiomyopathy. Sir, in these two conditions like constrictive pericarditis and restrictive cardiomyopathy, what you will see? Kusumal sign, KCR. If you want to know one more thing, there is one more R is there, sir, that is right heart failure. Right heart failure. Okay, in right heart failure. Even in right heart failure conditions also, you will see Kusumal sign. Kusumal sign. Done. With this, all the important points about the JVP completed. Now, after this, let me explain you the reflexes in the cardiovascular physiology. Very, very important topic. Reflexes also very, very important. Okay. So, let me explain you reflexes. What are the reflexes that you should know in the cardiovascular physiology, sir? First reflex is called as a Cushing reflex. Cushing reflex. Cushing reflexes means whenever a person is having high intracranial pressure, immediately the person's heart rate will decrease. That is called as a Cushing reflex. Increase in the intracranial pressure decreases the heart rate. That is called as Cushing reflex. Okay. Second reflex, that is called as Bainbridge reflex. Second one is Bainbridge reflex. So what is this Bainbridge reflex? Bainbridge reflex, it's the only tachycardiac reflex, which means the result is what? The result is going to be increase in the heart rate. When, sir? When your heart rate increases? Whenever there is increased venous return to the heart. Means whenever you are sending more blood to the heart, you tell me whenever there is more blood going to the heart have to beat more number of times or less number of times? The heart have to beat more number of times. Okay. So they will use the word increased venous return or increased atrial distension. Simple, no? Whenever more blood is going to the heart, the blood will go to the right atria. Whenever there will be right atrial distension, it means more blood is going to the heart. So immediately what will happen to the heart rate? heart rate increases. So that is called as Bain-Bridge reflex. Increase in the venous return to the heart increases the heart rate, that is called as Bain-Bridge reflex. It's a tachycardiac reflex due to increased venous return or right atrial distension. Done. Next, third reflex is Basal-Jarris reflex. Basal-Jarris reflex. Sir, what is this Basal-Jarris reflex, sir? Basal-Jarris reflex means certain chemicals like serotonin, veratridine and capsaicin. So these chemicals, how these chemicals are going to affect your heart, sir? Whenever you introduce these chemicals into the cardiovascular system, whenever you inject these chemicals, immediately they have observed, the scientists have observed the heart rate is decreasing, there will be hypotension, along with that there will be apnea. Sir. So the heart rate decreases, hypotension will be seen as well as apnea will be seen. So this reflex is called as, because of these chemicals, there is decrease in the heart rate, there is decrease in the hypotension, there is decrease in the BP, and there will be decrease in the respiration, sir, apnea. So this reflex is called as the Basal-Jarris reflex. Okay. Now after this, one more big reflex is there, that is called as a baroreceptor reflex. Okay. Fourth reflex I am going to discuss here, baroreceptor reflex. Okay, baroreceptor reflex. So what is this baroreceptor reflex? How to understand this? Now imagine this is your medulla. Okay, and down to it, what is this? This is here the spinal cord. Okay, so here is the arch of aorta, sir. Here is the arch of aorta. From the heart, arch of aorta is coming. From the arch of aorta, what is coming out? Sir, it's a carotid sinus. Here is the carotid sinus. The carotid sinus is going to divide into internal carotids as well as external carotids, sir. Internal carotid, external carotid. Done. Now in these areas where in the arch of aorta some receptors are there. What are these receptors called as? These are called as baroreceptors. What are they? Baroreceptors. Where are they located? Arch of aorta, and they are also located in the carotid sinus. Now what they are always checking? Sir, these baroreceptors always they are checking the mean arterial pressure, or you can simply say they are always checking the BP in the body. They are always checking what? The average BP. Mean arterial pressure means the average BP in the body. Always checking. Okay. Now tell me, whenever the BP increases here, okay, whenever your BP is increasing, whenever your mean arterial pressure is increasing, now these receptors, okay, the carotid baroreceptors and the aortic baroreceptors, they are taking this information via ninth cranial nerve, via the 9th cranial nerve and via the 10th cranial nerve. Via the 9th and 10th cranial nerves, this information, these are the afferents in this pathway. These are the afferents. Via the 9th and 10th cranial nerve, this increase in the BP, this information is going where? To the medulla. In the medulla, who receives this information? Nucleus of tractus solitarius. The nucleus of tractus solitarius, this nucleus, it receives the information about the mean arterial pressure. Now, nucleus of tractus solitarius, it will understand, oh, okay, the BP increased in the body. Now, this nucleus of tractus solitarius, do you know what it will do? It is going to now immediately decrease the heart rate. Okay, it is going to immediately decrease the heart rate, sir. Why? When heart rate decreases, automatically what happened to the BP in the body? After some time, BP will also come down. Okay, so this reflex, whenever your BP increases, immediately what happened to your heart rate? Decreases. So after decreasing the heart rate, again your BP will come back to, slowly back to normal. So this reflex, whatever I have shown here, this is called as a baroreceptor reflex. Tell me, in the baroreceptor reflex, where are the receptors located? Arch of aorta, carotid sinus. What are they sensitive to? They are sensitive to which pressure? Mean arterial pressure. What are the afferents in the pathway? 9th and 10th cranial nerves afferents in the pathway. What is the center for this reflex? Nucleus of tractus solitarius is the center for the reflex. What is the response for this reflex? Heart rate decreases. So always remember, whenever your BP increases, automatically your heart rate will decrease. Again, bradycardia. See. So this law is called as Mary's law. Mary's law, sir. So what is Mary's law? Mary's law will tell you, whenever your BP increases, heart rate will decrease. As we are discussing about some laws here, let me tell you one more important law, that is Frank-Starling's law, here itself. Frank-Starling's law. So what exactly is Frank-Starling's law, students? Normally, how much you will fill the heart? Tell me, how much you are going to fill the heart? That is end diastolic volume. You will fill the heart, no? Your left ventricle. How much you will fill? 120 ml. So that's the normal filling. End diastolic volume at the end of the diastole. At the end of the diastole, how much is filled? 120 ml. You are filling in the heart. Out of this 120 ml, how much will come out? That is the stroke volume. With one heartbeat, one heartbeat, how much will come out? 70 ml will come out. 70 ml will come out. Okay. So you keep 120 ml, 70 ml is going to come out. Now you tell me, when you increase the value, end diastolic volume value from 120 to let's say 200 ml, you have increased it. Okay, you have increased it. So automatically, what happened to the stroke volume? Do you think same 70 will come out? No. You have kept more blood into the heart. You have increased the venous return. You have increased the end diastolic volume. You have increased the preload. So automatically, when you keep more blood in the heart will contract more powerfully. So more will come out. So now in this condition, let's say maybe 160 ml is coming out, sir. 160 ml is coming out. So what I am trying to say, when you increase the end diastolic volume, automatically stroke volume automatically increases. So this law is called as stroke volume is directly proportional to end diastolic volume. If you increase the end diastolic volume, stroke volume increases. This law is called as, okay, this law is called, I should actually write like this. Okay, just wait. Actually, I should write like this. It's the increase in the first I have to write end diastolic volume. If you increase the end diastolic volume, automatically what happens to stroke volume? Increases. Okay, so stroke volume is directly proportional to end diastolic volume. This law is called as Frank-Starling's law. Frank-Starling's law. Tell me what we have completed so far. We have completed baroreceptor reflex also. Okay, baroreceptor reflex also completed. Tell me, in the baroreceptor reflex, ultimately what is happening? Sir, heart rate is decreasing, no? Heart rate is decreasing. So they will ask in your exam, see this baroreceptor reflex, is it a positive feedback reflex or negative feedback reflex? It is a negative feedback reflex. See, heart rate is decreasing. You are trying to bring the BP back to normal. So it's a negative feedback. So negative feedback reflex. Okay, negative feedback reflex. Okay, important about the BP. See, here I have used the word mean arterial pressure. How to calculate the mean arterial pressure? There is a formula to calculate the mean arterial pressure. Normally, you know, systolic BP how much? Systolic BP 120, diastolic BP 80. And what is the difference between the systolic and diastolic blood pressure? The difference between systolic and diastolic blood pressure is called as pulse pressure. Pulse pressure. So how much is the pulse pressure? 120 minus 80 is equal to 40. So pulse pressure is 40. Normal pulse pressure is 40, sir. Now, what is the formula to calculate the mean arterial pressure? I have told you mean means what? Mean means average. Mean arterial pressure is the average BP. So the formula to calculate it is diastolic blood pressure plus 1/3 of pulse pressure. 1/3 of pulse pressure. So how much it will be? How much it will be, sir? Tell me, diastolic blood pressure 80 plus 1/3 of pulse pressure. Normal pulse pressure is 40. So 40 divided by 3, how much? 13. So here 13, sir. 80 plus 13 is going to be 93. That's your mean arterial pressure, sir. So 93 mmHg. So 93 mmHg, sir. 93 mmHg is your mean arterial pressure. So tell me, what is the pulse pressure? Pulse pressure is a difference in the systolic and diastolic blood pressure. How much is that? 40. Okay. That's it. There is one more formula. This is one formula to calculate. Okay, this is one formula. That is diastolic blood pressure plus 1/3 of pulse pressure. This is one formula to calculate the mean arterial pressure. There is one more formula, that is 1/3 of systolic BP plus 2/3 of diastolic BP, sir. So this is also the same to calculate the mean arterial pressure. This is also one more formula. 1/3 of systolic blood pressure plus 2/3 of diastolic blood pressure. That will tell you the mean arterial pressure. Okay, our baroreceptors are mainly sensitive to mean arterial pressure. Next, after this, what else I have to teach you? Sir, where are these baroreceptors located? See, these baroreceptors, they are located, yes, you know, in the carotid sinus and arch of aorta. But in which layer of the blood vessel? They are present in which layer of the blood vessel? Sir, these baroreceptors, they are present in tunica intima, tunica media, or tunica adventitia. They are present in tunica adventitia, sir. That's also a question which was already asked. So these baroreceptors are located in tunica adventitia. These baroreceptors are sensitive to, they are sensitive Sensitive to which BP? Systolic BP and diastolic BP. They are sensitive to mean arterial pressure. The baroreceptors are sensitive to mean arterial pressure. Okay, done. Now, after this, what else I have to teach you is, sir, your BP will fluctuate with inspiration and expiration. Your BP is fluctuating like this, sir. Your BP is not constant always. Don't think that your mean arterial pressure is always 93. Your average BP is slightly fluctuating with every inspiration. With every inspiration and expiration, your BP will slightly fluctuate. Okay, so sometimes it increases and decreases, increases and decreases. So these BP fluctuations are called as Truby Herring waves. Truby Herring waves. So tell me, what are Truby Herring waves? Truby Herring waves are nothing but the BP fluctuations with respiration. So with the respiration, your BP will fluctuate. So those fluctuations are called as what? Truby Herring waves. Truby Herring waves. Okay, done. So with this, what we have completed is all important reflexes that we have completed, sir. All important reflexes we have completed. After this, what I should teach you in your cardiovascular physiology, next most important area is the blood vessels. Okay, let me tell you important points about the blood vessels. Okay, so we are entering into the vascular physiology, sir, now into the vessel topic. Let me talk about the aorta. Okay, important points about the aorta, sir. So aorta, what are the important points? Aorta has least cross-sectional area. Okay, which blood vessel has the least cross-sectional area? Aorta has the least cross-sectional area. So as the aorta is having least cross-sectional area, blood is going very fastly, sir. Okay, so aorta has maximum velocity of blood flow. And that too, how the blood is moving. The blood is going smoothly? No, the blood is going in more turbulent fashion. There will be turbulence seen. The blood moves in turbulent fashion. Turbulent fashion. Okay, turbulent fashion. So the blood goes in a turbulent fashion. Next step. Sir, what is the first branch of aorta? The first branch of aorta, the first blood vessels that comes out of the aorta, first branches. The first branches is your coronaries, coronary arteries. So coronary arteries are the first branches of aorta. See, when you will have maximum blood flow through the coronaries, in which phase do you think the coronary blood flow is going to be seen? Is it seen during systole or diastole? So remember, coronary blood flow is mainly seen during, okay, coronary blood flow occurs during diastole. Okay. See, usually blood flow is happening during systole. Usually the blood goes into the blood vessel during systole. But when the blood will go into your coronaries, it is diastole. Diastole. One more point about aorta is your abdominal aorta. Now I am talking about your abdominal aorta. So your abdominal aorta is the most common site of atherosclerosis. Okay, so abdominal aorta is the most common site for the atherosclerosis. That's also a very important point about aorta, sir. Next, aorta, this blood vessel, it has a maximum Wind-Kessel effect. Maximum Wind-Kessel effect. What does it mean by maximum Wind-Kessel effect? Maximum Wind-Kessel effect means usually major blood vessel has this Wind-Kessel effect, which means during systole they will stretch and they will relax back, they will recoil back, they will stretch and recoil back. Aorta will stretch and it will recoil back. So that effect is called as a Wind-Kessel effect, which is seen with the major blood vessels, and it's a maximum with the aorta. So these are some important points about aorta, sir. Okay. After that, next point is, let's say after aorta, let's talk about arterioles. What are the important points about the arterioles? Arterioles, remember, arterioles, they are called as resistant blood vessels. Resistant blood vessels. Why? Because the arterioles has the maximum smooth muscles. As they're having maximum smooth vessels, so they can undergo constriction. So they can act as a resistance for the flow of blood. So yes, arterioles, they have the maximum smooth vessels, so they are called as a resistant blood vessels, resistant blood vessels. Now tell me, when the arterioles are dilated, what happens? When the arterioles are constricted, what happens? When the arterioles are dilated, blood is going very, very smoothly, blood is going very, very easily into the capillaries, into the tissues. So the afterload decreases. So arterioles determines the afterload. Okay, you know something called as a preload and afterload concept. You have studied in your regular classes. Arterioles, when they are dilated, the afterload on the heart decreases. When they are constricted, afterload increases. So now tell me only one point which I want you to know, the concept of afterload. Afterload, it is dependent on what? It is dependent on arterioles, whether the arterioles are constricted or dilated. When the arterioles are dilated, blood is going very, very smoothly, so the heart have to generate less pressure. The heart can generate less pressure. Okay, let me just explain you in under 1 minute, sir. This is heart, sir. Okay, here is aorta. Aorta is divided into let's say directly I am showing arterioles here. Let's say I am showing the arterioles. So now tell me, heart have to generate how much pressure? Okay, depends on the how much pressure need to be generated by the heart. Depends on whether the arterioles are constricted or dilated. See, when the arterioles are dilated, blood is going very, very smoothly, very, very smoothly. So in order to push the blood forward, in order to push the blood forward into the cardiovascular system, in order to push the blood forward into the vascular system, heart have to generate less pressure. That is, afterload is going to be less. The pressure generated by the heart is called as afterload. The pressure required by the heart to push the blood forward is called as afterload. Now when the arterioles, now tell me, when they are constricted, when the arterioles are constricted, now in order to push the blood forward, heart have to generate high pressures. So what happened to afterload? Afterload increased. So yes, afterload increases with arteriolar constriction, afterload decreases with arteriolar dilation. So it's the arterioles which will determine afterload. Done. Next, about after arterioles, now let's discuss about veins. Okay, now let's discuss about veins. Now veins, they are having maximum, one point which I want you to know regarding veins is maximum blood. Veins contain, okay, maximum blood. How much percentage of your blood? 55% of the blood. 55% of the blood is present in the veins. So which blood vessels has the maximum smooth vessels? Arterioles. Which blood vessel has the maximum blood? Which blood vessels contains maximum blood in the body? Veins. Veins contain maximum blood. Maximum blood. Now, if I am talking about capillaries, see, in capillaries or in blood vessel, let's say this is one capillary. Sir, in capillaries, there are two types of forces present. They are called as Starling's laws of forces. Okay, they are called as Starling's forces. Starling's forces. What are these two Starling's forces? Let me tell you. First Starling force is called as a hydrostatic pressure. See, this hydrostatic pressure is because of plasma. What is this hydrostatic pressure, sir? Hydrostatic pressure always want to move the fluid out of the blood vessel. It wants to always move the fluid into the tissues. Okay, move the plasma into the tissues. Okay, it's like outgoing force. Next pressure is called as oncotic pressure. Oncotic pressure. That oncotic pressure is because of, this is MCQ, albumin. Albumin, what it will try to do? It will try to keep the plasma within the blood vessel. It is trying to, these albumin molecules, they are like sponge pieces. They are like sponge pieces. They are trying to hold the plasma within the blood vessel. Within the blood vessel. Okay. So in every blood vessel, not only in capillaries, sir, in every blood vessel, there are two types of forces present. One is a hydrostatic pressure because of plasma. Other is an oncotic pressure because of albumin. So one is a favoring force. To move the fluid out, other is an opposing force. It is, one is trying to move the fluid out, other is trying to move the fluid in or keep the fluid in, sir. So these two forces are called as Starling's forces. The question which was asked in the exam is oncotic pressure is due to albumins. Okay, done. Now with this, what we have completed, the important points about the blood vessels also completed. Now last point about the vascular physiology is the blood flow. The flow of blood within the blood vessel. The flow of blood within the blood vessel, it is dependent on Q. It is dependent on four things. One is pressure difference and radius to the power of 4 and inversely proportional to, inversely proportional related to length of the blood vessel and viscosity. So this formula is called as Poiseuille-Huygens formula. Okay, Poiseuille-Huygens formula. Okay, so what is this Poiseuille's law? What is this Poiseuille's law or Poiseuille-Huygens formula is telling you? So the flow of blood, it is dependent on, the flow of blood is dependent on 4 parameters. That is the pressure difference across the blood vessel. Okay, more the pressure difference, more blood will go. Radius, more the radius, more blood will go. But inversely proportional to, when the length increases, blood flow decreases. When the length of blood vessel increases, blood flow decreases. And when the viscosity of the blood, increases, blood flow decreases. Okay, based on this, now you tell me, sir, here is a blood vessel A. Here is a blood vessel B, sir. Okay, here is blood vessel B. Okay, so here everything same, sir, everything same. What is difference? Here radius is R, here the radius is 2R. Okay, radius is 2R. So tell me, when compared to A, in B, more blood will go or less blood will go? More blood will go, sir, because more the radius, more blood will go. How much more blood will go, sir? How much more blood will go? So Q is directly proportional to R to the power of 4. What happened to the radius in this condition? Radius doubled. So Q is equal to 2 to the power of 4, sir, that is 16 times. 16 times. You understand? So when you simply double the radius, 16 times more blood will go, sir. 16 times more blood will go. If you triple the radius, how many times more blood will go? If you triple the radius, 81 times more blood will go. Okay, 81 times more blood will go. So this Poiseuille-Huygens formula is also important. The blood flow is dependent on 4 parameters, that is pressure difference and radius, but inversely proportional to length of the blood vessel and inversely proportional to viscosity of the fluids, viscosity of the blood. Okay, so with this, the Poiseuille-Huygens formula also done, completed. Now after this, let's start the next system, that is respiratory physiology. Okay, respiratory physiology. See, in the respiratory physiology, what are the important things that you should know? Let me tell you, it's very respiratory physiology, how many marks you will be getting? You will be getting somewhere around 2 to 3 marks you will be getting, sir. Okay, you will be getting 2 to 3 marks you will be getting. What are the important topics that you should know in the respiratory physiology? First topic is surfactant. Okay, first topic number 1 is surfactant. Sir, surfactant, it is produced from type 2 pneumocytes. Surfactant is produced from type 2 pneumocytes. Okay. Next, surfactant, what it will do? It decreases surface tension. Okay, decreases which force in the lung? It decreases the surface tension forces in the lung. Okay. Next, surfactant production is increased by. Surfactant production is decreased by. Surfactant production, it is increased by steroids. Okay, steroids increases the production of surfactant. Steroids increases the surfactant production as well as thyroid hormones. Thyroid hormones. And who inhibits the surfactant? Insulin. So insulin is a hormone which inhibits the surfactant. Steroids are the hormones which promote the surfactant. Okay. Next, surfactant, what is it, sir? Surfactant, it is a majorly a lipid. It's a phospholipid. Surfactant, majorly it's a phospholipid. So what are the major lipids? The major lipid is called as lecithin. Lecithin is the major lipid of the surfactant. And what is the minor lipid? The minor lipid is called as sphingomyelin. Okay? Sphingomyelin. Major lipid is lecithin, minor lipid is called as sphingomyelin. So if the ratio in the amniotic fluid, see in the amniotic fluid, so actually amniotic fluid goes into the fetal lungs, it comes out of the fetal lungs. So in the amniotic fluid, if you see lecithin sphingomyelin ratio, lecithin to sphingomyelin ratio, if it is greater than 2, it indicates fetal lung maturity, fetal lung maturity. Okay, so now tell me fetal lung maturity, what is the ratio that is taken? Lecithin to sphingomyelin ratio. Lecithin is a major lipid, sphingomyelin is a minor lipid. Now what is the best test if they ask you for assessment of fetal lung maturity? What is the best test? If they ask best test is presence of phosphatidyl glycerol. Presence of phosphatidyl glycerol in amniotic fluid. Okay, presence of amniotic fluid, so presence of this chemical called as phosphatidyl glycerol in the amniotic fluid, that's the best test for the assessment of fetal lung maturity. That indicates fetal lung maturity, sir. 100%, that's the gold standard, that's the gold standard. Okay, next, after this, what else I have to teach you regarding the surfactant? See, surfactant production started, okay, let me write it here itself. So surfactant is coming from the type 2 pneumocytes. Okay, type 2 pneumocytes. Surfactant production started when, sir? 20 weeks of period of gestation. Surfactant production has started from 20 weeks of period of gestation. Okay, and where is the surfactant stored? The surfactant, it is stored in special vesicles called as lamellar bodies. Lamellar bodies. So it's the lamellar bodies are the places where the surfactant is stored. Okay, next step. After this, let me explain you the next topic. I am going to the next topic. Okay, the next topic that I am going to explain here is mechanics of breathing. Mechanics of breathing. See, in the topic of mechanics of breathing, how air enters into the lung, how air comes out of the lung. Okay, that's the topic, mechanics of breathing. Let me show you here. Let's divide this into two parts. Okay, during inspiration, what happens, and during expiration what happens. During inspiration as well as during expiration what happens. Let me show you the entire lung here. Okay, here is the lung, here is the alveolus, here is the alveolus. Now during inspiration, what happens is the intra-alveolar pressure, the pressure here, sir, the pressure in the alveolus, the intra-alveolar pressure, they will ask you what happened to intra-alveolar pressure. The intra-alveolar pressure becomes -1. Outside it is 0, you can't change outside, sir. Atmospheric pressure is 0. We consider 760 mmHg as 0 atmosphere, let's say. Now during inspiration, what happens? The intra-alveolar pressure becomes -1. Okay, and what happened to intrapleural pressure? Okay, let me show the intrapleural pressure here. So the intrapleural pressure, it becomes -6 mmHg, -6 mmHg. So the 2 points which I am talking here. So the intrapleural pressure during inspiration, it is going to be -6 mmHg. From actually its value is -2.5. Normally its value is -2.5 mmHg. Okay, in the beginning, during resting state, it is -2.5 mmHg. From -2.5, it goes to -6 mmHg. Okay, that's the one change. And during inspiration, what happens? During inspiration, the intra-alveolar pressure becomes negative, less value here. So now tell me, automatically air will go from high pressure to low pressure. High pressure to low pressure. Done. And what happens during expiration? See, during expiration, the same thing. Let's say here is your lung. Here is your alveolus. What happened to your outside pressure is 0. What happened to your intra-alveolar pressure? Intra-alveolar pressure becomes +1. It becomes +1. And what happened to the intrapleural pressure? Intrapleural pressure, it is again going back to from -6, it will again come back to -2.5 mmHg. Again it is going back to -2.5 mmHg. So now tell me, sir, here high pressure +1, here outside 0, so automatically air will come out. Air will come out. Okay, so this is how air goes into the lungs. This is how air goes into the lungs from high pressure to low pressure. And during expiration, air will come out of the lungs from high pressure to low pressure. So now tell me, intra-alveolar pressure during inspiration -1, during expiration +1. How intrapleural pressure will change? Intrapleural pressure -6 during inspiration, -2.5 back again during expiration. Okay. Next, let's discuss about, after this, now let's discuss about the next most important area in the respiratory system is ventilation perfusion ratios. Okay, I am directly going into the topic of ventilation perfusion ratios, sir. Ventilation perfusion ratios. Okay, ventilation perfusion ratios. This is the next most important area. Now, what are these ventilation perfusion ratios? Let me tell you what is normal. In your lung, how much ventilation will occur every minute? Do you know how much ventilation will occur? 4 liters of air will go into your lungs. And how much blood will go to your lungs? 5 liters of blood will go to your lungs every minute. Every minute 5 liters of blood will go to your lungs from the right side of the heart. So tell me, what is the normal ventilation perfusion ratio? Normal ventilation perfusion ratio is 0.8, and that is normal. That is normal. But in some conditions, ventilation perfusion ratios are going to be different, sir. Where? Let me tell you. If they specifically ask you ventilation perfusion ratio in the apex of the lung, in the upper lobes of the lung, the value will be 3.2. Okay. In the base of the lung, the value will be 0.6. 0.6. Okay. This is normal, always. Apex may 3.2, base may 0.6. The average value is going to be 0.8 in the entire lung if we take it. Now, in some conditions, this ventilation perfusion ratio, the V/Q ratio is going to be infinitive. In some conditions, the ventilation perfusion ratios is going to be 0, sir. Where? Which conditions? It's going to be infinitive. The ventilation perfusion ratio, it is going to be infinitive in 2 conditions. One is pulmonary embolism. Pulmonary embolism. Why it is infinitive, I am not explaining you. Simply I am telling you, the ventilation perfusion ratios becomes infinitive in which condition? Pulmonary embolism. And the same ventilation perfusion ratio is infinitive again in anatomical dead space, sir. You know there is something called as anatomical dead space. Even in anatomical dead space, the ventilation perfusion ratios are going to be infinitive. Okay, infinitive. Next, where the ventilation perfusion ratios are going to be 0. It is 0 in which condition? It is 0, it will become 0 in 3 conditions. Okay, one is atelectasis, foreign body obstruction, in the airway foreign body obstruction, and next one is airway compression. Airway compression. So in these conditions, the ventilation perfusion ratio is going to be becoming 0, right? Next, after this, let me explain you the topic of flow volume loops. Flow volume loops. Let me explain you what is a normal flow volume loop. See, this is a normal flow volume loop. Let's say here, this is a normal flow volume loop. On the x-axis, let's say like this. On the x-axis, this is y-axis. On the x-axis, I am talking about the volume changes. Volume changes, how much air is going into the lungs, how much is coming out of the lungs. So here I am talking about inspiration. This is how inspiration will occur. On x-axis, I am showing the inspiration. See, your inspiration is starting at this point, sir. It's not starting from 0. It's not starting from 0. Your inspiration is starting from this point, which means already in your lungs some air is there. That is called as residual volume. So how much residual volume will be there? 1.3 liters of air is already there in your lungs. So I am the person, I am asking you, take air, sir. So you are starting inspiration. Okay, inspiration. So gradually the air is entering into your lung with more speed. Okay, on y-axis I am talking about velocity, or you can say flow or velocity, sir. So Okay, now how much maximum air you can take? 6 liters. Okay, 6 liters. Okay, so here I am talking about the volume changes. You are increasing your lung volume from 1.3 liters, you are increasing it up to 6 liters. So here I am showing you the inspiratory loop. And if I ask you to do the expiration fastly, so you are doing expiration. So air is coming out of your lungs. Okay, let me show you with a different color. Air is coming out of your lungs. Initially air is coming out with very high speed, very high speed, and gradually the velocity decreases. So initially air is coming out with very high speed, and later air is coming out with gradually less speed. Velocity initially increases, later decreases. Okay, so this is expiratory loop, and downside I am talking about inspiratory loop. So you are starting your inspiration from residual volume up till your 6 liters, and while you are doing expiration forcefully, while you are doing expiration from 6 liters, you are going back to 1.3 liters. So this is a normal flow volume loop. No one will ask you about this normal flow volume loop. What they will ask you, sometimes this flow volume loop is going to shift to right side, sometimes this flow volume loop is going to shift to left side, sir. So now let me tell you in which conditions it will show right shift, in which conditions it will show left shift. So right shift is seen in right shift of the flow volume loop. Right shift of the flow volume loops are seen with R for R, restrictive lung diseases. In restrictive lung diseases, there will be a right shift. In obstructive lung diseases, okay, in obstructive lung diseases like emphysema, there will be left shift. So this flow volume loop, it is either going to undergo right shift or left shift. In obstructive lung diseases, left shift. In restrictive lung diseases, right shift will be seen. Okay, so can you tell me any other, okay, flow volume loops are different in obstructive lung diseases and restrictive lung diseases. These flow volume loops, they will change. Okay, but will there be any other change in obstructive and restrictive lung diseases? Will there be any other change in obstructive and restrictive lung diseases, sir? Yes. What are the other changes? Let me tell you, in a normal person, let me tell you what is normal. Okay, normal. In a normal person, there is something called as FEV1 by FVC ratios. FEV1 by FVC ratio in a normal person. The normal value is going to be 0.8, sir. Normal value. This is not V by Q ratio. This is different. In a normal person, FEV1 by FVC ratios are 0.8 without any doubt. It will come in medicine also. But if I am talking about obstructive lung disease, do you know what happens? In obstructive lung diseases, look, the FVC values will be normal. FEV1 values will be less, decreased. FVC values in this person will be normal. Okay, so if you do FEV1 by FVC ratio, that is the numerator divided by denominator. So what is happening, sir? Numerator is decreasing, denominator is normal. So what happens in obstructive lung diseases? What happens? It is less than 0.8. So most of the time it is less than 0.7. So in obstructive lung diseases, I am telling you, see, in obstructive lung diseases, the FVC will be normal, FEV1 will be decreased. So FEV1 by FVC ratios are also going to be decreased. Normal FEV1 by FVC ratio is, in normal person it is 0.8, in this person it is 0.1. Sorry, it's less than 0.7. In restrictive lung diseases, look, in restrictive lung diseases, what happens, sir? FEV1, it is reduced, and FVC, both are reduced. But proportionately, both are reduced proportionately. As both are getting reduced proportionately, so their FEV1 by FVC ratio will be normal. The ratio is going to be normal, sir. Okay, the FEV1 by FVC ratio will be normal. So never ever forget, sir, in obstructive lung diseases, FEV1 by FVC ratio is less than 0.7. In restrictive lung diseases, the FEV1 by FVC ratio will be normal or even increased. So that's the test, FEV1 by FVC ratios. These are the tests which are used to differentiate between obstructive lung diseases and restrictive lung diseases. Okay, so these ratios will change, sir. Done. Now after this, what else I have to teach you? The spirometry curves. Okay, spirometry. So in the spirometry, look, this is how a spirometry curve is going to be like. normally you will take 500 ml air in, 500 ml air out. So these are your inspirations, expirations. Your normal inspiration and normal expiration, sir. So these volumes are called as tidal volumes. These volumes are called as what? Tidal volumes. You will take 500 in, 500 out. These are your normal tidal volumes. But if I ask you to take extra air in, if I ask you to take as much air as possible, sir, can you take extra air upon tidal volume? Yes, you can take some extra air into your lungs. So this extra air that you can take into your lungs extra, this is called as your inspiratory reserve volume. Inspiratory reserve volume. Okay. Next, again you are going back to normal tidal volume, expiration done. After that, I am asking you, sir, can you do in extra expiration possible? Can you do extra expiration? Yes. You can take out some extra air out of your lungs, sir. So this is called as expiratory reserve volume. Expiratory reserve volume. And again, these are normal tidal volumes. Okay, normal tidal volumes. So now tell me, after normal, see, okay, just wait. Here are the tidal volumes. This dotted line, okay, this dotted line, this is the tidal volumes. Normal inspiration, expiration, in, out, in, out. Now, whatever you do, some air is always left over in the lungs, sir. Some air is always left over in the lungs. That is called as residual volume. Residual volume will never come out. How much is the residual volume? 1300 ml. How much is the expiratory reserve volume? The expiratory reserve volume is 1200 ml. Okay, and how much is the tidal volume? 500 ml. And what is the inspiratory reserve volume? 3000 ml. Okay, now I am asking you, sir, after normal expiration, this is the normal expiration, no? How much air is present in your lungs? How much air is present in your lungs? You have both the expiratory reserve volume plus residual volume. Both are there. So that is called as functional residual capacity, FRC. So can I say something like this? Functional residual capacity is equal to, it's a sum of expiratory reserve volume plus residual volume. Okay, expiratory reserve volume plus residual volume. Okay. Now what are these two volumes together called as? If I am pointing from here, top till here, what is this? It includes tidal volume plus inspiratory reserve volume. So that is called as your inspiratory capacity. So what is IC, guys? Inspiratory capacity is your inspiratory reserve volume plus tidal volume. Okay, tidal volume. Next, what is your VC, sir? Vital capacity. What is a vital capacity? Vital capacity means after maximum inspiration, look here, after taking the maximum inspiration, how much air you can take out? First, you can take out inspiratory reserve volume, you can take out tidal volume, and even you can take out expiratory reserve volume also. You can take out the expiratory reserve volume also. So vital capacity is equal to inspiratory reserve volume plus tidal volume plus expiratory reserve volume. Okay, that is what is called as your vital capacity. Okay, vital capacity. Okay, so if you add all these volumes together from top to bottom, if you add all these volumes, that is called as a total lung capacity. Total lung capacity. Okay, so these pyrometric curves are very, very important. They will ask you, mainly they will ask you this area, sir. Okay, from here to here. Okay, from here to here, that is called as a functional residual capacity. Okay, functional residual capacity means the air that is left over in the lungs. See, the air that is left over in the lungs after normal quiet expiration. After normal quiet expiration, how much air is there? Usually students will think residual volume. No, it's not the residual volume which is present. It's the residual volume along with expiratory reserve volume. Okay, so that is called as your functional residual capacity. Now after this, the last thing that I want you to know in the respiratory physiology is oxygen hemoglobin association, dissociation curves. Okay, association dissociation curve, oxygen hemoglobin association dissociation curve. See, these are the relationship between, see what exactly we are learning in the oxygen hemoglobin association dissociation curve. See, what we are learning is the relationship between the wife and husband, sir. Like, you know, like oxygen and HB for hemoglobin. Okay, the relationship between here, HB is like, you know, hemoglobin is like acting like a husband, oxygen is like a wife, sir. So what is the relationship between them? Okay, see, that we will explain, that we will discuss in the oxygen hemoglobin association dissociation curves. Okay, see, sometimes these curves, they will undergo right shift. Sometimes these curves will undergo left shift. So in which conditions there will be a right shift, and in which conditions there will be a left shift. See, right shift means what? Right shift means more oxygen release it to the tissue. Hemoglobin is releasing the oxygen. More oxygen is released to the tissues. So, more oxygen delivery to where? To tissues. And what does it mean by left shift? Left shift means less oxygen delivered to tissues by hemoglobin. Less oxygen is getting delivered sometimes, and sometimes more oxygen is getting released to the tissues. Now, in which conditions you will have such a right shift of the oxygen hemoglobin association dissociation curve? Right shift, it is seen in exercising conditions. Exercising conditions. Whenever you do exercising conditions, what happened to the carbon dioxide levels in the body? Increases. What happened to the oxygen levels in the body? Decreases. What happened to your body temperature? Increases. What happened to the acid production in the body? Increases, because you know, exercise, lactic acidosis, more acid will be produced. So the patient is going to have acidosis. And whenever you are doing exercise, what happens to your pH, sir? pH will decrease. Okay, pH will decrease, more protons are produced, acidosis, and less pH. Okay, now what happened to the 2,3 DPG levels in your RBC? The 2,3 DPG levels in your RBC increases. Okay, 2,3 DPG levels in your RBC increases. So they are all indicating what? So they are all indicating high metabolism in the body. Acidosis. See, whenever you are having more metabolism, more acids will be produced, more carbon dioxide will be produced, more body temperature will be produced. So during these conditions, which shift will occur? Right shift will occur, so that whenever you are simple logic, whenever you are doing more exercise, more oxygen should have to go to your tissues. More oxygen should have to go to your tissues. So right shift, they will ask you. Right shift is seen in which conditions? These conditions. These are the list of conditions. And in the same way, in which conditions you will see the left shift? Exactly opposite conditions. Whenever your metabolism decreases. Metabolism decreases, or whenever your carbon dioxide level decreases, or whenever you are having alkalosis. Okay, whenever you are having alkalosis, or whenever your pH increases, and there is a special type of hemoglobin, sir, which is called as a fetal hemoglobin. Fetal hemoglobin. This fetal hemoglobin also shows left shift, which means hemoglobin is tightly binding the oxygen. It is tightly binding the oxygen. It is not releasing the oxygen to the tissues. So left shift is seen in whenever your metabolism decreases, or carbon dioxide level decreases, alkalosis in the body, pH increases, or body temperature decreases. So in these conditions, there will be a left shift of oxygen hemoglobin association dissociation curves. Okay, very, very important topic. Now after this, two more things I want you to teach here, the just terms: Bohr's effect and Haldane's effect. What is this Bohr's effect and Haldane's effect? Bohr's effect is hemoglobin releasing what? Oxygen to tissues. Okay, at the level of tissues, see, at the level of tissues, in your tissues, what the hemoglobin will do? Hemoglobin releases the oxygen. Why? Because in your tissues, what happen? In your tissues, the partial pressure of oxygen will be less. One thing. And in your tissues, there is more temperature. In your tissues, there is more carbon dioxide. Okay, at the level of your tissues, there is more acids present. So because of this, sir, decrease in the PO2, partial pressure of oxygen, increase the temperature, increase the carbon dioxide, increase acids, they will all tell the hemoglobin to release oxygen. So hemoglobin releasing oxygen to the tissues due to decreasing in the partial pressure, increasing in the temperature, increasing the carbon dioxide, increasing the acid levels. That effect is called as Bohr's effect. Bohr's effect is what? Release of oxygen. Okay, and in the same way, what is Haldane's effect? Bohr's effect, remember, always occurs at the level of tissues. What is Haldane's effect? Haldane's effect is release of carbon dioxide. Where? Carbon dioxide into lungs. Okay, so what is Haldane's effect? Now the hemoglobin, what it is doing? It is releasing, or you can say RBC is releasing the carbon dioxide to the lungs. So the carbon dioxide will come away. So that effect is called as Haldane's effect, sir. So Haldane's effect occurs in the lungs. Bohr's effect is the release of oxygen to the tissues. Haldane's effect is the release of carbon dioxide into the lungs, sir. Okay, so these are the two effects which I want you to know for your exam. Okay, Bohr's effects and Haldane's effect. Okay, so again I am telling you, in your respiratory system, these are just like a revision, fast track revision. Okay, so in your respiratory system, very very important topic, surfactant, when it is produced, from where it is produced. Okay, surfactant is important. Surfactant production is increased by, surfactant production decreased by, surfactant is made up of lipids, which type of lipids, their ratios, surfactant is important. Next, flow volume loops is important. Ventilation perfusion ratios is important. The shifts, right shift of flow volume loop, left shift of flow volume loop, FEV1 by FVC ratios, how they are different in obstructive and restrictive lung diseases, and when the right shift is going to occur, when the left shift is going to occur in the oxygen. These are oxygen hemoglobin dissociation curves. Okay, and about the spirometry curves. Okay, the image based questions, the spirometry curves, these are very very important for your exam. Okay, other topics are also there, but these are very high yielding topics, very high yielding topics. Now after this, the last system that we are going to discuss is the nervous system. Okay, central nervous system. In this central nervous system, what you have to know, in this central nervous system physiology, what you have to know, I will tell you. Okay, 5 important topics are there. The 5 important topics are there. I will tell you what are the 5 important topics that you should know for your exam. Okay, see guys, I have already made a video on the already I have made individual systems, rapid revision of individual systems. Last just 5 months back, I have made the rapid revision of the individual systems. Okay, so I highly recommend you. I have gone there slowly. Individual systems rapid revision I have already done there. See, in that I have done the rapid revisions of the general physiology also. So I highly recommend you to watch the general physiology there. Okay, it recently recorded 4 months or 5 months back I have recorded. So general physiology, the entire general physiology, the cell membrane, transport of the substances, muscle physiology, nerve physiology, I have recorded over there. That will be like 2.5 hours video. That will be like a 2.5 hour video will be there. Okay, the entire general physiology I have recorded. So I highly recommend you to watch that. Okay, in that videos. Okay, now I will do the central nervous system. After doing the central nervous system, we will wind up the topic. Okay, so central nervous system, what are the important topics that you should know for your exam? Let me tell you. In central nervous system, let me tell you. First topic number 1 is your receptors, touch receptors. Okay, touch receptors. There are different types of touch receptors. Meissner's corpuscles, Pacinian corpuscles. One receptor is important for detecting different types of touch. For example, Meissner's. Say Meissner's corpuscles are going to detect which kind of touch? Fine touch. Meissner's corpuscles will detect fine touch. They are good in detecting very fine touch. Okay, and they will detect low frequency vibrations. Okay, low frequency vibrations. They will detect fine touch as well as the low frequency vibrations. Next up, Merkel cells. So the Merkel cells are going to detect. Mainly these cells, the Merkel cells with the touch receptors, they are mainly detecting. You know what they will detect? They are best in detecting 2-point discrimination. A sense called as a 2-point discrimination. Okay, ability to discriminate between 2 points. That is called as a 2-point discriminatory sense. So which receptors are best for 2-point discrimination? Merkel cells are best for 2-point discrimination. So they are also best for reading Braille script. You know, blind persons read what is written on the surface with the help of some elevations will be there, dots will be there. So which receptors are helping in reading Braille script? Sir, in reading the Braille script, which receptors are helping? Merkel cells are helping. Okay, they are best in 2-point discrimination. And where you will have the best 2-point discriminatory sense? The best 2-point discriminatory sense is present in your fingertips. The best 2-point discrimination is seen in your fingertips. Done. Next, Pacinian corpuscles. The Pacinian corpuscles, these are also touch receptors. They will detect which touch? Sir, deep touch. They will detect deep touch or crude touch, let's say. Pacinian corpuscles, Next point is they are best receptor for vibratory sense. They are best receptor for vibratory sense. Okay, they are best receptor for vibratory sense. Or they can say they are best receptor for high frequency vibrations, high frequency. Okay, they ask you what are the best receptor for high frequency vibrations or what are the best receptor for just simple vibratory sense. It's the Pacinian corpuscles, Pacinian corpuscles. And also remember, Pacinian corpuscles, these are the most sensitive, they are the most sensitive receptors. Of course, they are touch receptors. Vibration is nothing but a touch, no. They are most sensitive. They are most sensitive touch receptors. Okay, so if you look at a Pacinian corpuscle, there is an image based question, sir. If you look at a Pacinian corpuscle looks like this, like like an onion rings appearance will be there. Okay, so this Pacinian corpuscle, it is having this lamellations. Okay, the capsule is in the form of layers. So it's a lamellated receptor or capsulated receptor. It's lamellated as well as capsulated. The capsule looks like a lamellations. Okay, all others are also capsulated only. Mesenteries are also capsulated, but it is not having that appearance. Merkel's, it is not capsulated. Very, very important. Not capsulated or uncapsulated. It is uncapsulated. Merkel's is uncapsulated. Very, very important. It is uncapsulated. Okay, so done. These are some important touch receptors which I want you to know for your exam. Okay, after this, what else I should teach you? See, the touch is carried by which type of neurons? Okay, touch is carried by which type of neurons? For example, let me write here type of neuron. Here sense. Sir, senses. Here sense is touch. Touch is carried by which type of nerve fiber? That is A beta fiber. There is a type of neuron called as A beta fibers. Which will carry touch information. Okay. Next about the pain, sir. Pain. If I am talking about fast pain, the fast pain is carried by A delta fiber, A delta type of neurons. And if I am talking about slow pain is carried by C fibers. Okay, done. Next, in the same way, let me discuss other senses also now itself. Sir, for example, temperature is also a sense. Hot temperature and cold temperature. Hot temperature is carried by which fibers? Hot temperature is carried by C fibers. And cold temperature is carried by A delta fibers. Okay, same A delta. So these sensations are also carried by which fibers? So they will ask you in the central nervous system, there are different types of neurons present. Different types of neurons carries the different types of sensations. Now we will start to have it out. Sir, what are these neurons like A, B, C you are giving? Let me tell you, the neurons in your body are classified into A, B and C types. Okay, A, B and C types, A, B and C. Look at A type of neuron. A type of neurons are like this, B type, and these are C type. What is the difference between A, B, C and C? A type of neurons are very big in size, B are small and C are even smaller, sir. And not only that, A type of fibers, they are having high myelination around them. A type of fibers, they are having high myelination. So highly myelinated. Okay, highly myelinated. B type of fibers are having little myelination. C type of fibers are unmyelinated, sir. Unmyelinated. So now tell me, what is the difference between A, B and C? A, B and C. Sir, A, B and C, the size wise they are different and the myelination wise they are different. So when you are going from A to C, see, as you are going from A to C, what decreases? As you are going from A to C, myelination decreases, diameter decreases, myelination decreases, the diameter decreases, and velocity of impulse conduction also decreases. Diameter decreases, myelination decreases, and velocity also decreases. The velocity of impulse conduction, sir. Okay, all decreases, all decreases. Okay. Now, here itself, let me tell you. So, the A was further divided into A fibers. A fibers are further divided into A alpha. Okay, let me just erase this. A fibers are highly myelinated. No, let me write it here. Highly myelinated. See, A is further divided into A alpha, A beta, A gamma, A delta. Okay, A is further divided into A alpha, beta, gamma, delta, sir. Now, what I am trying to say, see, whenever you apply pressure, okay, whenever you apply pressure like this, whenever something is crushing you, whenever something pressure is there, this pressure is going to definitely damage the neurons or not? Yes. So, pressure is going to damage which type of neurons? Very, very important MCQ. Okay, pressure is going to, okay, which neurons are highly susceptible to pressure? It's a alpha, sir, alpha, followed by B, followed by C. So, pressure is going to kill which neurons first? A alpha. A alpha will be died first. When you apply pressure, A alpha fibers will die first, followed by B fibers, followed by C fibers, followed by C fibers. So, yeah, neurons are classified in your body into different types. Okay, there's A, B, C, okay, based on the myelination as well as the diameter. This is the classification. Let me take the classification. Classification of what? Neurons in the body. Classification of neurons in the body. Okay, A alpha fibers are highly susceptible to pressure. Next, after this, let me discuss about tracts, sir. Here, I have to discuss about the tracts. Okay, tracts. Let me divide the tracts into two parts: ascending tracts, and descending tracts. Descending tracts. Okay, ascending tracts and descending tracts. Okay, just wait. Now, let me drag this here. This is a new topic. Now, first let's discuss about the ascending tracts. Okay, how many types of ascending tracts are there? How many types of ascending tracts do we have? In anatomy also this will come. There are two types of ascending tracts. What are the two types of ascending tracts, guys? The two types of ascending tracts are anterolateral tracts, anterolateral spinothalamic tracts. Anterolateral spinothalamic tracts. And what is the other ascending tracts? The other ascending tracts are called as the dorsal column tracts. Dorsal column tracts. Dorsal column tract. Okay, so there are two types of ascending tracts. One is the anterolateral spinothalamic tracts and dorsal column tracts. Now, look at here. So, this anterolateral is further divided into two types: anterior spinothalamic and lateral spinothalamic. So, right here, anterolateral spinothalamic tracts are further divided into AST, anterior spinothalamic, and lateral spinothalamic. Okay, lateral spinothalamic. Now, what is the function of this anterior spinothalamic tract? What it is carrying to the brain? What it is taking to the brain? Which information it will take to the brain, sir? Anterior spinothalamic tract, it carries two sensations. It carries two sensations to the brain. What are they? Anterior spinothalamic tract, it carries crude touch and pressure. Crude touch and pressure. And lateral spinothalamic tract, it carries pain and temperature. So, now you tell me, if the lateral spinothalamic tract is damaged, the patient is going to lose pain and temperature. If the anterior spinothalamic tract is damaged, the patient is going to lose crude touch and pressure sensation. Okay. Then what about the dorsal column tracts? So, these dorsal column tracts, they are highly advanced. They are taking advanced sensations, sir. Okay. They are carrying which sensations? Let me write here, advanced sensations. What are the advanced sensations? What are those advanced sensations, sir? Let me write here. They are carrying advanced sensations. What are they? The advanced sensations include fine touch, vibration, proprioception, two-point discrimination, and stereognosis. So these are the advanced sensations. So advanced sensations are carried by the dorsal column tracts. Advanced sensations are carried by the dorsal column tracts in the spinal cord, and the primitive sensations are carried by the primitive sensations like see, touch, pain, temperature, pressure. They are carried by the anterolateral tracts. Anterolateral tracts. Okay. So these are the ascending tracts that I want you to know. Next, what are the descending tracts? There are how many types of descending tracts, sir? There are two types of descending tracts. What are they? The two types of descending tracts, they include, okay, the two types of descending tracts, they include the corticospinal tracts. Corticospinal means they are coming down, they are coming from the cortex, they are coming from the cortex, they are descending down into the spinal cord. Corticospinal, okay, corticospinal and extrapyramidal. Extrapyramidal tracts. Okay, extrapyramidal tracts. Now, there are two types of descending tracts, corticospinal tracts, extrapyramidal tracts. Now, tell me what is the function of this descending tracts? Descending tracts are motor in nature. They are motor. They are motor in nature, which means they will help in movements of the body. They will help in the contraction of the muscle. They will help in the contraction of the muscle. Now why do we require two types of descending tracts? Corticospinal tract along with one exception I am telling you. Corticospinal tract along with one extrapyramidal tract. That extrapyramidal tract example here I am telling you is rubrospinal. Corticospinal along with the one extrapyramidal tract called as a rubrospinal tract, it helps in muscle contractions. Which muscle contraction? Fine movements in the body. It is responsible for what? Controlling fine movements in the body. Controls fine movements, fine voluntary movements in the body, controlling the distal group of muscles. And what about the other extrapyramidal tracts? Other extrapyramidal tracts include tectospinal, vestibulospinal, okay, reticulospinal. All these are, okay, other remaining extrapyramidal tracts. Okay, what they will do? They will control gross, not fine, sir, gross motor control. Okay, gross motor control, not the fine motor control, gross motor control. Understand? So now these are the totals. These are the total tracts in the body: ascending tracts, descending tracts. Ascending tracts are of two types. Okay, anterolateral tracts. Look here. Anterolateral tracts, they are carrying the primitive sensations. The dorsal column tracts are carrying the advanced sensations. And what about the descending tracts? The descending tracts are also of two types: corticospinal tracts, extrapyramidal tracts. Corticospinal along with the rubrospinal, they control the fine movements in the body, and extrapyramidal tracts, they are going to control the gross voluntary motor movements in the body, like maintenance of the posture. Okay, so gross motor control like maintaining posture, tone in the muscles, balance. Okay. Now, one question was asked regarding the tone, sir. In one of the FMG exam, the question which was asked regarding the tone. Can you tell me what is a tone? What is a tone? Tone means, look, I am like this. I am just doing like this. Okay, what I am doing? Now I am just stretching the muscles. Okay, so my muscles, they will offer some resistance. Okay, when I am doing like this, my muscles, they will offer some resistance for the movement. So resistance against passive stretch is called as a tone. So I am trying to stretch it, my muscles will offer some resistance to it, that is called as a tone, sir. Tone means resistance against passive stretch. Resistance against passive stretch is called as what? Tone. Resistance against passive stretch is called as tone. That's the MCQ already asked in the exam. Okay, resistance against passive stretch is called as a tone. Next, after this, now let me explain you clinicals. Here, let's say this is the spinal cord. Okay, here is the spinal cord, sir. Okay. Now, in the spinal cord, see, this area is called as a dorsal column. You anyway know it. This is called as a dorsal column. Now, in the spinal cord, these are your lateral horns. Sorry, not lateral horns. Sorry, these are your ventral horns. Like this. So, these are your dorsal horns. These are your dorsal horns. These are your ventral horns. Okay, you know it anyway. Now, tell me what is the tract that I am showing here? The tract that I am showing here, this is a dorsal column tract. What is the name of it? Called as fasciculus gracilis. And one more tract which I am showing here, this is called as fasciculus cuneatus. These are the dorsal column tracts, fasciculus gracilis, fasciculus cuneatus. Okay. Here I am showing you, this is the lateral spinothalamic, LST. And here I am showing you anterior spinothalamic, AST, anterior spinothalamic. You know, these dorsal column tracts, fasciculus gracilis and fasciculus cuneatus, they are carrying the advanced sensations from the body. And lateral spinothalamic tract, it is carrying which sensation to the brain? It is carrying the pain and temperature, and the anterior spinothalamic is going to carry pressure and crude touch. Now you tell me, if half of the spinal cord is damaged, do you know what happens? Sir, if the half of the spinal cord is damaged, now you tell me which tracts are affected? Is it the dorsal column tracts are affected or the anterolateral tracts affected? See, these are anterolateral, these are the dorsal column tracts. If half of the spinal cord is damaged, now tell me which tracts are affected? Both. So now write, there is loss of, due to damage to these tracts, right, there is loss of advanced sensations on, okay, now let us say this is right side, this is left side. Now the patient is going to lose the advanced sensation on the left side only, same side. So loss of advanced sensations on same side of lesion, Okay, but now tell me, because of due to loss of LST and AST, due to damage to the lateral spinothalamic and anterior spinothalamic, sir, they are carrying primitive sensations. Okay, but from which side of the body? They will carry the primitive sensations from the opposite side of the body, sir. So now due to damage of this LST and AST, there is loss of primitive sensations or touch, pain, temperature, pressure. Primitive sensations, okay, loss of primitive sensations on opposite side. Okay, loss of primitive sensations on opposite side of the lesion. Okay, opposite side of the lesion. So now this syndrome is called as what? Brown-Séquard syndrome. Brown-Séquard syndrome. So what exactly is Brown-Séquard syndrome, guys? In Brown-Séquard syndrome, sir, there is hemisection of the spinal cord. Half of the spinal cord is damaged. So when half of the spinal cord is damaged, yes, the dorsal column tracts are affected as well as the anterolateral tracts. Both the dorsal column tracts as well as the anterolateral tracts are affected. So due to the damage to the dorsal column tracts, there is a loss of advanced sensations on the same side of the lesion, but due to the damage to the anterolateral tracts, there will be loss of sensations on the opposite side of the lesion or on the opposite side of the body. This condition is called as Brown-Séquard syndrome. Okay, done. Now after this, in nervous system, what else is important? See, there is something called as phantom limb pain or phantom limb phenomena. Phantom limb pain or phantom limb phenomena, sir. What is the concept of the phantom limb? Imagine there is a person. Okay, there is a person who lost his upper limb gone, sir. Okay, now still even after the amputation, still he can feel the limb is not there, but still in his brain he can feel the sensations from the limb that is even absent. See, usually 80% of the amputees, amputation done, they will come to the clinic and they will tell to the doctor, sir, doctor, I can still feel the pain in my palm. I am having the pain sensation in my palm. You are looking at there, first of all, limb itself is not there. The entire limb itself is not there. But how can he feel the sensation? Because maybe this limb is not there, but this hand area, it is still present in the brain. Okay. So if that area is irritated, if that area is activated, then he can still feel the pain in the limb that is even not present. Actually, right now you are seeing me in your brain, you are hearing me in your brain. So even touch, pain, temperature, they are also felt in brain, sir, not here. If the touch and pain, they are not felt here, they are actually felt in your brain. So tell me, what is this phantom limb phenomena? Phantom limb phenomena means amputee can still feel the pain in the limb that is absent. This is explained by, that's the question. Phantom limb pain, it is explained by two theories are there. One is law of projection, and second theory is law of projection and cortical plasticity. Okay, law of projection and cortical plasticity. So these are the ones which explains the phantom limb pain. Phantom limb pain is explained by law of projection as well as cortical plasticity. Done. This is what they will ask you in your exam. What is the phantom limb pain? The pain can be still felt in the limb that is not even present. Why? Because the sensations are not felt here, thus every sensation is felt in the brain, still brain is present. So if that area, the hand area in your brain, if it is activated, you can still feel the pain. Okay, done. Now after this, one more important point regarding the sensations. We are still discussing about the sensations. No? See, thalamus, sir. Thalamus. First, all the sensations from your body, first go to thalamus. Which nucleus of the thalamus receive all the sensations? First write, all sensations goes to thalamus. All sensations go to thalamus. Okay, except one sensation, except olfaction. Except olfaction, all other sensations are going to thalamus. Now, which thalamic nucleus receive all the sensation? All sensations like touch, pain, temperature, pressure, this primitive sensation, and even all the advanced sensations. All the sensations are going to one nucleus, sir, that is ventroposterolateral nucleus. It's a ventroposterolateral nucleus. It is a sensory nucleus, sir. It's a sensory nucleus receiving all the sensations from the body. Where is this VPL nucleus located? It is located in the thalamus. So which nucleus of the thalamus receives the sensation? Ventroposterolateral nucleus. Okay. So now about vision, visual information. Visual information is going to which nucleus of the thalamus? That is lateral geniculate nucleus. It's a lateral geniculate nucleus receives the information about the vision, sir. Visual fibers. Vision information goes to lateral geniculate nucleus. Next, audition, hearing, sir. Hearing or audition. Hearing information will go to which nucleus of the thalamus? The answer is medial geniculate nucleus. Medial geniculate nucleus. Medial geniculate nucleus. It's a medial geniculate nucleus receives the information from the ears, and the information from the eye, visual information from the eye is going to the lateral geniculate nucleus. Okay. Then what about the taste? Taste information is going to ventroposteromedial nucleus. Very, very important. Ventroposteromedial nucleus. It's a ventroposteromedial nucleus receives the taste information. Okay. So all the sensations first go to thalamus. So thalamus, okay, is a sensory gateway. So thalamus is considered as a sensory gateway. Okay, sensory gateway to cortex. So first the sensation has to go to the thalamus, and from the thalamus the sensations later they will be relayed on to the cortex. They will be relayed to the cortex, to different parts of the cortex. Okay. Now see, as we have discussed about the taste, there is a newly discovered taste, called as umami taste. Okay, umami taste. See, this umami taste is a newly discovered taste. That umami taste is because of a chemical called as monosodium glutamate, MSG. Okay, that umami taste is due to monosodium glutamate. Now in one of the FMG exam they have asked this question, umami taste receptor. What is the receptor for umami taste on your tongue? That is MGLUR4. Okay, MGLUR1. So that is the monosodium glutamate receptor 4 and monosodium glutamate receptor 1. They are the receptor for umami taste. So umami taste is because of which chemical? Monosodium glutamate. Okay. Next, in the same way, they will ask you bitter taste. Bitter taste is the most sensitive taste. So our tongue is most sensitive to which taste? Bitter taste. Okay. Bitter taste is because of presence of which chemicals? Alkaloids like quinine, and some toxins, poisons like strychnine. Okay, so quinine, strychnine. So quinine and strychnine, these chemicals, they are alkaloids, sir. They are responsible for what taste? Bitter taste. So bitter taste means poison, poison, poison. Okay, so done. Next, sir, yeah. So thalamus is the sensory gateway. Thalamus is the sensory gateway. It's receiving all the sensations. All the sensations first come to thalamus. So yeah, thalamus is a major sensory gateway. But thalamus is also having some motor nucleus. That's the question which was asked. So what is the motor nucleus of the thalamus? The motor nucleus, okay, motor nucleus. What is the motor nucleus of the thalamus? The answer is ventrolateral, ventrolateral and ventro-anterior. Okay, so ventrolateral and ventro-anterior nucleus. These nucleus, ventrolateral nucleus and ventro-anterior nucleus, they are the motor nucleus of the thalamus. That's a question already asked in the exam. Okay, so regarding thalamus, you have to know. Next, one more point is, sir, which order neurons starts from thalamus? Which order neuron starts from thalamus, sir? See, actually, in the sensory pathway, there are 3 order neurons. I hope you have studied from anatomy. First order neurons, second order neurons, third order neurons. So, the third order neurons, thalamus, will give rise to third order neurons. Okay, third order neurons begin. So, the third order neurons will take the sensory information from thalamus to cortex. Third order neurons begin from thalamus, thalamus, thalamus. Very important. Third order neurons begins. Now, after this, what else I have to teach you? Some more special receptors are there, sir. What are they? What is their function? Let me tell you. Okay, see, listen carefully. Here, this is your muscle, sir. Okay, here this is your muscle. Okay, this is your skeletal muscle. Sir, skeletal muscles, they are having what? Myocytes. Myocytes. So, these myocytes, okay, let me show you. For example, here this is a one myocyte. Here there will be present. That myocyte, it will contract, you know, myocyte. Sir, myocytes, they are made up of, they are called as, or you can say, they are called as extra fusal fibers. Okay, they are extra fusal fibers. The myocytes, they are considered as extra fusal fibers. Okay. Now, within the muscle, within the center of the muscle, there is one more structure present. One more structure present, which is called as a muscle spindle. Okay, here this is a muscle spindle. This apparatus is called as muscle spindle. See, these muscle spindles, they are known as intrafusal fibers. Okay, intrafusal fibers. Okay, so intrafusal fibers. Now, what I am trying to say, in every skeletal muscle in your body, there are 2 types of fibers present: extrafusal fibers, intrafusal fibers. So, when a muscle is contracting, see, when a muscle is contracting, who will contract? Extrafusal fibers or intrafusal fibers? Both will contract. Both will contract. So, extrafusal fibers, they are having a motor innervation. No doubt the extrafusal fibers are having a motor innervation as well as the intrafusal fibers. Look at here. There is a motor innervation, this red color neuron. There is a motor neuron which is innervating the extrafusal fibers, and there is a motor neuron which is innervating the intrafusal fibers. What is the name of this motor neuron? So, it's the alpha motor neuron innervates the extrafusal fibers, and gamma motor neuron innervates intrafusal fibers, which is nothing but muscle spindle. Gamma motor neuron innervates muscle spindle or intrafusal fibers. Okay. So, alpha motor neuron helps in the contraction of extrafusal fibers, and gamma motor neurons helps in the contraction of intrafusal fibers. Okay, sir, done. Now, question is, sir, what is the function of this muscle spindle? What is it? First of all, sir, muscle spindle is a proprioceptor. Okay, muscle spindle, what is that? It's a proprioceptor. It's a proprioceptor, sir. Which means it's a receptor. First of all, it's a receptor. What it will detect? Sir, these muscle spindles, they are receptors. Yes, okay. What do they detect? They detect length changes. Okay, so length changes they will detect. So when your muscle is getting stretched or when your muscle is getting contracted, so length is changing, no? Your muscle length is changing, no? That length changes will be detected by a receptor called as a muscle spindle. See, when I am coming and touching like this, the touch is detected by a receptor, touch receptor. In the same way, when a muscle, if it is getting stretched or relaxed, okay, contracted, relaxed, contracts, relax. So, muscle length is changing, no? That length changes will also be detected by proprioceptor called as a muscle spindle. which is made up of intrafusal fibers. Okay, done. And not only that, look at here. Here, what is this? Sir, muscles, they are having the tendons, you know, muscles are attached with the tendons. So, here in the tendon, there is one more receptor present called as a Golgi tendon organ. Okay, it is also one of the proprioceptor. Okay, it is one of the proprioceptors. It is also a proprioceptor. What it will detect? Sir, if it is a receptor, what it will detect? It will detect tension changes, not length changes, tension changes. Okay, it will detect what? Tension changes. So, the Golgi tendon organs, they will detect the tension changes on the muscles. So, whether the tension on the tendons increases or tension on the tendons decreases. Imagine I am trying to hold 20 kgs of weight like this. I am weighing 20 kgs dumbbell, sir. So, what happens? Muscles are contracting. So, there will be more tension pull. There is more tension on the tendons. So, the tension on the tendons is detected by Golgi tendon organ. The muscle length changes are detected by muscle spindle. Okay, muscle spindle. So, now these are the points which I want you to know regarding the structure of the muscle, which includes extrafusal fibers, intrafusal fibers. Extrafusal fibers innervated by the alpha motor neurons, intrafusal fibers are innervated by the gamma motor neurons. Okay, muscle spindles detect the length changes and Golgi tendon organs detect the tension changes. Okay, done. Next, okay, see guys, here I am talking about, let's say, muscle spindle. What it should do? It is detecting the length changes, detects length changes. Okay, length changes. So, now this information, it is detecting, array sir, muscle length is changing. So, this information it have to give to the, with the help of sensory neurons, it have to give this information to where? It have to give the information to central nervous system. Array muscle length is changing. Okay. Next, in the same way, Golgi tendon organs, let's say Golgi tendon organs, what do they detect? They detect tension changes. So, with the help of other sensory neurons, with the help of a different sensory neuron, it have to give this information to the central nervous system. So, now tell me, muscle spindles give this information. Muscle spindles, with the help of which neurons will give this information to the central nervous system? With the help of a neuron called as primary 1A fiber / secondary fiber. With the help of fibers called as primary fiber, 1A fiber or secondary fiber, the muscle spindles gives this information to central nervous system. In the same way, the Golgi tendon organs gives this information, tension changes, to the central nervous system with the help of 1B fibers. Okay, with the help of which fibers? 1B fibers. Okay, now you understand? So, they will ask you, muscle spindle, okay, it is having sensory supply or not? Yes, muscle spindles, they are giving this sensory information with the help of primary 1A fibers and secondary fibers. Golgi tendon organs, they are innervated by which type of sensory neurons? 1B fibers. But tell me, what is the motor innervation? What is the motor innervation to muscle spindle? The motor innervation to muscle spindle is a different neuron, sir, that is gamma motor neuron. So, yes, your muscle spindles, they are having motor innervation, true, as well as sensory innervation. Motor as well as sensory innervation, sir. Both are there. Okay, done. Next, after this, what else you should know in the nervous system? Let me tell you important centers and their function. For example, in your hypothalamus, there is a nucleus called as suprachiasmatic nucleus. See, what is the function of the suprachiasmatic nucleus? The suprachiasmatic nucleus, it is considered as a biological clock. Okay, it's considered as what? It's considered as a biological clock. What it will do? So, the suprachiasmatic nucleus, it controls circadian rhythm. It controls what? Circadian rhythm. Okay, simple circadian rhythm means the sleep-wake cycles. Same events happens again and again in our body every 24 hours. Okay, so suprachiasmatic nucleus is a biological clock. It controls your sleep-wake cycles or circadian rhythm. Okay, in your hypothalamus, there is one more nucleus present. What is that nucleus called as, sir? Lateral nucleus of hypothalamus. Lateral hypothalamic nucleus. Lateral hypothalamic nucleus. It is your hunger center. It is your hunger center. It is the one responsible for your hunger. Okay. Now here itself I want you to know which hormones increases the hunger. Which hormone increases the hunger? Hormone called as ghrelin. Ghrelin, a hormone called as ghrelin. So when this ghrelin is produced, sir, so ghrelin, when it is produced, ghrelin is produced during fasting. Okay, fasting. Tell me, during fasting what is produced? Ghrelin. What ghrelin is going to do? It's going to increase your hunger. Okay, it's going to increase your hunger. So which center is responsible for that hunger sensation? It's a lateral hypothalamic nucleus. It's a lateral hypothalamic nucleus which is your hunger center. Now, then what is the satiety center, sir? Satiety center. What is your satiety center? Satiety center means feeling of fullness. Feeling of fullness means after eating a plate full of biryani, sir, you will feel I'm done, I can't eat further. Okay. So what is your satiety center? The satiety center, sorry, here I should write, the satiety center is your ventromedial nucleus. Ventromedial nucleus. So this ventromedial nucleus of the hypothalamus, is considered as the satiety center. So which hormones increases the satiety? Which hormones are going to make you feel full? Satiety, sir. Leptin. Leptin is going to decrease your hunger. Decreases hunger. From where this leptin is produced? Sir, leptin, it is produced from adipocytes. So leptin produced from adipocytes. Okay, produced from, sir. Leptin produced from adipocytes. Okay, leptin decreases your hunger, ghrelin increases your hunger. Next nucleus, let's say fourth nucleus, sir. Okay, supraoptic nucleus. Supraoptic nucleus of the hypothalamus produces antidiuretic hormone, and paraventricular nucleus of the hypothalamus produces oxytocin. Oxytocin. Done. Next, after this, now two more nucleus I am telling you. You already know this, but let me tell you. 6 and 7. What are they, sir? That is anterior hypothalamic nucleus, anterior hypothalamic nucleus, HN for hypothalamic nucleus, anterior hypothalamic nucleus, and posterior hypothalamic nucleus. Anterior hypothalamic nucleus and posterior hypothalamic nucleus. What they will do? So the anterior hypothalamic nucleus, A for AC, sir, it cools down your body, it decreases the body temperature. It decreases body temperature. And posterior hypothalamic nucleus, it increases the body temperature, sir. Increases body temperature. Okay, so A for AC, anterior hypothalamic nucleus, cools down your body, decreases your body temperature. So now tell me, how your body temperature can be decreased, how you can decrease the body temperature? Via two mechanisms. One is sweating and vasodilation. Vasodilation. Vasodilation means more blood will come to the skin, more heat loss. And how can you increase the body temperature? How can you increase the body temperature? That is shivering. Okay, shivering and vasoconstriction. Okay, shivering and vasoconstriction. Understanding? So these are the hypothalamic nucleus. Different hypothalamic nucleus have a different functions, sir. So anterior hypothalamic nucleus decreases your body temperature, and the posterior hypothalamic nucleus increases your body temperature. So can I say something like this? Sir, it's the hypothalamus which can increase your body temperature, which can decrease your body temperature. So that's why hypothalamus is considered as a thermoregulatory center. Hypothalamus is considered as what? Thermoregulatory center. Okay, it's a thermoregulatory center. So your hypothalamus is a thermoregulatory center. Right? Next, after this, I want to discuss some important centers which will keep you awake. Okay, wakefulness centers. Wakefulness centers which will keep you awake. Right now you are all awake, right? You are listening to the class. So what are the wakefulness centers, and what are the centers in your brain which will take you to the sleep? So wakefulness centers, there are 4 wakefulness centers. Okay, there are 4 wakefulness centers, sir. So what are the 4 wakefulness centers? The 4 wakefulness centers include, one is lateral hypothalamic nucleus, Next one, posterior hypothalamic nucleus and reticular formation in your brainstem, reticular formation, especially the locus ceruleus, the nucleus called as the locus ceruleus of the reticular formation, and raphe nucleus. Raphe nucleus. So these four nucleus is a lateral hypothalamic nucleus. I have told you lateral hypothalamic nucleus is a hunger center. Posterior hypothalamic nucleus is going to warm your body. So same areas, sir, same areas. So lateral hypothalamic nucleus, posterior hypothalamic nucleus, reticular formation, and raphe nucleus, they are all going to keep you awake. Right now your cortex is active because of these four regions. Lateral hypothalamic nucleus, it produces a neurotransmitter called as orexins. Okay, orexins. And posterior hypothalamic nucleus produces histamine. Reticular formation produces norepinephrine. And raphe nucleus produces serotonin. So these are neurotransmitters. These four neurotransmitters like orexin, histamine, norepinephrine and serotonin, they are all responsible to keep you awake. They are all the wakefulness neurotransmitters. These are all the wakefulness neurotransmitters. They will keep you awake. Okay. Then what are the sleeping centers, sir? Which center will take you into the sleep? That is called as ventrolateral preoptic nucleus. Again I am repeating, ventrolateral preoptic nucleus. Ventrolateral preoptic nucleus will take you into the sleep center. It's the sleeping center. It is the one responsible for the sleep. How many types of sleep are there? REM sleep is there and NREM sleep is there. REM and non-REM. Okay, REM and non-REM. So what is the neurotransmitter of REM? Acetylcholine is the neurotransmitter of REM. And in NREM it's the GABA. Okay, GABA. So these are the sleeping neurotransmitters. Acetylcholine and GABA. Acetylcholine and GABA. They are the sleeping neurotransmitters. They are the neurotransmitters responsible for the sleep. And what are the wakefulness neurotransmitters? Orexins, histamine, epinephrine, serotonin. One important point about the orexin is, see, who increases your hunger? See, who increases your hunger? I have told you ghrelin increases the hunger, sir. Okay, but not only ghrelin, also orexins. Orexins also increases your hunger. Orexins also increases your hunger, sir. Okay, done. Who produces ghrelin? Stomach. Who produces orexins? Lateral hypothalamic nucleus. So with this, what we have completed is different areas which are controlling the wakefulness and sleep. Now few more areas I will let you know. See, important miscellaneous areas. See, what is the vomiting center? What is vomiting center? Where is it located? Vomiting center is called as a CTZ. Chemoreceptor trigger zone is called as a vomiting center. It is the one responsible for vomiting. Where is it located? It is located in an area called as area postrema. Okay, area postrema. Second is called as reward center, sir. Reward center. So what is the reward center? Reward center is your ventral, tegmental area and median forebrain bundle. So ventral tegmental area and the medial forebrain bundle, these areas are considered as the reward center. Okay, the feeling of reward, something like, see, after completing the entire revision you will have, okay, I have done my revision. Okay, so reward center is the ventral tegmental area and medial forebrain bundle. Next, region number 3 is your addiction center. So what is your addiction center? The one responsible for the addiction center is the nucleus accumbens. Okay, nucleus accumbens is the addiction center. Okay, so these are the important areas which I want you to know: vomiting center, reward center, addiction center. Next, the last topic is basal ganglia, sir. Okay, basal ganglia. So in basal ganglia, what I want you to know is, sir, basal ganglia is made up of multiple structures. What are they? Caudate nucleus, putamen, globus pallidus. Okay, so caudate nucleus, putamen, globus pallidus. Fourth nucleus is substantia nigra and subthalamic nucleus. Subthalamic nucleus. See, caudate and putamen together called as striatum. Okay. Next, what I want you to know is, guys, listen. These basal ganglia, what is the main function of basal ganglia? Main function of the basal ganglia is to inhibit involuntary movements. It wants to inhibit involuntary movements. Okay, so the basal ganglia is not a one single structure. It's not one single structure. Basal ganglia includes multiple nucleus. Okay, multiple nucleus. These are the 5 nucleus. Now, when these, okay, let me write first here. Basal ganglia function is what? Inhibits involuntary movements. When the basal ganglia is damaged, when the basal ganglia structures are damaged, unnecessary involuntary movements will come. So, the question which was asked in the exam, caudate damage to caudate is going to cause an involuntary movement called as damage to caudate nucleus, or they will use the word damage to striatum, will cause what kind of involuntary movement? Called as chorea. Okay, chorea, sir, is going to cause chorea. Damage to globus pallidus, if the globus pallidus, if it is damaged, that's going to cause an involuntary movement called as athetosis. Okay, so some medicine books mention that globus pallidus damages can lead to chorea, sir. Possible. Okay, globus pallidus damages can also lead to chorea. Okay, next subthalamic nucleus. When the subthalamic nucleus is damaged, that is going to cause a type of involuntary movement called as hemibalismus. Hemibalismus. Okay, so now they will ask you, sir, chorea is an involuntary movement, no doubt in that. What kind of movement is chorea? Chorea is what kind of movement, sir? Chorea is sudden. It's not actually sudden. I should say it is flicking movement, sir. Flicking movements. Okay, so flicking movements in the upper limbs. So how the chorea is going to look like, watch it in the YouTube. Okay, how chorea looks like. Athetosis, what kind of movement is athetosis? See, they will use these keywords. Athetosis is a writhing movement. Okay, dance like or writhing movements. Okay, and hemibalismus. What kind of movement is a hemibalismus, sir? Hemibalismus is sudden or violent flinging. Not flicking, flinging. Okay, like a bird, flinging. Sudden flinging or railing. Okay, movement. Okay, these are violent movements. Sudden flinging or railing movements of the limbs are called as hemibalismus. Okay, hemibalismus. Now, what I have told you? Guys, I have told you different nucleus of the hypothalamus. Different nucleus of the basal ganglia. So basal ganglia, it contains different nucleus. Damage to different nucleus is going to cause a different types of involuntary movements. So they will ask, chorea is due to damage to caudate. Athetosis is due to damage to globus pallidus. Such questions will come in your exam. Now, what I want to say. See, we have done all the systems. See, EEG topic, I haven't discussed the EEG topic because anyway you have done your EEG topic in your psychiatry as well as medicine also EEG topic will come. Okay, I am not going to the topic of EEG because anyway you have done your EEG topic in other subjects also. Okay, EEG contains alpha, beta, gamma waves, delta waves, in which condition. Okay, let me, why to unnecessarily skip it, just small topic only, EEG. See, EEG, there are different types of EEG waves, alpha, beta, gamma, delta, theta waves. Okay. Alpha, beta, gamma, theta and delta waves. Okay. Now tell me, EEG waves, alpha waves are seen in relaxed mind, sir. Relaxed mind. Okay. Or you can say wandering mind. Wandering thoughts. means you are absolutely relaxed, come and going, like some thoughts comes and goes, some thought coming and going. It's a relaxed mind. So when a person is in relaxed state, if you measure the electrical activity of the brain, which waves will be recorded? Alpha waves will be recorded. Next, beta waves. Sir, beta waves, okay, beta waves, they are seen when, sir? Beta waves, they are seen with busy mind, okay. But one more thing which I have forgot is alpha wave frequency. What is the frequency of alpha waves? 8 to 12 hertz. 8 to 12 hertz is the frequency of alpha. What is the frequency of a beta waves, sir? The frequency of beta waves is 13 to 30 hertz. Okay, see, frequency is increasing. Frequency is increasing. Okay. Next, when you will have gamma waves, gamma waves are seen during intense mental activity. When you are having intense mental activity, sir, intense mental activity, like problem solving, doing some mathematical, problems, doing some hypothesis, or gamma learning new things, or absolute attention. Okay, in all these conditions you will have gamma waves. What is the frequency of gamma waves? More than 60 hertz. Gamma waves frequency is more than 60 hertz. Next, theta waves, sir. What about the theta waves? Theta waves are seen during light sleep. Okay, light sleep or drowsiness. Okay, theta waves are seen during light sleep. Now, during light sleep, do you know what happens? During your light sleep, the short-term memory will be converted into long-term memory. The short-term memory will be converted into long-term memory in your hippocampus. Okay, hippocampus. So, in your hippocampus, the short-term memory will be converted into long-term memory during light sleep. And during light sleep, which EEG waves will come? Theta waves. What is the frequency of theta waves, sir? The frequency of theta waves is 4 to 7 hertz. Okay, 4 to 7 hertz, because from 8 it is alpha. Next, and delta waves. Delta waves are seen during deep sleep. Deep sleep, sir. Deep sleep. Delta waves are seen during deep sleep. Delta, D for deep. And not only deep sleep, they are also seen during anesthesia, sir. Surgical anesthesia. Okay, or in our infants also. So in infants also, see, in infants, surgical anesthesia, and during deep sleep, in these conditions, what kind of EEG waves will be recorded? Delta waves will be recorded. Okay, so these are the different EEG waves seen with different conditions. Okay, next here, the same EEG topic I am discussing. Sir, sleep is there, no? Sleep. Sir, sleep is divided into two phases. What are the two phases of the sleep? NREM sleep, and REM sleep, NREM, REM sleep. So we will spend 80% of our time, we will spend in NREM sleep, sir. Okay, and NREM, it has phases. What are the different phases of NREM? That is NREM stage 1, NREM stage 1, NREM stage 2, NREM stage 3, and NREM stage 4. These are the stages of NREM sleep. Okay, this NREM is further classified into 4 stages. See, NREM stage 1, if you measure the electrical activity of your brain in NREM stage 1, do you know which waves will be coming? NREM stage 1 is considered as a light sleep, sir. So, theta waves will be seen. Okay, they will ask you in NREM stage 1, which EEG waves will be recorded? Theta waves will be recorded. NREM stage 2, important MCQ, it's the longest sleep. Okay, we spend 55% of our sleep. 55% of our sleep time we spend in NREM stage 2. Okay, NREM stage 2. Okay, so in NREM stage 2, which frequency waves are coming? 8 to 12 hertz. They are alpha-like waves. They are not alpha waves, they are alpha-like waves are coming. Apart from them, you will also see during NREM stage 2, you will also see sleep spindles on the EEG, sleep spindles. Also K complexes. So sleep spindles and K complexes are seen in NREM stage 2. Very important. Next, stage 3 and 4. Stage 3 and 4, they are considered as deep sleep, sir. Deep sleep. So which waves will be coming in deep sleep? Delta waves. Delta waves will be coming, sir. Frequency 1 to 3 hertz. Okay, so don't forget. Done. Next, REM sleep, sir. REM sleep is also having one more name. REM sleep is also called as a paradoxical sleep. Paradoxical sleep. Okay, paradoxical sleep. REM sleep is also called as a paradoxical sleep. See, in REM sleep, if you measure the electrical activity of the brain, which waves are coming? Sir, the frequency that is coming is 13 to 30 hertz. Okay, 13 to 30 hertz frequency is coming. So these are beta-like waves. They are not beta waves. They are beta-like waves are coming. Okay, you can say beta-like waves are coming. Okay, so that is what is seen in REM. And the electrical activity, if you measure the electrical activity, how these REM sleep waves are going to look like? No, they are going to show sawtooth pattern. The waves looks like a sawtooth, sir. Sawtooth pattern. Apart from sawtooth pattern, what else will be seen? Sir, here the patient is also going to have, or the person is also going to have some spikes called as a PGO spikes on EEG. PGO spikes. So PGO spikes, if they ask you, PGO spikes, pontogeniculo-occipital spikes. PGO spikes are seen in which phase of the sleep? REM sleep. During REM sleep, the waves, that REM sleep, the EEG waves, how they appear? Look, how they appear like? They appear like a sawtooth. Okay, REM sleep is also called as a paradoxical sleep, and maximum time we spend in which sleep? NREM stage 2. NREM stage 2. Okay, done. See here, let me tell you one more difference between NREM and REM, sir. What is the one more difference? One more difference is in NREM you will see some abnormalities like somnambulism. Okay, somnambulism, that is especially seen with NREM stage 3 and 4. NREM stage 3 and 4, you will see somnambulism. What exactly is somnambulism, guys? Sleepwalking. Somnambulism is sleep walking. Okay, next you will see bruxism. Bruxism is mainly seen in NREM stage 2, sir. NREM stage 2. Bruxism mainly seen in NREM stage 2. Okay, apart from that, you will also see nocturnal enuresis. Nocturnal enuresis, that is bedwetting, sir. Bedwetting, it's an abnormality during the sleep, during which sleep? NREM, during NREM, sir. And one more abnormality that happens during NREM is night terrors. Night terrors. What are night terrors? Night terrors are the bad dreams that can't be remembered. So dreams occurs during NREM, true. Dreams occurs during NREM, true, but you can't remember them. So all these are not only dreams. Somnambulism, bruxism, nocturnal enuresis, night terrors, they are not remembered. NREM for not remembered. Any event which happens in NREM, all these events are not remembered, sir. Not remembered. Okay, you can't remember them. Dreams are also not remembered. In NREM, dreams are not remembered. Okay, next, during REM, which abnormalities will be seen? During REM, you will be having nightmares. Nightmares, sir. What are nightmares? Nightmares are bad dreams which can be remembered. So the bad dreams that can be remembered, are called as a nightmares. The bad dreams that cannot be remembered are called as a night terrors. Night terrors seen in NREM, nightmares are seen in REM. See, in one of the recent exam, this question has been asked, what is the treatment of choice for nocturnal enuresis? If a person is having nocturnal enuresis, the treatment of choice is bed alarms. Okay, if they ask about the drug, then you can go with desmopressin. Okay, so with this we have completed the whole physiology, sir. The whole physiology, the whole 6 systems I have completed. Okay, so it takes almost like, I thought it will be completed in 4.5 hours. It takes almost 6 hours of time. But anyway, before going to the exam, see, let me tell you one thing. Okay, it doesn't matter how your preparation is. Whatever has happened, sir. Always have a positive mindset. That one positive mindset is going to help you to cross the river, sir. Okay, for the success, what you need to have is a positive mindset. Even though you have prepared everything, you haven't prepared anything. Every day in the morning, the first thing that should come out of your mouth, I am going to clear the exam. Before going to the sleep, the first thing that comes is I am going to clear the exam. Okay, morning and night. Be confident. Don't underestimate yourself. Don't even think about the result, sir. Thinking about the exam day, thinking about the result is going to unnecessarily make you panic. Forget about the result. What you have to do is only you have to do the preparation. What is only in your hands? What is in your hands is the preparation, sir. do it perfectly, do your preparation perfectly, prioritize your subjects, make sure you are good at 200 marks. For 200 marks you are good, sir. So even though if something goes wrong, still you are having that 50 marks is there. Okay. So prioritize your subjects, mainly concentrate on physiology, pathology, pharmacology, anatomy, biochemistry and forensics. Okay, so first 2 year subjects, anatomy, physiology, biochemistry, pathology, pharmacology, microbiology and forensic. So these are the subjects which will give you marks easily. Okay, the high yielding subjects, easy scoring subjects, first and second year subjects. See, yeah, medicine can give you almost 30 marks, but it is hard to get the marks. So prioritize your subjects. Okay, so you have to have high priority for your preclinicals which are going to bring you easy marks. And in the big subjects, I am asking you, okay, I am highly recommending you to go through PSM and OBGYN repeatedly. Do as many repetitions as possible, because it's a PSM and OBGYN, they will decide whether you are going to clear the exam or not. So do as many revisions as possible with the OBGYN and PSM, followed by surgery, sir, followed by surgery. So prioritize. Yes, of course, all subjects are important, but not equally. Some are high important and some are less important. So prioritize your subjects, prioritize. Okay, see, I might be good in medicine, you might be good in different thing. Okay, so priority. Okay, and check whether they are like, you just select 12 subjects, for example, let's say. Are the 12 subjects covering 200 marks or not? So do the priority and do those subjects, revise as many times as possible. Do the revision of that particular subject as many times as possible. Okay, that's what I'm saying. So all the best, guys. Okay, don't panic. At this point of time, every student is having that one problem, like, I couldn't able to complete subject, I couldn't able to do as many revisions as possible. Every student will have that problem. So don't worry about the result. When you are thinking about the result, you will have that problem. Forget about the result. What is there in your hand is only preparation. So do it perfectly. Okay guys, all the best for your exam. See you. Thank you.